أقعد فترة وتتعرف عليه.
بس قصنا من أول. Hello everybody. This is the third day and last day of our conference by Jordanian Society of Hematology, and we had an excellent presentations by excellent presenters, and we will start this day by our prestigious speaker, Professor Emanuele Valeriani from Italy. He will talk about important subject about thrombosis in cancer patients. And it's my pleasure to introduce my colleague, Dr. Ayman Abu Kamar, to introduce Prof. Emanuele Valeriani. Please, Dr. Ayman.
Thank you, Dr. Hussam. Good afternoon, everyone. It's a great pleasure to moderate this session with you, my colleague, Dr. Hussam, and to present our respected speaker, Dr. Emanuele Valeriani. Professor Emanuele, he is an internal medicine professor in the Department of Public Health and Infection at Umberto University Hospital. Professor Emanuele, he is a member of the Italian Society of Internal Medicine, International Society of Thrombosis and Hemostasis, and also he is a member and National Coordination Officer of the Italian Society of Thrombosis and Hemostasis. Professor Emanuele, he has many publications about thrombosis and hemostasis, and mainly about the thrombosis in the cancer patient. And Professor Emanuele, today he will talk about the cancer-associated thrombosis. Dr. Emanuele, time is yours.
Okay. Hi there. Thank you for the kind presentation, and thank you for inviting me as a speaker in this great congress. Now we will talk about a very interesting topic that during the last years was the center of the research on the topic of venous thromboembolism. So this is the agenda of my presentation. As we can see, I identify some questions that may come in mind during daily clinical activity, and that I will try to clarify during this further time. First, we have to keep in mind that most evidence regard venous thromboembolism, while quite less data were available for arterial thrombosis. Patients with cancer have a higher risk of both arterial and venous thromboembolism than general population. These are the result of a recent nationwide study, including more than 8 million of people, of which more than 150,000 had cancer. Despite limited by the retrospective nature of the study, we can see that the risk of arterial thrombosis was about 7-fold higher, and that of venous thromboembolism about 15-fold higher in patients with cancer than general population. Let's start with the first question. What type of thrombosis should I expect in patients with cancer? On the side of venous thromboembolism, I can see patients with lower extremity deep vein thrombosis and or pulmonary embolism, that is usual site thrombosis. Conversely, upper extremity deep vein thrombosis, cerebral vein thrombosis, and splenic vein thrombosis fall within the group of atypical site thrombosis. However, all venous thromboembolism may be symptomatic, as well as incidentally detected during the restaging radiological imaging. Acute myocardial infarction, acute ischemic stroke, or transient ischemic attack and acute limb ischemia are on the side of arterial thrombosis. This type of thrombosis are rarely incidentally detected, and patients quite always presented specific symptoms like chest pain, sign of acute neurological deficit, and or acute limb pain. Now the question is, had all patients with cancer the same risk of a venous thromboembolism? Obviously not. And we can identify some specific features that can help us identify those patients at higher risk. First of all, we have tumor-associated risk factors, such as the site of cancer. As we can see in this two-forest plot, some cancers, such as breast, skin, male genital, endocrine tumors, share the lowest risk of venous thromboembolism, with relative risk that fall between 2-fold higher to 6-fold higher. Conversely, lung, brain, pancreatic cancer share the high risk of venous thromboembolism, with relative risk up to 15-fold higher than general population. Finally, hematological cancer, mainly multiple myeloma and some type of lymphoma, show an intermediate risk of venous thromboembolism. However, it should be acknowledged that from a public health perspective, a high proportion of VTE burden is attributable to highly prevalent cancer, like as breast, colorectal, and prostate cancer, despite a lower level relative risk for venous thromboembolism. As for venous event, the site of cancer appears to be associated with risk of arterial thrombosis development. As we can see in this picture, endocrine tumors at the lower risk, gastrointestinal respiratory cancer the higher risk, and once again, hematological cancer an intermediate risk of arterial thrombosis. Let's focus on hematological cancer and incidence of thrombosis. Here we can see that some type of cancer was responsible for higher incidence of venous thromboembolism at both acute myocardial infarction and ischemic stroke. Also, the stage of cancer has been associated with the risk of thrombosis. These are the result of a recent prospective study, including patients from Denmark and Norway. Patients with a localized cancer had the lowest incidence of venous thromboembolism, while patients with disseminated cancer the highest incidence. Despite data scanty, the incidence of venous thromboembolism appears to be associated also with the histological type of cancer. Indeed, as we can see, for example, in this cohort of patients with non-small cells lung cancer, patients with adenocarcinoma had the highest incidence, while those with squamous cancer, the lowest incidence of venous thromboembolism. The last tumor feature that appears to be associated with venous thromboembolism is the time since cancer diagnosis. As we can see in this table, the adjusted odds ratio for event development was very high within the first 3 months from diagnosis and significantly dropped over time, reaching values of roughly 3 after 5 to 10 years since the diagnosis. Also, anti-cancer treatments have an high impact of thrombosis development. Here we can see the incidences of venous thromboembolism sorted by the type of anti-cancer drug. immunotherapy and protein kinase inhibitors show the higher incidence, while anti-angiogenetic and other targeted therapy share intermediate values of incidences. This is a very interesting classification of what we have to know about the effect of anti-cancer therapy on thrombosis. Some kind of drug, as platinum-based or immunomodulatory agents, were associated with just a higher risk of venous thromboembolism. Other kind of drugs, such as VEGF-targeted molecules, were associated with an increased risk of arterial thrombosis. Finally, BCR-ABL RTK inhibitors were associated with an increased risk of both venous and arterial events. Finally, should be acknowledged that information are missing for some kind of anti-cancer drugs, and further study will be needed to increase the knowledge on this topic. Also, erythropoietin-stimulating agents increase the risk of venous thromboembolism by twofold, with an effect that appears to be consistent for different types of baseline cancer. Patients with cancer had also the need to use some central devices or venous catheter that once again may increase the risk of venous thromboembolism. The presence of an indwelling catheter, mainly in the upper arms, represent a frequent and transient additional thrombotic risk factor in cancer patients because of local vessel wall mechanical damage and blood coagulation activation from infused medication. Surgery is another relevant thrombotic risk factor for venous events development, and we will try to discuss the topic later, showing the recommendation of principal international guidelines. And finally, there are many patient-associated risk factors that may increase the thrombotic burden. As we can see in this table, across the others have advanced age, female sex, Black ethnicity, and the presence of other comorbidities such as anemia, infection, renal, and lung diseases appear to be the most relevant risk factors. In the last years, several biomarkers have been associated with cancer-associated thrombosis. For example, high leukocyte and platelet counts and low hemoglobin levels before chemotherapy have been strongly associated with the risk of subsequent venous thromboembolism. These parameters derived from routinely conducted blood count studies in patients with cancer and are easily available in clinical practice and can be considered cost-effective prognostic and predictive biomarkers. Some word about the D-dimer. That is a small protein fragment derived by fibrin degradation, and its value are associated with an increased risk of venous thromboembolism. However, the dimer is frequently elevated in patients with cancer, as we know, and vary broadly between laboratories. And there is a lack of consensus regarding the appropriate cutoff value to be considered as a high risk. Finally, further studies are focused on other molecules, including soluble P-selectin, C-reactive protein, and tissue factor-bearing microparticles, but their potential role in VTE prediction has to be well studied. All of us know about the rule to exclude a venous event in general population. So many studies have shown that it is safe to withhold anticoagulant treatment without further diagnostic testing in patients with a low score on the Wells rule, combined with a negative D-dimer result. The validity of this approach, however, has been questioned in various subgroups of patients, such as those with active cancer. The reason for these concerns are twofold. Firstly, the pretest probability of deep vein thrombosis in patients with cancer is higher compared with patients without cancer, reducing the negative predictive values of the Wells rule and D-dimer testing, and increasing the failure rate of the rule-out approach. Secondly, most patients with active cancer have an increased D-dimer values even in the absence of thrombosis, thereby reducing the efficiencies of the rule-out approach. And finally, as we can see in this table that report the results of an individual patient data meta-analysis on 13 studies, the combination of a low score on the Wells rule and a negative D-dimer in patients with cancer occurred in only 9% of all patients. Moreover, in these low-risk patients, deep vein thrombosis was still present in at least 2% of patients. Risk assessment model have been developed to identify a subset of cancer patients in whom the risk of VTE development is high enough to justify thromboprophylaxis. The best validated tool is a score proposed by Corana and colleagues, which aims to identify cancer patients receiving chemotherapy at high risk of VTE based on tumor type, hemoglobin concentration or use of erythropoietin stimulating agents, white blood cell count, platelet count, and body mass index. To improve the performance of the Corana scores, others have proposed modification by adding several biomarkers or type of chemotherapy or by replacing body mass index with performance status. Although the performance of this course in the initial derivation studies was promising, subsequent external validation studies are either lacking or have reported conflicting results. These are the results of a multinational prospective cohort study that provide a direct comparison of the performance of 4 risk assessment model: the Corana score, the Vienna CAT score, the PROTECT score, and finally the CONCO score. All these scores, as we can see, had a poor discriminatory performance, although the Vienna CATs and PROTECT scores were able to discriminate between high and low risk patients. Indeed, the 6-month VTE incidence among patients classified as high risk by these two models was approximately 2-fold higher than in low-risk patients. The predictive performance of these two scores appear to be mainly driven by the predictive value of the dimer in the Vienna CAT score and the type of chemotherapy in the PROTECT score. However, the use of these two latter models was more complex than Corana score, and the risk of venous thromboembolism in patients classified as low risk was still not negligible. As previously reported, patients with multiple myeloma have an increased risk of venous thromboembolism than general population that is even greater in patients receiving immunomodulatory or other thrombogenic therapy. Here we can find the impaired VTE score that has been developed to quantify the risk of venous thromboembolism in patients with multiple myeloma starting chemotherapy. Once again, tumor-associated, treatment-associated, and patient-associated risk factors were included in this model. On the left side of the screen, the 6-month incidence of venous thromboembolism are sorted by the score classification that include patients in 3 risk subgroups. Another easier to use model for venous thromboembolism risk prediction in patients with multiple myeloma receiving immunomodulatory drugs is the SAVED score. Using 2 nationwide databases with more than 3,000 of patients, this study externally validated a simple model that seemed to identify patients with a 2-fold increased risk of venous thromboembolism. Finally, on the left, we can see a risk model in patients with lymphoma receiving chemotherapy. In this score, that we can see on the left side of the screen, patients were classified in three kind of risk: low-risk patient, intermediate-risk patient, and high-risk patient. However, the reproducibility of these results in other setting is unknown and should be further investigated in external validation course. Conversely, on the right side of the screen, we can see the result of another study that identified three variables that appear to be strongly associated with the venous thromboembolism development. As we can see, patients with cerebral localization, a tumor bulk more than 10 centimeters, and a reduced performance status were associated with higher incidence of venous thromboembolism than general population. However, should be acknowledged that there are currently no validated risk tool to predict arterial thrombosis in patients with cancer, and this remains a clinical gap of knowledge. So now let's start the chapter of cancer-associated thrombosis prophylaxis with the question: should hospitalized medical patients with cancer receive anticoagulation for prophylaxis of venous thromboembolism? Despite the no high incidence of venous thromboembolism in the cancer population, thromboprophylaxis in hospitalized patients with cancer represents a major gap of knowledge. Data from the US DVT registry found that hospitalized patients with cancer are actually less likely to receive venous thromboembolism prophylaxis than patients with cancer due to the relative contraindication to pharmacological thromboprophylaxis, such as thrombocytopenia, active or high risk of bleeding. On the other hand, there are limited data to support the use of antithrombotic prophylaxis and regarding the optimal regimen in hospitalized medical patients with cancer. Recently, a small phase 2 trial showed that a weight-adjusted low molecular weight thromboprophylaxis approach appears to be feasible and safe as a fixed-dose approach. Multiple scoring systems have been proposed to improve venous thromboembolism prevention, and in this particular setting, such as hospitalized medical patients, the Padua prediction score is broadly used. It considers several comorbidities, as we can see, and assigns 3 points to active cancer. However, even though the scoring system includes cancer diagnosis as a variable, it has been tested primarily in medical patients that are hospitalized and have not been validated in any specific cancer populations. In a similar manner, the improved score is used to predict venous thromboembolism development in hospitalized medical patients. Active cancer had a high predictive value once again, but this score has been tested primarily in medically hospitalized patients and have not been validated in any specific cancer population. Finally, should be reported that the ability of the Corona score to predict venous thromboembolism in hospitalized medical patients was evaluated in a recent retrospective study. This table showed that patients with a high score appear to have a twofold higher risk of venous thromboembolism development than patients classified as having a low risk. Here we can address the question of about the duration of prophylaxis that is uncertain as well. Indeed, patients with active cancer remain at higher risk of venous thromboembolism also after hospital discharge, but results from the EXCLAIM study did not show a clear benefit in VTE reduction when antithrombotic prophylaxis with low molecular weight heparin was extended up to 28 days compared to the standard 10 days, while a statistically significant increase in bleeding risk was reported. These are the results of the Magellan trial that are similar for the EXCLAIM trial. Indeed, extended medical prophylaxis with rivaroxaban appears not to significantly reduce the risk of venous thromboembolism in hospitalized medical patients with cancer, but was responsible for an increased bleeding risk. Knowing all of this, now we will talk about the three most recent guideline recommendations on the management of medical prophylaxis in hospitalized medical patients. First, the ASCO guideline stated that patients with active cancer and no bleeding or other contraindication should receive medical prophylaxis in the case of acute medical illness or reduced mobility. Otherwise, they may receive medical prophylaxis whether no other risk factors were present. However, medical prophylaxis should not be offered for minor procedures, chemotherapy infusion, or for stem cell bone marrow transplantation. This guideline suggests medical over mechanical prophylaxis in all hospitalized medical patients with low molecular weight heparin over unfractionated heparin. Furthermore, they suggest discontinuing prophylaxis at hospital discharge rather than continuing beyond the discharge date. And finally, the ESMO guideline that recommend medical prophylaxis with a low molecular weight heparin, unfractionated heparin, or fondaparinux for all patients confined to bed and obviously that are hospitalized. As we know, surgery is a well-known risk factor for venous thromboembolism, and all patients with active cancer undergoing a major surgical procedure should be considered a direct perioperative risk for venous thromboembolism compared with patients without cancer. While in-hospital postoperative prophylaxis has long been the standard, most recently several studies have evaluated longer duration of therapy in up to 4 weeks, for example, with in-hospital prophylaxis. We can see the result of a recent meta-analysis that suggests significantly lower rates of venous thromboembolism with extended thromboprophylaxis, with no difference in other outcomes such as major bleeding or death. So the ASCO guideline stated that in hospitalized surgical patients that have active cancer and that receive major surgery at low bleeding risk and have not bleeding or other contraindication, they should receive medical prophylaxis. Mechanical prophylaxis may be added in patients with the higher risk of venous thromboembolism, but it does not be used as monotherapy unless anticoagulation is contraindicated. Medical prophylaxis should be started pre-surgery and continued for 7 to 10 days, and as we can see, up to 4 weeks just in high-risk patients. The ASH guidelines sorted their recommendation by surgical bleeding risk. If the latter is low, medical prophylaxis is suggested along with mechanical prophylaxis if venous thromboembolism risk is high. In cases of high surgical bleeding risk, just mechanical prophylaxis is suggested. More specifically, low molecular weight heparin is suggested over unfractionated heparin and is suggested to start medical prophylaxis post-operatively and continue it after discharge. Finally, the ESMO recommendations are based on surgical bleeding risk as well. Low molecular weight heparin should be preferred over unfractionated heparin or fondaparinux, but medical prophylaxis should be started within 12 hours pre-surgery and continued at least 10 days and up to 4 weeks in high-risk patients. Finally, we will talk about ambulatory patient with cancer. Ambulatory is defined as the period of time during which a patient is not hospitalized for surgery or medical illness or receiving end-of-life care, but is in the community receiving anti-cancer therapy as an outpatient. Starting in the 1990s, a study from Levin and colleagues first investigated thromboprophylaxis in cancer outpatients. They showed that low-dose warfarin in women with metastatic breast cancer was associated with an 85% reduction in relative risk for venous thromboembolism, with no increase in bleeding rate compared to the control arm. Most recently, several studies addressed the question of thromboprophylaxis in the outpatient setting, enrolling broad populations with different types of malignancies, with a focus on specific cancer types carrying a high risk for venous thromboembolism, such as pancreatic cancer or myeloma multiple myeloma. Specifically, the PROTECT study included patients with lung, breast, gastrointestinal, head, neck, and ovarian cancer that were randomly assigned to receive daily subcutaneous nadoparin or placebo. As we can see on the left side of the screen, rates of VTE in high-risk patients were lower in nadoparin than placebo group, without increasing the risk of clinically relevant major bleedings. On the right side, we have the result of SAVE-ONCO trial that are similar to the previous. In this study, a patient with any metastatic of locally advanced solid tumors starting chemotherapy were randomly assigned to receive simuloparin or placebo. Despite the low rate of events in the control arm, the study demonstrated a significant reduction in the incidence of venous thromboembolism in patients receiving simuloparin, with no increase in the incidence of major bleeding. Similar evidence has been observed in multiple myeloma. An Italian study showed that in patients with a new diagnosis and without a high individual risk of VTE, medical prophylaxis with either aspirin or low molecular weight heparin during lenalidomide-based induction treatment is associated with a low incidence of venous thromboembolism without any increase in major bleeding. So direct oral anticoagulants, and particularly the factor Xa inhibitors apixaban, edoxaban, and rivaroxaban, are being widely investigated during the last year for use in patients with cancer. However, the results of this recent meta-analysis concluded that in ambulatory cancer patients, primary thromboprophylaxis with direct factor Xa inhibitors may reduce the incidence of symptomatic venous thromboembolism and probably increase the risk of major bleeding when compared with placebo. So this is as ASCO guidelines say about the topic, and they stated that medical prophylaxis should not be routinely offered to ambulatory patients with cancer. Otherwise, high-risk patients, as those with a corona score more than 2 and no bleeding risk factors and no drug interactions, may receive medical prophylaxis with low molecular weight heparin, apixaban, or rivaroxaban. Specifically, patients with multiple myeloma receiving thalidomide or lenalidomide-based regimens with chemotherapy and/or dexamethasone with a low risk of venous thromboembolism should receive aspirin or low molecular weight heparin, while patients with high risk of venous thromboembolism just low molecular weight heparin. ASH guidelines suggested low molecular weight heparin, apixaban, or rivaroxaban in patients, once again, at high risk of venous thromboembolism, while apixaban or rivaroxaban or no prophylaxis in those with an intermediate risk of venous thromboembolism. Finally, in patients with low risk of venous thromboembolism, no medical prophylaxis is recommended. And finally, the ESMO guidelines that suggest low molecular weight heparin, apixaban, or rivaroxaban for a maximum of 6 months in high-risk patients and high dose of low molecular weight heparin for a maximum of 3 months in patients with pancreatic cancer on first-line therapy. Specifically for patients with multiple myeloma, low molecular weight heparin is recommended for 3 to 6 months in patients at high risk of venous thromboembolism, while aspirin is recommended in patients receiving immunomodulatory drugs or dexamethasone. Finally, apixaban or rivaroxaban are potential options in patients with a creatinine clearance more than 30 or intolerance to low molecular weight heparin. And now this is a very important table in which we can find the approved dosage of anticoagulant therapy for medical prophylaxis in patients with cancer sorted by the type of clinical setting. However, appropriate treatment of venous thromboembolism in patients with cancer is crucial. And now we'll talk about whether patients with cancer should receive anticoagulation for therapy, for treatment of venous thromboembolism. As we can see, treatment of venous thromboembolism is very important, is crucial because of the negative impact of survival and the high risk rate of complication, including recurrent venous thromboembolism and bleeding. However, should be acknowledged that up to date, different therapeutic options are currently available for this patient. During the last year, low molecular weight heparin are shown to be superior to vitamin K antagonists, and they were the cornerstone for treatment of thromboembolic events in cancer over the last 20 years. The first studies of note is the CLOT study that randomly assigned patients with cancer and acute symptomatic VTE to receive dalteparin, followed by warfarin, the target ENR of 2.5 or therapeutic dalteparin for 6 months. Patients in dalteparin had a significantly lower rate of recurrent events with similar rate for major bleeding and any bleeding. After 10 years comes the CATCH trial that compared therapeutic doses of tinzaparin for 6 months with warfarin on target INR of 2 to 3. Similar to the prior study, the rate of venous thromboembolism decreased from 10% in the warfarin group to 6.9% in the tinzaparin group, although this was not statistically significant. Major bleeding rates were similar in two arms, while clinically relevant non-major bleeding events were significantly lower in the tinzaparin group. Now here we have the results of 3 major trials comparing the efficacy and safety of direct anticoagulants and dalteparin. All 3 DOACs are at least non-inferior and more safe than dalteparin. We have the result of Okusai VTE cancer select with edoxaban, select D with rivaroxaban, and Caravaggio with apixaban. Based on these data, ASCO guidelines stated that low molecular weight heparin, unfractionated heparin, fundaparinux, and rivaroxaban is preferred for the initial phase, while molecular weight heparin, edoxaban, and rivaroxaban for long-term anticoagulation for at least 6 months in patients with active cancer, and beyond the 6 months in selected patients, as well those with metastasis or receiving chemotherapy. VKA, as we know, are inferior in terms of both efficacy and safety, but may be used if low molecular weight heparin or DOACs are not feasible. Both ASH and ESMO recommendations are similar, but included apixaban in short, long-term, or extended phases of treatment. However, it should be acknowledged that there is an increase in major bleeding risk with DOACs in gastrointestinal and potentially genitourinary cancer. Caution with DOAC is also warranted in other settings with high risk for mucosal bleeding or drug-to-drug interactions. Only two prospective multicenter studies, the DALTECAN and TCAT studies, have assessed the safety and efficacy of extended therapy with low molecular weight heparin up to 12 months in patients with cancer and acute venous thromboembolism. The rate of recurrent VTE decreased from during month 7 to 12, and the safety was appropriate in both studies. So we can argue a possible favorable risk to benefit profile for extended treatment. On the other hand, whether drug is used, the indication to continue anticoagulant therapy until the cancer is active should be periodically reassessed. Across the special consideration, we have to report the incidental venous thromboembolism that is defined as asymptomatic venous thromboembolism that is diagnosed on radiological imaging ordered for other reasons, such as cancer staging or restaging. They contribute to up to the half of all venous thromboembolism events in patients with cancer. So the ASCO guidelines stated that incidental venous thromboembolism should be treated as symptomatic venous thromboembolism with a case-by-case evaluation in incidental isolated subsegmental pulmonary embolism. Some words also on vena cava filters that may be offered to patients with absolute contraindication to anticoagulation in acute thrombosis if the thrombus burden is considered life-threatening or in patients with thrombus progression despite optimal anticoagulation therapy. Recommendations in this topic are similar also in the ASH, the ESMO guidelines, with more stringent criteria for vena cava filters in the ASH guideline that suggests using supratherapeutic low molecular weight heparin doses over filter. Finally, in this table, we can see the dosage of different anticoagulant drugs that may be used in the acute phase as well as for the long-term treatment of venous thromboembolism in patients with cancer. Now, just some word on the risk of recurrent venous thromboembolism that may occur despite appropriate anticoagulation. Lack of compliance, temporary withholding of therapy due to bleeding or procedures, inadequate dosing, cancer progression, or just heparin-induced thrombocytopenia are possible reasons for venous thromboembolism recurrence. Here we can see a model that can help us to identify those patients with cancer at high risk of recurrent event. However, low molecular weight heparin is considered to be the preferred approach, and patients who have a recurrent venous thromboembolism should be started on therapeutic low molecular weight heparin if on other treatment. Here we can see the recommendation of ESMO guidelines for the treatment of cancer-associated thrombosis and thrombocytopenia. Thrombocytopenia is defined as a low platelet count and is common complication in patients with cancer, mainly those with hematological cancer. Despite the higher bleeding risk, thrombocytopenia is not associated with a reduction of thromboembolic risk. Several aspects should be considered for assessing individual risk of recurrence, including time from events, thrombotic burden, and the feature of thrombocytopenia. However, it should be acknowledged that there are limited data for the management of arterial thrombosis in patients with cancer. Medical therapy, including antiplatelet agents and catheter-based revascularization, are the cornerstone for arterial thrombosis treatment in patients with both cancer and without cancer. However, attention should be paid to the increased bleeding risk of patients with cancer. Here, I reported the ESMO chart for the use of single antiplatelet agents for secondary prevention. And as we can see, low-dose single antiplatelet therapy may be continued until the platelet count remain over 50,000. These are the ESMO guideline recommendation on the use of dual antiplatelet therapy in patients with acute coronary syndrome or the post-PCI. Finally, this is once again the ESMO recommendation for the use of thrombolytic therapy, thrombectomy in patients with acute ischemic stroke. Finally, we know that there are ongoing research that focus on developing future anticoagulants with an improved safety. Several promising approaches to reduce the bleeding risk involve targeting the intrinsic pathway of coagulation with the goal of preventing thrombosis without impairing hemostasis. So patients with an increased risk of bleeding, such as those with cancer, may benefit from these new anticoagulants, and ongoing trials are addressing the efficacy and safety of factor Xa inhibitors in patients with cancer-associated thrombosis. Thanks for your attention.
Thank you, Professor Emmanuel, for this comprehensive talk. It's very excellent and very informative. And I think now the floor is open for questions. Doctor, can I start with Dr. Marwan Akasha?
Hello. Thank you for your precious talk. Actually, at the moment, I have a patient with the new onset pulmonary embolism on top of liver cirrhosis with an INR.
Excuse me, I can hear you very well.
You can't hear me?
Yeah. Now I can hear you.
تقدر تحكي دكتور مروان بس صوتك مسموع من هون.
I will repeat. Today I have a lady with a new onset pulmonary embolism on top of cirrhotic liver and INR of 2. So how can I manage with INR of 2 and acute onset pulmonary embolism?
Cancer patient.
She's a cancer patient, colon cancer.
Okay, as we can see in one of my slide that I select, patient with cancer may have recurrent events. In this case, we may try to switch to low molecular weight heparin if other drug is used.
So I will use fondaparinux like.
You can use low molecular weight heparin such as enoxaparin, for example, or dalteparin, or another kind of low molecular.
INR. Despite high INR.
2 INR.
The INR is 2.
INR is 2. Yes, but we have to withhold warfarin or the.
She was not on warfarin. Liver cirrhosis. She has liver cirrhosis. She's like child B liver cirrhosis.
Yes. Okay. Now I understand the question.
With the new onset PE.
Yeah, I know. As we know, patients with cancer have an increased bleeding risk, but also an increased thrombotic risk, and INR not well perform or indicate the bleeding risk of patients with liver cirrhosis. So we can use low molecular weight heparin to treat this recurrent event.
Okay.
At the therapeutic doses.
Okay, thank you. Thank you.
Yes. You're welcome. Thank you for the question.
Thank you for your excellent overview about the cancer thrombosis. What do you mean by high dose low molecular weight heparin? High dose low molecular. I know the dose is 1 milligram per kg twice daily or 1.5. You mentioned high dose low molecular weight heparin in one of your slides, or just.
Yeah, Allora, you can hear me? Can you hear me?
Yes, we can.
Okay. As therapeutic doses of low molecular weight heparin are 1 milligram per kilogram. Supratherapeutic doses of low molecular weight heparin is an increase of 25% of the standard dose. Okay.
Thank you for your presentation. My question is, as shown in the previous several slides.
Excuse me, I can hear you very well. Can you repeat, please?
As shown in previous slides, several slides, the hemoglobin less than 10 is one of risk factor to increase renal embolism. So this, you encourage us to increase the by blood transfusion, for example, the hemoglobin of cancer patient to more than 10 in order to decrease the risk of venous thrombosis. Origin is the data is just for risk stratification.
Excuse me, I can't hear you very well. Can you repeat slowly, please?
من هين دكتور؟
من هون أخذ لا سؤال.
Okay. As shown in the several slides in your lecture, the hemoglobin less than 10 is one of the increase the risk factor for venous embolism.
Okay.
So do you encourage us to increase the level of hemoglobin to our cancer patient to more than 10 by blood transfusion, or just data this was just for risk stratification?
Yeah, these are only data for risk stratification, and there are no recommendation to increase hemoglobin value to reduce the risk of venous thromboembolism. I don't know if reply well your question, but I can.
Yeah,
okay, thank you.
Thank you again. In the risk model you showed, where do congenital thrombophilic factors fit in?
There up to date there are not risk assessment model that evaluated the effect or the role of thrombophilia in patients with cancer. This is a great question and have to be evaluated in further studies.
I think we can we have one or two questions. Dr. Ayman.
Thank you, Professor, again. Actually, I have two questions.
Thank you all.
First, the question, as you mentioned in your lecture, the risk of thrombosis was higher in adenocarcinoma subtypes compared to the other subtypes, and the lowest was squamous cell carcinoma. Is there any idea why is this difference or an explanation? The other question regarding the risk of bleeding after anticoagulation among the oral anticoagulation agents. Is there any difference of bleeding? For example, if we have a patient with GI cancer and there's risk of bleeding and there is thrombosis, and we like to start on anticoagulation. Is there any difference between the oral anticoagulation? Do you prefer some over the others?
Okay, let's start with the first question. And there are scanty data on the effect of histological type of some cancer on the risk of venous thromboembolism, and this is those that I reported are the result of one study that is only descriptive, and authors did not report any suggestion on the effect, but we can argue that histological type, more aggressive histological type is responsible for a higher risk of venous thromboembolism. For the second question, in our center, we prefer to start treatment of venous thromboembolism are less contraindicated with oral anticoagulants. And risk about the risk of bleeding, the risk of bleeding is higher in some gastrointestinal or genitourinary cancer. So in this kind of patient, we can start with a low molecular weight heparin and then shift to oral anticoagulants.
Okay, thank you. I think we have the last question by Dr. Khalid Halahla.
Okay.
Thank you very much. Very comprehensive and lots of data. My question regarding the inferior vena cava filters, even if you put the risk of thrombosis is really high, I know there is contraindication regarding chemotherapy, thrombocytopenia. Would you still recommend, I looked on the recommendation of the ASCO, but would you still recommend vena cava insertions in cancer patients, in active therapy and active cancer?
So in our practice, we recommend vena cava filter after a careful evaluation of thrombotic risk of the patient. And if patient have a absolute contraindication to start anticoagulant treatment and thrombotic burden is high, we evaluate the use of a vena cava filter that we will remove when patient can start the anticoagulant therapy. Okay.
Thank you. Thank you.
Thank you very much, Prof. Emmanuel. This is a very comprehensive and a very nice lecture to all the audience. And I hope all they have get the benefit from this lecture. And with that, we conclude this session. We move to the next lecture. Thank you very much.
Thank you all. Bye.
Grazie.
Ciao.
Onları duyamıyoruz.
Açıyoruz.
Kısa zaman da öbür resim çıkıyor sürekli. Değilmiş.
Açıyoruz biz. Mikrofonu açık mı diye baktım ama.
Şimdi azaldı. Can you hear me?
Yes, we can hear you.
Yes, we can hear, Doctor.
Could you see my slides?
Yes.
Okay, first of all, I would like to thank Jordan Society of Hematology for their invitation. I'm glad to be.
Okay, let me present you, Doctor, first.
Okay, please.
Okay. Good afternoon, ladies and gentlemen. First of all, in my name and Jordanian Society of Hematology, please, Dr. Celine, accept our sincerest condolences and deepest sympathy. No words can describe how sorry we are after hearing about this disaster. I mean the earthquake in South Turkey and north of Syria. Please accept our condolences, Doctor. Now, ladies and gentlemen, let me present our speaker, Dr. Celine Bakir is a hematologist working in Ashibadi Masalak Hospital in the University of Health Science Kanuni Sultan Sulaiman Education and Research Hospital. She has graduated and finished her residency and fellowship program from Istanbul University. She has multiple publication, presentation, as well as many honors and awards. Dr. Celine talks will be about the latest update in the treatment of sickle cell disease. Please, Doctor, the mic is yours.
Thank you. First of all, I would like to thank Jordan Society of Hematology for their kind invitation, and I'm glad to be a part of this meeting. Before starting my talk about sickle cell anemia, I would like to declare my sorrow. As you all may know, Turkey and Syria are affected by a terrible earthquake disaster. Thank you for your best wishes for us. It is very hard to stay calm and give a talk in these circumstances of my country. I would like to say that my heart is with the victims. So my presentation plan will start shortly with the background and pathophysiology of the disease. I will mention shortly about the disease characteristics and will come to the management. Sickle cell disease and its variants are genetic disorders resulting from the presence of a mutated form of hemoglobin S. Dr. Herrick described the first clinical case of sickle cell disease in 1910. 4 decades later, Ingram and colleagues characterized the replacement of glutamic acid with valine in the 6th position of the beta-globin chain, as you see on the right-hand side. This disease is a global health condition affecting more than 20 million people worldwide, mostly of African descent. 1 in every 375 African American infants are diagnosed with sickle cell disease annually. Average lifespan is about 50 years of age, but in the last decades, many adults may live to 70 years in well-resourced countries. Mortality rate is 50 to 80%, especially in the first 5 years of life for underdeveloped countries. And World Health Organization declared sickle cell disease as a global health problem in 2006. So calling for worldwide efforts to develop affordable and effective treatment options is very critical. It is an autosomal recessive disease. Homozygous hemoglobin SS and hemoglobin S beta thalassemia are the most common and clinically severe phenotypes. And there are some other compound heterozygous forms, including hemoglobin SC and others. If there is hypoxia, acidosis, or dehydration, hemoglobin S polymerizes and forms linear elongated fibers called sickles, which cause chronic hemolytic anemia, acute episodes of pain due to vaso-occlusion, and obstruction of blood flow, meaning tissue ischemia. Due to this ischemia reperfusion injury, we see a generation of reactive oxygen species, endothelial cell activation, increased adhesion molecules, activation of blood cells, which leads to a chronic inflammatory state. Intravascular hemolysis of sickles cause nitric oxide depletion and endothelial dysfunction. And deoxyhemoglobin S polymerization causes lipid peroxidation and membrane damage, which leads to a hypercoagulable state. All of these pathophysiologic events lead to chronic organ damage and shortened life expectancy. We see here the drepanocytes. Shortly, we can say vaso-occlusive phenomena and hemolysis are the clinical hallmarks of the disease. There are some complications of sickle cell disease, acute complications and chronic complications. Among acute complications, we can say vaso-occlusive crisis and pain, acute chest syndrome, hepatobiliary complications, multi-organ failure, priapism, splenic sequestration, and cerebrovascular disease. And chronic complications are again chronic pain, neurocognitive dysfunctions, pulmonary hypertension, leg ulcers, bone disease, retinopathy, renal failure, and growth retardation. Here in this figure, we can see some of the complications, again, cerebrovascular disease, hepatopathy, avascular necrosis of bones, bone infarctions, osteomyelitis, retinopathy, cardiac left ventricular hypertrophy, pulmonary hypertension, nephropathy, and leg ulceration, as you can see. Of course, I'm not going to read all of the details of this table, but I am going to show you that pain is about affecting about 50% of the patients, and also chronic lung disease, restrictive chronic lung disease affects more than 70% of adults. So these are the most common complications. When we come to the management strategies, there are two ways. First one is the prevention and treatment of the complications, which are infections, transfusion. I will go into the detail of the background of drug therapy. Then I will discuss the complications one by one and chelation. And the other way is the cure, which is achieved by transplantation or gene therapy. Early in childhood, functional acyclemia develops, which makes the individuals susceptible to infections. There are two major measures for preventing infections: immunization and prophylactic penicillin use. 2012 Cochrane review included data from 457 patients, which shows penicillin prophylaxis was associated with a decreased risk of pneumococcal infection and death. When feasible, antibiotic prophylaxis is indicated for individuals who are household contacts of persons with infections. When we come to immunization, all routinely recommended childhood vaccines, including those against Streptococcus pneumonia, Neisseria meningitidis, Haemophilus influenza type B, and hepatitis B, are recommended. There are two types of pneumococcal vaccine. First one is the conjugated vaccine, which can be administered as early as 6 weeks of age, and it elicits an effective immunologic response during the first 2 years of life. The polysaccharide vaccine includes a greater number of serotypes, but is not immunogenic under the age of 2. Additionally, annual seasonal influenza vaccination starting at 6 months of age is recommended. After the pandemic, we have to say that COVID-19 vaccination is very important for these patients. And data from the baby hug trial is reassuring that the use of hydroxyurea, which drug I'm going to talk about in detail later, does not interfere with the response to immunizations. Infections are the most common reason of morbidity and mortality. That's why we don't have to forget that fever is always a medical emergency in sickle cell disease. If we see a patient with fever, we have to take blood and urinary cultures and start as soon as possible with antibiotics with coverage against Streptococcus pneumonia and gram-negative enteric organisms. Risks go to extent in adults. Also herald some acute and life-threatening conditions such as acute chest syndrome or osteomyelitis. And if there is accompanying hypotension, petechiae purpura, central venous catheter, history of infection, any acute complication, or a septic patient, we have to hospitalize. Sorry, there is a problem.
Excuses.
Coming to transfusion, there are three ways of transfusion: simple transfusion, simple chronic transfusion, and exchange transfusion, all to treat and prevent complications. When we look at this diagram, we see in which indications the transfusion types are recommended. Simple transfusions we can use in symptomatic anemia, acute neurologic complications, acute chest syndrome, acute multi-organ failure, perioperative time, and acute splenic or hepatic sequestration. Simple chronic transfusions we can use to prevent stroke, in prevention of recurrent acute chest syndrome, anemia of chronic kidney disease, pulmonary hypertension if there is chronic hypoxia, and heart failure. Exchange transfusion we use in acute neurologic complications, severe acute chest syndrome, again in acute multi-organ failure, pre-operative preparation, sometimes before giving birth, prevention of hypervolemia and hyperviscosity, and iron overload. Transfusion is not indicated in asymptomatic anemia, acute kidney injury unless multisystem organ failure, in priapism, and uncomplicated painful crisis. The aim of long-term transfusion is to maintain a low concentration of hemoglobin S. The hemoglobin S target varies according to the indication. Usually, the most major, one of the most major indications is prevention of stroke, and in that situation, we target 30% of hemoglobin S. In intrahepatic cholestasis, it is controversial, but usually some authors target 20, some authors target 30% of hemoglobin S. Transfusion have some risks. First risk in sickle cell disease, as I mentioned in the pathophysiology, is the hyperviscosity. And the second risk is when we transfuse chronically, there is the risk of alloimmunization. Remarkable Rh allelic diversity and mismatch is seen in almost 90% of individuals. Extended red cell phenotyping, including subgroups, is recommended in this situation. And there is the risk of iron load, which I'm going to mention later shortly again. The indications for exchange transfusion, if we have to say again, are stroke, acute chest syndrome, hepatopathy, planned surgical procedures during pregnancy, in women who have a history of severe complications prior to stem cell mobilization, and in cases of iron load, But don't forget about the economic issues. The role of exchange transfusion is not determined in pulmonary hypertension, end-stage renal disease, and sickle retinopathy. I am now on the main subject of my talk, which is the treatment of sickle cell disease. In 1948, Dr. Watson observed that the delayed onset of clinical symptoms due to higher hemoglobin F levels occurred during the first year of life. Patients with hemoglobin S who co-inherited a persistent fetal hemoglobin are relatively asymptomatic. Hemoglobin F has the ability to form hemoglobin hybrids that inhibit hemoglobin S polymerization. So, more recent clinical studies support the use of hydroxycarbamide in children with a dosing strategy of different hemoglobin F targets according to the indication. Another important factor in addition to hemoglobin F levels is the distribution of hemoglobin in erythrocytes. Numerous hereditary persistent fetal hemoglobin variants lead to significant hemoglobin F levels in the majority of erythrocytes, I mean pancellular, producing benign clinical phenotypes. To achieve maximal clinical benefit, it's critical that pharmacological agents produce a pancellular hemoglobin F distribution. So all effective treatments are mainly based on the idea to induce hemoglobin F. Hydroxycarbamide, which I'm going to call HU, hydroxyurea, proved effectivity in adults and was FDA approved in 1998. But efforts to define a non-chemotherapeutic treatment option and the role of events downstream of deoxyhemoglobin S polymerization expand drug targets. And since 2018, 3 new drugs were FDA approved, but research to develop treatments continue. Firstly, we start with hydroxycarbamide. It is an S-phase specific cytotoxic, antimetabolic, and antineoplastic molecule. It is a potent inhibitor of ribonucleotide diphosphate reductase. Much is still unknown about how it induces hemoglobin F synthesis. One of the most widely accepted mechanisms is stress erythropoiesis response, which alters erythroid differentiation kinetics, resulting in a release of reticulocytes and erythrocytes with high hemoglobin F levels. Hydroxyurea also reacts with heme-containing proteins to release nitric oxide. There is this one major trial, phase 3 multicenter study of hydroxycarbamide in patients with sickle cell anemia, completed in 1995, showing clinical benefit of hydroxyurea in decreasing walk pain episodes in 50% of adult patients. Hydroxyurea causes a heterocellular distribution that we target of hemoglobin F synthesis. Disease-modifying effects unrelated to hemoglobin F induction, such as reduction in erythrocyte adhesion and leukocyte counts, is additional. Approval in adult patients by FDA is in 1998 and by EMA is 2007. And the use in children above the year of 2 was approved in 2017. So it has a proven efficacy and tolerable side effect profile. Switch trial shows hydroxyurea versus chronic transfusion in children with sickle cell disease at high risk for stroke, which is determined by an abnormal transcranial Doppler ultrasound. It is a multi-center open-label phase 3 trial, which is a non-inferiority trial. And the other trial with a lovely name, Baby Hug trial, is a randomized double-blind multi-center phase 3 trial in which even 9 months of age, children can get hydroxyurea, and it shows reduced pain, dactylitis, acute chest syndrome, hospitalization, and low transfusion amounts. So when we come to the dosing, we can start with 10 to 15 milligrams per kilogram per day, and we can increase 5 milligrams kilogram per day to the maximal dose of 35 milligrams per kilogram per day. In 4 to 12 weeks, there is an increase in hemoglobin F around 5 to 15%, and there is 1 grams per deciliter increase in hemoglobin. There is a trial, HOPES trial, which is a prospective randomized phase 3 trial, which is still ongoing, is testing weight-based dosing with pharmacokinetic guided dosing, which is not quite available in every center, but we will see the results. Hydroxyurea indications are pain, including dactylitis, acute chest syndrome, low hemoglobin and low percentage of hemoglobin F, elevated leukocytes, elevated LDH, chronic hypoxemia, and abnormal transcranial Doppler values refusing transfusions. There are some other not clear indications, as you can see here. Potential benefits of hydroxyurea are decreased vaso-occlusive pain. This is a major benefit. Decreased acute chest syndrome episodes, decreased transfusions, and decreased transcranial Doppler measurements, decreased priapism episodes, and improvement in survival, life expectancy, and quality of life. When we come to the side effects, mainly there are dermatologic side effects, as you can see here, usually skin ulcers, hyperpigmentation, but there are also some neurologic, gastrointestinal, hematological side effects. Two problems I have to mention about, and the first one is reversible bone marrow suppression. And the second one is a decline in hemoglobin F response to hydroxyurea in some individuals. This is important because it leads us and shows us a need to discover additional pharmacological agents that induce hemoglobin F by novel mechanisms or novel targets. There are recently drugs approved, L-glutamine, voxelotor, and crizanlizumab. And cells multi-center trial is an drug and given to people who are above 5 years of age, and it has been shown that it decreases the number of walk pain crises and acute chest syndrome episodes. So FDA granted approval for children above 5 years of age and adults. Voxelotor, Oxbrita, is an hemoglobin S polymerization inhibitor. It's a first-in-class agent. It stabilizes the relaxed oxygenated state of hemoglobin, non-polymerizing conformation of hemoglobin S. So it can shift oxygen dissociation curve to the left and modulates hemoglobin affinity for oxygen. The net result is a decrease in the concentration of the oxyhemoglobin S. It is checked by HOPE trial. It is a phase 3 randomized placebo-controlled trial. It is again oral drug, and it is given to patients above 12 years of age. And there has been a significant increase in total hemoglobin levels and reduction in hemolysis. Crizanlizumab is Adakveo, first-in-class monoclonal antibody against P-selectin. The main trial is SUSTAIN trial, which is double-blind randomized phase 2 trial. This drug is given IV monthly, and if the patient has taken hydroxyurea before, to 16 years of age. There has been detected a significant reduction in VOC or pain crisis, regardless of concomitant hydroxyurea use, and low incidence of adverse events. There is now another phase 2 trial shows efficacy of a pan-selectin inhibitor, Rivipancel, in the treatment of acute crisis, and phase 3 trial is under investigation. So what is more? Treatment strategies combining hydroxyurea with drugs targeting other pathophysiologic events are possible. So it will be the era of personalized combination drug regimens, in especially patients non-responsive to hydroxyurea or with contraindications. So-called targeted therapies include drugs that enhance metabolic molecules in erythrocytes, inhibit hemoglobin S polymerization, target abnormal vascular physiology, and having systemic effects. In this figure, you can see all of these targets, actually. So erythrocyte metabolism targets. Let's start with these. There is this enzyme, soluble guanylate cyclase. It is a key enzyme in nitric oxide signaling pathway. And nitric oxide binds a heme group in soluble guanylate cyclase. So vasorelaxation, smooth muscle proliferation inhibition occurs. And there are two soluble guanylate cyclase agonists, riociguat and olinsuguat. They are currently in clinical development for sickle cell disease. Riociguat is the only FDA-approved medical therapy for chronic thromboembolic pulmonary hypertension. There is a case series of 6 patients with sickle cell demonstrated safety and tolerability in adults. Olinsuguat was tested in strong SCD trial against placebo, but it was not found superior. Continuing with the metabolism targets, if there is an activation of pyruvate kinase, ATP increases. There is a decrease in 2,3-D-phosphoglycerate and hemoglobin S polymerization. In this concept, we have 2 drugs, etavopivat and mitapivat. These are small molecules activating erythrocyte pyruvate kinase, so decreasing sickling. The increase in ATP promotes repair and reduces chronic hemolysis. Etavopivat is tested in Hibiscus trial, which is still ongoing, versus placebo in improving hemoglobin and reducing vaso-occlusive crisis. Tobinontrin is another small molecule inhibitor of phosphodiesterase 9. It acts primarily on erythrocytes with the potential to act on leukocytes and adhesion mediators. It is checked in OLE trial in adult, mostly adult patients, and it is shown to reduce VOC rate. Imatinib mesylate, which we already know very well from CML, has preclinical data in mouse models that imatinib inhibits c-KIT-mediated mast cell activation and resultant neurogenic inflammation causing chronic pain in sickle cell disease. Imatinib was used in 2 sickle cell disease patients with CML who experienced reduced frequency of VOC episodes and pain. Therefore, there is this IMPACT trial. It is an early phase 1 trial investigating the safety and efficacy in reducing VOC pain, acute chest syndrome, and the need for opioids. Now we come to hemoglobin S polymerization as another target. The NMT1 inhibitors, including 5-azacitidine and its analog, decitabine, are effective in hemoglobin F induction. Decitabine incorporates into DNA. It's a potent drug with a favorable safety profile, but it is effective in IV form. Orally, it is not effective because it is rapidly degraded by intestinal cytidine deaminase. So oral administration of tetrahydrouridine, it is a cytidine deaminase inhibitor called cedazuridine before decitabine, resulted in a significant increase in hemoglobin F levels in sickle cell disease patients. There is another drug, benserazide, targeting hemoglobin S polymerization. It is usually used in Parkinson's disease. It is an L-DOPA decarboxylase inhibitor. In benefits trial, it is checked in patients with beta thalassemia. Now, after the finding of induction of this drug of gamma globulin, it will be checked in sickle cell patients too. Metformin, we all know, induces hemoglobin F levels in erythrocytes through FOXO3 silencing. There is, for metformin, FITMET trial, an early phase 1 trial. It is initiated in patients with sickle cell disease, but the outcome have not been published yet. The third target area is vascular targets. Ambrisentan is a selective endothelin receptor antagonist. It is approved for the treatment of idiopathic pulmonary hypertension. It is tested in sickle cell disease in a phase 1 clinical trial and found to be safe, tolerable, reducing microalbuminuria, increase arterial diameter, and improve microvascular functions. Intravenous immunoglobulin decreases neutrophil adhesion and erythrocyte neutrophil interactions in sickle cell disease. And again, in a phase 1 clinical trial, in low doses, it shows a decrease in membrane-activated complex activity. So these are now, let's say, experimental drugs, of course. And systemic targets. So systemic targets work through the pathophysiology of the disease again. When there is intravascular hemolysis, hemoglobin is released in plasma. It is oxidized and methemoglobin is formed. Methemoglobin dissociates into free heme and globin chains. Oxidation of free heme bound and detoxified by hemopexin. When free heme overwhelms the ability of hemopexin, heme iron loading of reticuloendothelial system happens, which causes a chronic inflammation. Hemopexin is a candidate agent for acute VOC and acute chest syndrome, and phase 1 study in adults is ongoing. And in VOC pain, of course, there is this problem of opioid-induced addiction, tolerance, and hyperalgesia, and we need non-opioid alternatives. Ticagrelor, an antiplatelet drug, is tested in a HESTIA-3 trial, but it was not found superior in comparison with placebo. Ketamine is an NMDA receptor antagonist used for anesthesia, and it is controversial if it is non-inferior to morphine. Current evidence is not sufficient to confirm safety and efficacy, and it is we can accept ketamine as an adjuvant drug to get less accumulative morphine doses. And Improved trial and a phase 2 trial shows inhaled mometasone furoate in non-asthmatic patients with cough or wheezing in sickle cell, measuring the effect on markers of pulmonary inflammation and vascular injury. The study found that nitric oxide and vascular cellular adhesion molecule levels are reduced, which causes a reduction in pain episodes. Studies have shown that sickle cell disease patients have a deficiency of essential omega-3 fatty acids, and supplementation supports a decrease in walk pain. And there is another phase 3 trial about an agent, again an omega-3 fatty acid in sickle cell disease patients. Safety and tolerability of 3 different doses are going to be checked, and the effect on the number of walk episodes. After all of these, just some few words about combination therapies. The concept of combined therapy was provided in 2 studies. The first study combined hydroxyurea with arginine butyrate, which resulted in higher hemoglobin F levels compared with butyrate alone. And the other study makes a combination with histone deacetylase inhibitors and DNMTA1 inhibitor 5-azacitidine. The challenge for the future is to design and conduct rational combination therapies, likely be guided by the severity of clinical phenotype and non-overlapping toxicities.
Dr. Selir, 2 minutes, please.
I would like to mention the acute complications actually, but I don't think there will be time for that because it was in my slides, they were like one by one. Let's say shortly, in acute chest syndrome, we have to be cautious to give antibiotics. We have to consider hypoxemia and give supplemental oxygen treatment. We have to transfuse not above hemoglobin 10, and in rapid progression we have to do exchange transfusion. In hepatobiliary complications, again we have to consult a surgical, we have to do a surgical consultation and give antibiotics. In symptomatic cases we have to do cholecystectomy, and in confirmed acute hepatic sequestration we have to perform transfusion, simple or exchange. After organ failure, we can switch. In pain crisis, mild to moderate pain, we can use non-steroid anti-inflammatory drugs. In severe pain, we have to use parenteral opioids, and we don't administer blood transfusion unless there are other indications. And hydration is very important. Oxygenation is very important. In priapism lasting for more than 4 hours, we have to give hydration, analgesia, consult with an urologist, and we do not transfuse for acute treatment. In splenic sequestration, we have to give immediately IV fluid resuscitation. For acute splenic sequestration, we have to transfuse to raise the hemoglobin to a stable level, careful about the hyperviscosity, and if there is recurrency, we have to do splenectomy. In stroke, it is important if acute stroke is confirmed by neuroimaging, we have to perform an exchange transfusion, and hemoglobin S level we have to maintain below 30%. Pulmonary hypertension, we have to give supplemental oxygen, diuretics, hydroxyurea, escalation, anticoagulation, and pulmonary vasodilator therapy, like ulcers. I can switch. Bone health and growth disturbances are also very common in sickle cell disease. Don't forget about zinc in growth disturbances. And don't forget about the patients who are hospitalized due to an acute complication. We have to do thromboembolism prophylaxis. So folic acid and a multivitamin without iron is the main issues in nutrition. And long-term blood transfusion can lead to iron overload. So we have to check serum ferritin and liver iron concentration, and maybe we prefer exchange transfusion. Cure comes with transplantation. I am not going to go into detail very much because of time, but we don't have to forget about two problems: conditioning regimen, which can be a non-myeloablative regimen. It has expanded transplantation as a treatment option for adult patients with pre-existing organ dysfunction who would have been otherwise ineligible. And there is an HLA-matched sibling or as donors, there is a very low amount of donors, below 15%. So haploidentical transplantation comes in front. These are the indications for the transplantation. As you can see: stroke and vaso-occlusive pain crisis in recurrency, acute chest syndrome with recurrent hospitalizations, osteonecrosis of multiple joints, elevated transcranial Doppler levels, and lastly, gene therapy. In 2014, the first patient was successfully treated with gene therapy, and the first clinical trial was opened in the US with the lentiglobin, and over 20 patients have been treated with the variations of this globin. And preparatory regimens combined with autologous hematopoietic stem cell transplantation. As you can see, there are so many trials which are active in sickle cell disease. And my last words are the implementation of early diagnosis, education, recommended treatment strategies, new treatment options, screening, and close follow-up, and in a patient-centered setting is essential to address the medical vulnerabilities of this population. Thank you all for listening to me, and I'm going to dedicate my talk to the victims of the earthquake in Turkey and Syria. Thank you.
Thank you, Dr. Celine, for this excellent presentation and useful and updated information.
Thank you.
Any question for one or two questions, if there is anyone?
Dr. Qasim, I have a question, please.
Please.
Please go on.
Okay, thank you for your nice presentation, doctor. We have a patient who is 10 years old, sickle thalassemia. Actually, he developed a stroke while his hemoglobin S was 75%. And after we did an exchange for him, 2 times actually, and the hemoglobin S less than 50%, he developed another stroke. And after that, when the hemoglobin S even 40%, he developed another stroke in within a 2 weeks period. Do you recommend to add anticoagulant for this patient as antithrombosis for this, like low molecular weight heparin or anything? Because as we decrease the hemoglobin S level in this patient, but he is still having a stroke. Thank you.
Thank you for your question. Maybe I don't know if he is taking hydroxyurea, but maybe if it is possible.
Yes, he received hydroxyurea in the highest dose, actually.
Highest dose.
Yes, and unfortunately, we don't have a mass donor for him for hematopoietic stem cell transplantation.
I think from my experience in Istanbul University, there were about 5 patients. We did exchange transfusion due to the same situation as you mentioned, recurrent stroke. So we also had to hospitalize these patients. That's why we used low molecular weight of heparin in a prophylactic dose in those patients. But after we can decrease the hemoglobin S levels in one patient, I remember below 35%, then we could cope with the recurrency of the stroke.
Thank you, Doctor.
Thank you, Dr. Musa. Thank you, Dr. Celine.
Thank you.
Next session.
Thank you very much.
Thank you, Dr. Celine. Thank you.
Can you see my slides okay? Thank you. Sorry, I'm not able to hear anything. So I didn't know if you just wanted me to start or if you wanted to do an introduction.
Good evening, ladies and gentlemen. I'm Dr. Zamoni, medical oncologist at Royal Medical Services, and my colleague, Dr. Osimertinib, medical oncology consultant at King Abdullah University Hospital. It's a pleasure to be a part of this fruitful scientific conference. Very thanks for Professor Abdullah Abadi and of course for Dr. Ghadir Abdin. Today our topic will be about the first-line management in diffuse large B-cell lymphoma, presented by Dr. Wendy Osborne. Dr. Wendy Osborne is a consultant hematologist at the Freeman Hospital in Newcastle upon Tyne Hospitals NHS Foundation Trust. She graduated with first-class honors from Newcastle University in 1998 and completed her general medicine training at Queen's Medical Centre, Nottingham. Dr. Osborne worked in hematology departments in Glasgow before returning to Newcastle to undertake higher specialist training. Dr. Osborne is chair of the British Society of Hematology Lymphoma Special Interest Group and a member of the NCRI Clinical Studies Group, High-Grade Lymphoma Subgroup, Hodgkin Lymphoma Subgroup. Dr. Osborne is on the Medical Advisory Panel for Lymphoma Action and is a principal investigator and co-investigator for numerous clinical trials. Dr. Osborne is the teaching lead for the hematology undergraduate program at Newcastle University and was appointed as an associate lecturer in 2016. Dr. Osborne, please start your session.
Thank you very much. And I'm delighted to talk to you today about how should we manage diffuse large B-cell lymphoma in the first-line setting. Let me just check the slides move forward. There we go. And here are my disclosures. We know that diffuse large B-cell lymphoma is important, and it's important because it's the commonest non-Hodgkin lymphoma we look after. And although for many patients it's curable, about 60% of patients we cure first line, when patients relapse, the subsequent treatments are often toxic and the responses are often poor. And so it's really important that we try to optimize our first line treatment for these patients. So I think that there are 5 important questions when we're in clinic with these patients. Can we do anything better than R-CHOP 21? What about these higher risk patients, these high IPI or double hit lymphoma? What are the data to try and should we be intensifying treatments for these patients? And then over the years, I think it's fair to say that we've had lots of discussion about whether we should consolidate with autologous stem cell transplant. We look after, unfortunately, many patients who are older and less fit. What is the optimal way to manage them? And then finally, the question about the role of radiotherapy in diffuse large B-cell lymphoma. So we know that if we're going to use R-CHOP, that there is no improvement if we give 8 cycles as opposed to 6 cycles. And 8 cycles up until a few years ago had been a standard of care, particularly in mainland Europe. But now most centres would agree that using R-CHOP 21, it would be 6 cycles. The UK ran the R-CHOP 14 versus R-CHOP 21 study, a randomised large phase 3 study, and there was no difference in progression-free or overall survival in the patients who had R-CHOP 14, and it was more difficult to deliver. And so again, in most situations we would use, if we're using R-CHOP, we would use R-CHOP 21. And we also know from the randomised Goya study that unlike in follicular lymphoma, where there is a benefit of using a different anti-CD20, obinutuzumab, for diffuse large B-cell lymphoma, there was no benefit compared to rituximab. And then for many, many years, we've been trying to add targeted therapies in combination with R-CHOP to try and get an improvement in outcome. In the Phoenix study, the addition of ibrutinib showed that there was no improvement in event-free or overall survival in the non-GCP intention to treat population. The data have been reanalyzed for patients with co-expression of MYC and BCL2, and in the younger patients there was a better event-free survival, but this is a sub-analysis of these studies. Addition of lenalidomide has not again produced an improvement there was a benefit of lenalidomide maintenance, but only in older patients, and this was shown in the REMARK study. So this is a summary slide really of all the attempts to improve on outcome on first-line R-CHOP. So I think that we were quite interested at ASH this year with updated data from the Remodel B study. So the Remodel B study used real-time gene expression profiling, which was done in a central lab in the UK, with the addition of bortezomib to R-CHOP to see if there was an improvement. The primary readout from the study done at 2 years showed that there wasn't a progression-free survival benefit by adding bortezomib. It did show that there was a new description of this so-called molecular high-grade phenotype, which is associated with inferior outcome. And I think as we're understanding more and more about the biology of diffuse large B-cell, we understand that it isn't just one disease and that it incorporates many diseases with certain risk factors. And this will be the future that we have to understand this. But the 5-year follow-up were presented just back in December in New Orleans, showing that with additional follow-up, there was a 15% improvement in progression-free survival in the ABC group. And if we looked at the molecular high-grade group, this was increased to 26%. And this also translated into an overall survival of 13% at 60 months. Now, in practice, certainly in the UK, we can't do real-time gene expression profiling. And so at present, we are not taking this forward. And I think that's partly due to these also new data that's come through from the Polarix study. So the Polarix study was adding Polatuzumab to R-CHOP. And Polatuzumab, as we know, because we use it quite a lot in a relapsed refractory setting, is an antibody drug conjugate targeting 79B, which is targeted and internalized. And the sort of one of the main benefits of the Polarix study was the randomized double-blind placebo-controlled trial. And this was certainly when NICE in the UK has recently funded this approach. There was a big emphasis on the fact that we have got a randomized blinded study. And patients with the inclusion criteria is listed there, 18 to 80, with an IPI of 2 to 5 and a performance status of 0 to 2, were randomized to Pola-R-CHOP compared to Pola-R-CHOP, but they're placebo, so it was blinded and we didn't know. I recruited patients into this study. I still don't know which arm they were in. It was stratified according to IPI, so 2 versus 3 to 5, and also bulky disease with bulk considered at 7.5 centimeters. So it's really important before we change practice that we look at the groups, because even in a randomized study there is chance that that actually the groups aren't balanced due to chance alone. Good numbers, over 400 patients, and the groups were well balanced. And you can see here with important risk factors such as IPI, such as bulk. You can see that stage and extranodal involvement were also balanced, as were the biological subgroups. And I think that the biological subgroups is something that we are understanding more and more, but we still have work to do so that we can really select the highest risk patients so that we know in the future how we can optimally treat them. So the endpoint, investigator-assessed progression-free survival, showed at 2 years a 6.5% improvement in progression-free survival. And I think it's really important to look at what that means, because we know, and I'll show you, there hasn't been an overall survival difference, but we know that because of the fewer relapses, fewer patients in the Pola-R-CHOP arm needed subsequent lines of therapy. And I think that this is, to me, what's important, because when I'm thinking about data for my patients, I always would ideally like to see a survival benefit. Have we not seen that because we have more successful subsequent lines of therapy? Have we not seen that because it's too early? I'm not sure, but what I do know is that I don't want my patients to have to go through second line and subsequent therapies for diffuse large B-cell lymphoma, because we know that for many patients it's high dose therapy and a stem cell transplant, which is one of the most toxic treatments that we give. And you can see here the differences in patients who required subsequent therapies. The subgroup analyses, so again, there's been a lot of discussion about subgroup analyses, but this wasn't powered to look at the subgroup analysis. So although patients who were older and male and no bulk did have an improvement and higher IPI, this didn't reach statistical power. You can see the confidence intervals all overlap. So there is no overall survival difference, and this is important. But as I said, we do need to think about what the subsequent therapies mean to our patients. And the really important thing when we've got a PFS benefit, which is clinically meaningful, but we need to make sure that we aren't giving our patients more toxicity, because when there has been no survival benefit shown, if we'd have seen significant toxicity differences between the arms, for example, one arm needing the patient to be in hospital for a significant duration of time, I think I would be less inclined to have used this new approach. But we can see that actually there's similar safety profile, slight increased risk in febrile neutropenia and diarrhea in the Pola-R-CHOP arm. And there were also data showing there was an increase in peripheral neuropathy of significance. So I think that this is important. And to me, this is important that it was a blinded study so that we know that there was accuracy in describing these AEs. With further follow-up, there was a PFS benefit of 7.7%. This was presented at ASH a couple of months ago, and there is no overall survival benefit. So can we improve on R-CHOP21? I think that we've seen PFS benefit with Pola-R-CHOP. I think we've seen intriguing benefit in a subgroup with the addition of bortezomib, but because of the practicalities of real-time gene expression, that isn't an approach that we're using. And in the UK, NICE has now funded a few weeks ago Pola-R-CHOP, so for our patients, that is now our standard of care if they met the POLARIX inclusion criteria, so fit enough for full dose R-CHOP, aged 18 to 80, and IPI 2 to 5. Now, what about these high IPI patients and these double hit lymphoma patients? And I have to say, over the last 10 years or so, my practice has changed depending on the data that we have coming through. And I do think that there probably has been some element of reporting bias for some of these subgroups. So first of all, we know from another great randomized trial from the Alliance group that patients, all comers, there is no benefit of DAR epoch compared to R-CHOP. But within this study, there were two small groups of these high-risk subgroups to really comment any further. But overall, we know DAR epoch is more toxic and R-CHOP just as effective. So for these high IPI groups, again, we've seen some encouraging data suggesting the use of intensifying regimes. In the UK, the R-CoDox-M-IVAC study showed an impressive 2-year PFS for a very high-risk group of patients. But again, the toxicity of this is high, with actually treatment-related deaths in the poorer performance status patients over the age of 50. So in the UK, there are a few centres that do use this R-CoDox-M-IVAC approach for high IPI patients. I don't use it because of the toxicity and because it's sort of small phase 2 data. And I think it'll be interesting to see if physicians now move to Pola-R-CHP in the groups of patients they would have given CoDox-M-IVAC. I do think that CoDox-M-IVAC has an advantage of CNS prophylaxis within it. CNS prophylaxis is another whole can of worms and will be a talk in itself about the optimal approach to this. But my practice for high IPI disease is to treat them actually as I would a standard risk patient. And this is also true for double hit lymphoma. So 10 years ago, I was intensifying these patients. And in fact, I did even allo a couple of patients up front. Fortunately, they are still alive and well because now I've seen more subsequent data. I've moved away from intensifying these patients. And I think that's because we've seen, I've just listed a few of the data sets there, that we've seen some data suggesting that intensification is important, but there is selection bias in some of the patients that are intensified. And when we look at the retrospective Flatiron data, and there are other retrospective series, again, showing that there's no benefit with the intensification. And with this equipoise in data, and knowing that DAR epoch is more intensive with many patients requiring inpatient stays and late effects associated, my standard practice for double hit patients is to use standard of care, which up until 3 weeks ago in the UK was R-CHOP, and now it's Pola-R-CHP. I do think that if you are going to choose to intensify these double hit patients, it's important that you know the immunoglobulin partner gene, because it's only those patients where the MYC is translated to this partner gene that are associated with a poor prognosis. Actually, the patients who don't have an immunoglobulin partner have a standard risk prognosis. So you do not want to expose those patients to the increased toxicity. So again, I think that, there is debate about this intensification of patients up front. And I don't think that we have enough data to truly say if some centres' approach is right or wrong. My conclusion of the data is that I just still use a standard approach. But if someone is using an intensive approach, it is important to know the MYC partner gene. So again, I think over the years, we've wondered about the benefit of consolidating with autologous stem cell transplant. Again, a very toxic procedure, and we are learning more and more about the late effects of auto. And there certainly is more and more late effects data being published and presented. So we saw with a SWOG study that there was a PFS benefit, but no OS benefit with an auto. So again, if we're not getting a survival benefit and there is marked increase in toxicity, you could argue whether this is the optimal approach. And another meta-analysis showed that there was no clear value in upfront auto. So my personal approach is that I don't consolidate even the highest risk patients with auto. And I do think that if it's going to be done, it needs to be done within a clinical trial setting. I briefly want to mention the GAINED study because I think that these data are intriguing, and this does use an intensive approach. It is only phase 2 data, and really the initial study design was to look to see if the addition of obinutuzumab with this approach was superior to rituximab. And the outcome, as we've seen before, is that obinutuzumab as an antibody in high-grade lymphoma is not superior. But the reason I wanted to show this to you today was that I think that the PFS from this whole cohort is impressive. And I think, again, we are going to need to understand how and when we use interim PET therapy to guide our treatment response. When is the optimal time to do the PET? And at which time point do we know that our patients aren't responding adequately so that we can intensify that group of patients to improve the outcome? And certainly in our UK research groups, that's what we're looking at, interim adapted PET studies, also looking at the circulating DNA response as well. Because maybe the future will become like Hodgkin lymphoma, where we can risk adapt our approach so that the patients that are going to do well anyway, we can give them standard of care, whether that's R-CHOP or Pola or CHIP, whether we can reduce the number of cycles they need to reduce toxicity. And yet those patients that aren't getting a PET response at the correct time in their treatment and aren't clearing their circulating tumour DNA at a correct time, that it's those patients that we need to think about intensifying. And this is why I do think that this study is intriguing. So patients randomised, as I've said, to the obinutuzumab or rituximab. Now in France, they actually give quite a lot of ACVPP. In the UK, we stick to CHOP. They have shown a benefit with their approach with ACVPP, but it is toxic and we've found it too toxic. Patients are given 4 cycles of either CHOP or ACVP with their antibody of randomization. The centres were elected which their approach would be, so there would be a CHOP treating centre or an ACVP treating centre. And then they would have a PET scan after 2 cycles and then again after 4. Now, in the patients who achieved an early response after 2 and remained in response after 4, they just completed therapy. So just focusing on the CHOP-treated patients, they went on to have a total of 8 cycles, so 4 more. As I said at the beginning, now we all would agree that 6 is adequate, but at the time of starting this trial, there were some centres that still used 8 cycles. If they were in the ACVBP group, then their consolidation approach was with methotrexate rituximab as listed there. But the ones I want to focus on, because it more mirrors my approach, is the R-CHOP treated patients. Now, if patients were PET2 negative, PET4 negative, their 2-year PFS is 90%. So that's good, and that's what we would expect picking out good risk patients. If the patients were PET2 positive, PET4 negative, then they went on to receive high-dose methotrexate and a beam autograft. And if they remained PET positive, then they went on and had high-dose second-line therapy. So it's listed here as salvage therapy. I do a lot of work with Lymphoma Action, our patient support group in the UK, and patients don't like that word salvage, so I'm trying to remove it from my vocabulary and use high-dose second-line therapy. And for these patients who are high-risk patients, PET2 positive, PET4 negative, 84% PFS. The patients who went on to receive high-dose therapy, so the PET4 positive patients, had a 62% PFS at 2 years. So a couple of points. We all need to be more uniform about our interpretation of PET. So whether we're using a Deauville score cutoff or 4 and 5 as positive, I think that's helpful if we're using a similar approach. With this, it was looking at delta SUV, so change in SUV. But this did mirror a similar Deauville positive. So I won't adopt this practice as yet. This is still early data, but it is just showing us that PET-adapted selection of patients, I think, will be part of our future management. So any benefit in consolidating with auto? No, not outside of a clinical trial. Now, what about less fit or older patients? Now, this could be a whole talk in itself, and so I've really just got a couple of slides to summarize it, because I know that we want to make sure that there's good time for questions and discussions about all these controversial areas. I think that one thing that is really difficult is this functional assessment. And when we look at data for older patients, it is so heterogeneous. I see 90-year-old patients who are cycling 10 miles a day, and other 90-year-olds who can't leave the house and need assistance with all of their comorbidity, with all of their functional requirements, and have a high comorbidity index. Also know that to do a full functional assessment, it takes time, and we're all doing busy lymphoma clinics, so many of us do an end of the bed assessment to decide how fit our patients are. I think it's really helpful to give a steroid pre-phase if patients are older and their performance status is above 2. And this was shown in many data sets, but particularly from the German group, that you can improve outcomes by giving this steroid pre-phase. And then there's a lot of discussion about R-CHOP or R-mini-CHOP. And again, there's been quite reproductive data showing that actually when patients are over the age of 80, and obviously we think about biological age rather than chronological age, the outcomes seem as good with R-mini-CHOP compared to R-CHOP, and it is much better tolerated. So my standard of care for these older patients, which generally tends to be over 80, is that I would give them R-mini-CHOP. These patients wouldn't have been eligible for Polarix anyway, so I won't give them Pola R-CHOP or give them dose-reduced Pola R-CHOP, because that was outside of the study. It's important that we assess cardiac function because of the anthracycline, and if patients have a reduced cardiac function, then my approach would be to give them R-CGVP, and this was following UK data published by Paul Fields. And again, over the last few years, I think we're really understanding the importance of bone protection, as well as GCSF prophylaxis, which I would give as standard to all of my patients. But for bone protection, we know, and this has been replicated in other publications, and we've audited our data in Newcastle, and we found a similar cumulative fracture incidence of nearly 12% in patients who are receiving a significant amount of steroids. And so now my approach following these data is to give bone protection. So we give calcium, vitamin D, and weekly alendronate for patients who have certain risk factors, which include age or previous factors, previous bone fractures, or bony involvement of their lymphoma. And I'm really hoping that we can try and reduce this, because this is associated with huge amounts of morbidity for our patients if we don't protect their bones. And then just in the last 5 minutes or so, what about the role of radiotherapy in diffuse large B-cell lymphoma? And again, we have long debates in our MDT about the optimal approach and when we should use radiotherapy. And the MDT is such an important forum, and we are having our clinical oncology colleagues in that MDT is essential, as well as my PET radiology colleagues. So really we need to think about the use of radiotherapy in early stage DLBCL, as well as when we should use it for consolidation for more advanced stage DLBCL. So we've known now for more than 20 years that if we have a patient with limited stage disease, we can give them combined modality therapy. So 3 cycles of CHOP, we would now give R-CHOP, as stated, you have to have advanced disease for the Polarix approach, so we still would use R-CHOP and radiotherapy. And this showed that actually it was improvement because less toxicity in PFS. And we've seen now from many early limited stage studies that there is this later relapse that we are seeing, and it feels like it might be a different biology of disease, but many patients tolerate a combined modality approach. Now that we have PET scanning and functional assessment so we can really truly understand if there is disease activity or not, I think practice changed with the presentation of the FLIER study. The important thing to remember about the FLIER study is that these are very good risk patients. So you can see here that they were age-adjusted IPI of 0 with limited stage disease and no bulk. But these patients were randomized to 4 or 6 cycles of R-CHOP. They could stop at 4 cycles if they were PET negative after R-CHOP. In the study, they did have 2 further cycles of rituximab, but I think that many of us have adopted this approach and do not give these extra 2 cycles of rituximab. And you can see here that it's a non-inferior approach, and you're able to drop 2 cycles of R-CHOP. And then this was sort of not PET, the FLIER study is not PET guided in the sense that all patients received 4 cycles and then had their assessment. But Daniel Persky presented these data a few years ago at ASH using a PET guided approach. So again, if patients were PET negative after 3 cycles of R-CHOP, then they could go on and have a 4th cycle of R-CHOP with excellent outcomes. If they were PET positive, then they had radiotherapy and Zevalin. As I said, the FLIER study had very good risk patients in. These patients, the majority of them had a stage modified IPI of 0 to 2, so still good risk. And 40% of them had extranodal involvement. Now, extranodal involvement, I think, when we're thinking about early stage disease, is difficult. And it's difficult because there are mixed data, and extranodal disease is so heterogeneous. So some people consider tonsillar disease as extranodal, and it's published as tonsillar disease. I consider that as nodal, whereas comparing that to bone or breast, obviously testicular, we manage differently. So there has been a retrospective data set published by Memorial Sloan Kettering suggesting that extranodal disease patients do have an inferior outcome. So although many of these studies did include extranodal disease, because of the heterogeneous nature of these patients and the small subgroups within them, I think we do need to assess that on a case-by-case basis. And for many of my patients with extranodal disease, I do treat with the full 6 cycles. Now, Canada's retrospective data is always helpful. They always have fantastic database and publish really helpful real-world data. And they've used a PET-guided approach for many years. And if their patients were PET negative after 3 cycles, they would go on and just give them a 4th. And if they were PET positive, they would have radiotherapy. What they showed again was that they had quite good risk patients, with the majority being stage modified IPI of 0 to 2 and half considered extranodal. But as I've said, that was many different subtypes. And really good outcome if patients are PET negative. So I think that that's quite convincing that with this approach, with higher risk patients that are in the FLIER study, we may want to avoid radiotherapy in these patients. It's disappointing the outcomes for the PET positive, and I think that we still optimally don't know the approach for these patients. And as standard, I tend to give them a full 6 cycles of CHOP and then consolidate. So in the MDT, we need to think about individual risk, because for some patients, a further cycle of R-CHOP can be more toxic for them than radiotherapy. So for some patients, I would prefer to continue with my combined modality approach. If they've got groin or axillary disease, I would rather that to reduce their anthracycline exposure. I think we need to think carefully about risk. As I've said, most patients in these studies had a modified IPI of 0 to 2. And I think that if they're not tolerating full dose R-CHOP, then we can't give them fewer cycles. And then just to finish off, again, 10 years ago, we used to consolidate every bulky patient, so considered as more than 7.5 centimetres in our centre, with radiotherapy. And this was following the Unfolder and the Recover 60 study. But again, now that we've got PET-guided therapy, we've seen data from Optimal 60, which was just looking at older patients, but if they achieved PET negativity, then they did very well without radiotherapy. And there's been a meta-analysis suggesting that there's no benefit if bulk. So I think we don't have a randomized prospective trial for this. So I think we need to do this on a case-by-case basis. For the majority of my patients now, if they have bulky disease and achieve PET negativity, I don't consolidate them unless my clinical oncology colleagues feel that actually the site of disease is a very low risk site to consolidate. Again, the Canadian data have confirmed this as well, showing that radiotherapy is, if patients were PET negative, had as good an outcome as those who didn't have radiotherapy. And another really important point is that those patients who were PET positive on that bottom slide here, if they have radiotherapy, you pull that curve up. So now in the MDT, my patients who have sites of PET positivity at the end of our CHOP, we will be quite aggressive with the radiotherapy because I do think that we go on and cure patients by consolidating sites of PET positive. So I use a PET adapted approach to consolidation. So this is to summarize the role of radiotherapy. So PET guided approach for limited stage disease, and for consolidation tend to trust the PET unless it's thought to be very low risk, and occasionally we will consolidate. But if they're PET positive, really do try and give that radiotherapy. So 5 important questions. I think I've summarized them all there, and I'm happy to take any questions.
Okay. Thank you so much for your nice presentation. I have one question for you, Professor. You told us about bortezomib in ABC, it increase overall survival. Is this the standard of care with you in your practice? And when we use this bortezomib in ABC?
Yeah, so we were all very surprised, even in the UK, and it was our data when these were presented in December. And we don't use that. And the reasons that we don't use that is because these data were using real-time gene expression profiling. So it was only patients who had ABC identified on gene expression profiling, which is not deliverable in the UK. And the other main reason is that when we've looked at, as we know, bortezomib now, this was a academic study, so there's no license for us to use it in this setting, and there's no support to put this forward for license. I do believe that if we'd not seen such a positive outcome from Pola-R-CHP, we might have taken this forward further. And certainly, if we can get more access to real-time gene expression profiling, then we might have taken this further. But at present, this is of academic interest, and we're not using that clinically.
Thank you so much. Is there any question? Please.
Yeah, thank you very much, Professor. Very nice talk. I looked at the study that you presented, the GAIN study. It's a very important and good study to evaluate obinutuzumab versus rituximab. But looking back on the induction backbone, using ACVP and R-CHOP, little bit mixing the results, I would say. So if you get back to the French data using the ACVP, it was, yes, I agree, there is a benefit in progression-free survival and overall survival, but inclusion in the induction part, both chemotherapy regimens, probably, I would say, probably would mix the results of this study. What do you think about it? What do you comment about it? Thank you very much.
Yeah, I completely agree. And I think that we see when they've sub-analyzed just the R-CHOP or the O-CHOP treated patients, they did still have a better outcome than we would have expected in this higher risk population. So They felt when they were opening the study, because the standard of care in France is different, that many centres wouldn't have opened it if they'd been encouraged to use only R or O CHOP. So I don't, and I won't use their approach, but what I do like about their approach is using this PET-guided, PET-adapted approach, because we know that if patients get an early PET response, that is going to pick out the better responders and a better risk group. We also sometimes understand now that PET after 4 is probably even more predictive. In the UK, because it's not changing my practice, I don't do an interim PET. I do a midpoint CT. I want to save my resources for where PET changes my management. And PET changes my management at baseline if I'm thinking about my CNS IPI calculation. And it changes my management at end of treatment to try and get those PET positive sites to have some radiotherapy. So interim PET, I just do a CT. Some centres do a PET, but it doesn't change management. So in the UK, it's £1,000 for a PET. So I just use a standard CT midpoint. But if we understand from approaches like the GAINed study, and that's certainly what we're trying to develop in the UK, that we can do a PET-guided approach. Wouldn't it be fantastic if we can get outcomes like in Hodgkin lymphoma, where we get that PET-guided approach, we can limit the toxicity for the good risk, we can intensify for the high-risk patients using our knowledge of PET scanning.
Thank you.
Last question. I will include my
Thank you, Doctor, for this nice presentation. My question is about double and triple hit. Should we give more intensive chemotherapy initially, or should we even test for the C-MYC or not? Because it's a very expensive test, actually. So in your
yeah. So again, we have argued a lot about this in the UK. We do test it because it's now part of the WHO diagnostic criteria that we have a high-grade B-cell lymphoma with translocation of MYC and BCL2. So they've reduced the importance of BCL6. Probably about 8 years ago, we did it on everybody because it was changing our treatment. And I spent probably 2 years giving these patients DAR-EPOC until, it feels like every time there's a new publication, I change my mind, and I do think that I over-treated some people. If it is expensive, and if it's not changing your treatment, then I wouldn't personally have a problem with not doing the test. I believe I work in the National Health Service and we've got certain resources. The reason that we do the test is because the pathologists say, because it's in WHO criteria, that's why we need to do it. It's also really helpful that it's our standard of care test, because we need to know this for all of our clinical trials, because it's part of the risk stratification, and therefore it isn't excess research costs because it's our standard of care. I personally don't do intensification. I think 4 or 5 centres in the UK treat these patients with DAR-EPOC. I can't stand here or sit here and argue that's wrong because the data aren't clear, but my interpretation is that I use standard of care. So for these now, I would use Pola-R-CHP.
Okay. Thank you, Professor Wendy, for this comprehensive tour. You covered many areas in non-Hodgkin lymphoma. We are very thankful for you, and goodbye.
Thank you very much. I wish you all well.
Good evening. Today we have Dr. Robert Klamroth. Dr. Klamroth, he is a head of Department of Internal Medicine and Biology and Coagulation Disorders and the Director of Comprehensive Care Hemophilia Treatment Center and the Hemostasis and the Thrombosis Unit at the Vivantes Clinicum in Germany. He holds specialist training degrees in internal medicine, angiology, and hematology. He is the current president for the European Association of Hemophilia and Allied Disorders and holds membership of various national and international societies in the field of angiology, thrombosis, and hemostasis. He also serves as a vice president at the German Society of Thrombosis and Hemostasis. Dr. Klamroth will talk about the role of factor 7, activate factor 7 over 7 in the congenital hemophilia with inhibitors. Dr. Klamroth, please.
Yeah, thank you very much. I hope you can hear me clearly. And thank you for the invitation to your Congress. It's now a total different topic, and I will share my screen now. And I hope you can see my slides. So it's about the on-demand treatment of heptacoag alpha and congenital hemophilia with inhibitors. And first of all, I will share my disclosures, different companies who are all working in the kind of coagulation. It's mainly for research and for giving presentations. So I will talk a little bit about congenital hemophilia and inhibitor development and why this is an important topic still, and about recombinant factor 7A for the treatment of bleeds, and I will present 2 clinical cases for you. First of all, hemophilia. I think you all are familiar with hemophilia. It's a recessive X-linked bleeding disorder, most commonly caused by genetic mutations, more often in factor 8, 80%, and rarely 20% in factor 9. This is hemophilia B. And there are approximately 1 in 5,000 males who are born with congenital hemophilia. In my experience, it's about 50%, at least in hemophilia A, where spontaneous mutations occur and the disease is not known in the family. The bleeding severity correlates very nicely with the residual clotting factor level. So we have severe hemophilia, where you have no factor 8 or factor 9. Normally the diagnosis is very early. Patients have a severe bleeding tendency. Bleed locations are mainly the joints. And if you don't treat the disease, patients have at early age joint disease. Moderate patients with a residual activity of 1 to 5% of factor 8 or 9. Normally the diagnosis is a little bit later. The bleeding tendency is heterogeneous. So there are moderate patients who have spontaneous bleeds and need a prophylactic regimen, and there are moderate patients who only bleed when they have an injury or a surgery. In mild hemophilia, normally there are no spontaneous bleeds. Patients bleed when they have surgery or severe trauma, and there's a certain variation in those patients. Normally, severe patients are diagnosed very early in life. Moderate patients are diagnosed in childhood. In mild patients, sometimes diagnosis is later in life, and these patients could be underdiagnosed. So the usual treatment of these patients is to replace the missing clotting factor. So in hemophilia A, we replace factor 8, and in hemophilia B, we replace factor 9. But unfortunately, patients can develop an antibody, an inhibiting antibody against this factor 8 or factor 9, and that we are calling inhibitor. They are alloantibodies directed against the replacement factor 8 or factor 9, and they neutralize the activity of the factor. So treatment is more difficult. Patients with inhibitors are on a higher risk to have bleeds and develop long-term joint damage. And the reason is that the bleeds are more difficult to control because we cannot use factor 8 or factor 9, and there's more uncontrollable bleeding, and they have normally a lower quality of life. Why do patients develop inhibitors? And the immunological mechanisms are still not clear. So there are a variety of mechanisms, and the development, of course, is that if you have an inhibitor, factor treatment is ineffective. We look now at risk factors for inhibitor development. The genetic background is probably the most important part. The severity of hemophilia, the underlying mutations, and the mutations where no factor at all is produced, the so-called null mutations, and higher inhibitor risk than missense mutations. Patients with a family history of inhibitor, of course, have a higher risk to get an inhibitor again, and there is a correlation to ethnicity and to some kind of immune response genes. It's a big discussion about environmental factors, type of product, if you start with prophylaxis, if you give peak treatment moments in surgery early in life, if the immune system has other challenges. What we know is that these inhibitors normally develop in the first 20 treatment days or first 20 exposure days. And the mutation, and normally that's standard of care in most countries, to look at the mutation who is causable for hemophilia, because that is the best prediction for the risk of inhibitor development, and null mutations have a high inhibitor risk, missense mutations a lower inhibitor risk, and there's a huge variation about the probability to develop an inhibitor depending on this mutation. There was an ongoing and long discussion if a specific product is better or has a lower risk of inhibitor development. So some older plasma-derived products we had an hint that there might be a lower inhibitor development. All in all, if we look at all published evidence and cohort studies, there is not a big difference. All the difference is quite small between plasma-derived and recombinant products. What I think it's a little bit more reliable is if we start treatment with very high doses very early in this period of the first 50 exposure days, then we provide a danger signal there might be a higher risk of inhibitor. So prophylactic treatment with the clotting factor concentrates is at least one thing we could do to avoid inhibitor development. Look at the prevalence. Hemophilia A has a higher inhibitor development than hemophilia B. It's normally about 20 to 30%, depending on the cohort you selected. It starts in the first 20 exposure days, up to 50 exposure days. Above 100 exposure days of factor concentrate, it's very unlikely to develop an inhibitor. So you can see it at least in severe hemophilia A, normally the inhibitor development is in the first years of life. It's very rare that patients who are previously treated, so-called PTPs, develop an inhibitor later in life. There's some recent data for hemophilia B from the PETNET study. That is a large European cohort study about children with hemophilia. That in hemophilia B, maybe we underestimated the inhibitor risk a little bit, and it's more 5 to 10% if you look at all patients. There was a publication from Charlie Hay from the UK data that there might be another peak later in life. And they looked here at patients with inhibitors dependent on age. And of course, the highest risk is in the younger cohort when we start treatment below 5 years. And there might be another peak in patients over 60. This was not confirmed in a study we did lately across Europe. And my impression is that if you keep patients on regular prophylaxis, and they don't develop an inhibitor later in life. But earlier on, there were a lot of adult patients with on-demand treatment, and when they have a longer period without getting factor VIII, there is another risk if they get a surgery or a peak treatment moment that they develop an inhibitor. So nowadays, with most patients, at least in the European countries and in the US, staying on prophylaxis throughout life, there is no higher inhibitor risk later in life compared to adulthood. So what is the consequence? And if you look at all studies, we can treat hemophilia with a prophylactic treatment with clotting factor concentrates very well, but patients with the development of an inhibitor against factor VIII or factor IX, they have a greater need for adaptive devices. They are more frequent in hospitals. And you can see here that the percentage of patients who had consequences for daily life, like immobility, self-care, daily activities, pain and discomfort. And it's the dark blue and light blue are the patients with inhibitors. It's much more, they are much more affected than the patients without inhibitors. So because we want to discover inhibitors as soon as possible, there's certain tests recommended, and the intervals is if you start treatment in children, you should test the first 5 exposure days until the 20th exposure days, so every 5 exposure days. Then you until the 50th exposure days every 10 days, and when the children have more than 150 exposure days, you can do it 2 times a year. And we recommend at least that adults with above 150 exposure days should be tested every year if they're an inhibitor or not an inhibitor, and we use the Nijmegen modified Bethesda assays. Of course, if there are some clinical failures, like patients doesn't respond to the clotting factor concentrate, or if patients have a surgery, then we should do an inhibitor testing in between. What is essential? And you all know, if you have a bleed, independently with or without inhibitor, if you have a bleed, and especially a joint bleed, you should treat as early as possible. Ideally within the first 2 hours after the onset of the bleed, because if you have a rapid bleeding control, you have less joint damage. Yeah? So it's essential to control the bleed as early as possible in order to avoid joint damage. Of course, inhibitor patients where treatment is more difficult have a higher risk to develop joint disease. And so wherever you are, early treatment of bleed is good in order to lower the consequences of a bleed and joint disease. So here's to summarize what is the benefits of early treatment. It's reduced joint damage, reduced complications. Of course, patients have pain if they have a bleed in the joint, and you reduce this pain if you start early treatment. You can patient mobilize, and of course, and I will show you that, if you start early the treatment of a bleed, then you reduce costs because you need a lower amount of factor concentrate until the complete resolution of the bleed. In patients with inhibitors, we cannot use factor 8 or factor 9. So we need bypassing agents to activate without factor 8 or factor 9 the coagulation system. And we have 2 products. It's recombinant factor 7A and plasma-derived APCC. APCC is, as I heard, not approved in Jordan. So the first choice for patients with an inhibitor against factor 8 or factor 9 is recombinant factor 7A. And now I will talk a little bit about the recombinant factor 7A for the treatment of bleeds in patients with congenital hemophilia and an inhibitor. So it's a recombinant product not derived from human plasma. There's no risk of transmission of any viruses. And at pharmacological concentrations, you all are familiar that recombinant factor 7A directly avoids factor 8 on the surface of activated platelets. And I will show you a little bit more about how beta-cork alpha is working in this cartoon. So if you have an injury, factor 7A works locally at the site of vascular injury in conjunction with tissue factor, and there are activated platelets. Binding to factor 7A with tissue factor, you have an initiation of coagulation. There's a small amount of thrombin which activates platelets. Now, and on these activated platelets, this high doses, pharmacological doses of recombinant factor 7A directly activates factor 10 on the surface. And there's a thrombin burst, and this thrombin burst is leading to a stable hemostatic clot, and which controls the bleed. So recombinant factor 7A needs only, of course, platelets, and it needs some substrate to generate thrombin and to build a stable clot. So recombinant factor 7A is licensed and there are two different dosing regimens that can be recommended. So you can give 2 to 3 injections of 90 microgram per kilogram body weight at a 3-hour interval. If further treatment is required, you can give an additional dose, or you can give one single injection of 270 micrograms per kilogram body weight. The second dose is widely used in Germany because in Germany, patients with inhibitors who have a bleed are on a home treatment. And of course, if you're on home treatment, one injection has an advantage against 2 or 3 injections concerning the intravenous injection. But concerning effectivity, both is the same. And if you treat in hospitals, of course, you can give this dosing interval of 90 microgram per kilogram body weight every 2 hours. So there are a lot of studies where recombinant factor 7A shows effectivity in the treatment of bleeding episodes in patients with inhibitors. And usually the starting dose is 90 microgram per kilogram body weight. And you can repeat this dosing every 3 to 4 hours. Here are the key publications over the years and different studies. In dose regimen was 3 times or up to 3 times 90 microgram per kilogram body weight. There was a lot of different kinds of bleeding, joint bleeds, other bleeds, and you see there is a success in these studies about 90% to control a bleed in patients with hemophilia and inhibitors. So, I told you already that early treatment is really important, and that's especially in patients with inhibitors. Because if you treat early, you control the bleed early, you minimize the damage. And if you compare now when the bleeds are treated, you see it very nicely here, the efficacy across the 3 independent studies. So if you treat the first hour, you normally need only 2 or 3 injections. 2.2 injections in 90% of the cases were enough to treat the bleed. If you start later, after 9 hours, you need more injections. And if you don't start immediately, if you wait days to treat the joint bleed, you need much more injections. So early treatment is not only beneficial for the patient to control the bleed, it saves you product because the bleeding stops earlier and you need less Mo7. Here the same, it's in the study it was home treatment and has demonstrated regardless of bleed severity. But again, it's very effective in our patients across all kinds of bleeding. And if you initiate treatment earlier, 0.6 hours, you are much more effective if you start treatment later. Because in this study, again, where effective treatment was initiated after 0.6 hours on average, and if treatment was not effective, then it was usually initiated later. So again, if a patient comes to a hospital, treat him immediately, then you save product and you are more effective. Of course, there were some new trials, and the last trial about safety and efficacy of recombinant factor 7A was a SMART-7 trial, and they wanted to include more than 40 patients, more than 25 exposure days, and the primary objective was to monitor prospectively if there was any decreased therapeutic response or development of neutralizing antibodies towards eptococ alpha in this trial. And in this trial, in the end, 51 male patients with congenital hemophilia A or B with inhibitors were included. 31 completed the trial, and the study was finalized. All in all, there were 1,415 patient drug exposure days. There were some adverse events. There were some serious adverse events and some medical events of special interest. But if we look at what we are most interested in, there were no positive factor 7 binding antibodies. That's reassuring. And there were no thromboembolic events. So the drug was safe. And was it effective? And if you look at effectiveness for all bleeds treated in this trial, can see here that the effectiveness was above 90% in most of the cases, especially if patients were treatment was initiated very early. You see it here again in this trial that if you start within the first hour, you have the highest efficacy. If you start between the first and the fourth hour, still you have efficacy above 90%. But if you start later than 4 hours to treat the bleed, efficacy is only 87%. So again, it's always the same idea. Early treatment is more effective than later treatment in these patients. In the European countries and in many countries now, Emticizumab, a bispecific antibody, is licensed for prophylaxis in patients with hemophilia A and inhibitors. And this is very effective to avoid any spontaneous bleeds, but patients with Emticizumab still have traumatic bleeds or need surgery. And so it's of great interest, and there was a lot of fear that there might be a thromboembolic risk if you give additional clotting factor concentrates to patients treated with Emticizumab. That was especially the case if you give APCC. And so there was a study to look at if we combine recombinant factor 7A with Emticizumab in the Haven studies. And was 181 patients with hemophilia A and inhibitors included in the Haven studies, and 61 of them were on Emticizumab prophylaxis and used recombinant factor 7A for one or more events to stop or prevent bleeding. And in total, 210 bleeds were analyzed in this guide. And there was some guidance because before the guidance, patients, there was a recommendation: treat bleeds as usual. You treat it without Emticizumab, and after some thrombotic events, mainly with APCC, there was a guidance to using the lower doses. If you look here now at these bleeds, which initial doses were used, and you can see here that most patients had an initial recombinant factor 7A dose of 100 plus minus 20 microgram per kilogram body weight in the majority of cases, and that was more or less the same at any time. What you can see that before the new guidance and before the thrombotic events with Emticizumab, there were 23 patients who used the high dose, which is very popular in German, of 260 microgram per kilogram body weight. This was not the case, and that's the middle after the new recommendation, where most people used the regular dose of 90 micrograms per kilogram body weight. The dose interval was about 2 hours. I tell you that most patients were treated a first dose and then a second dose after 2 to 3 hours. There was not a big difference here between before and after the new recommendation. And if we look now for safety, there were no serious adverse events. There were no case of thrombotic macroangiopathy or thromboembolic events, and no adverse events due to the concomitant dose of Emticizumab and recombinant factor 7A. And I can tell you from my own experience that we do surgery in patients with inhibitors on Emticizumab in addition with recombinant factor 7A regularly. And so far, from all the evidence in the real world, we have no hints that there is a higher thromboembolic risk if we use recombinant factor 7A in combination with Emticizumab. So in the end of my talk, I would like to present 2 clinical cases to you, which might be of interest to see how we use this in practice. I started hemophilia treatment in 1996, and we used in my hospital in 1997 for the first time recombinant factor 7A in a patient with hemophilia A and inhibitor. And I can tell you that was, for this time, it was a drug which makes a real difference to our patients. Because before it was very hard, treatment was not effective, especially in this patient. other treatment modality failed, immune tolerance induction was not possible, and with recombinant factor 7A, for the first time, we were able to successfully treat bleeds. And over the time, I used this drug mainly in patients with congenital hemophilia A and B and inhibitors, and in patients with acquired hemophilia, but that's the different chapters. On the other hand, in Germany now, all patients with hemophilia A and inhibitors are on a prophylactic treatment with Emticizumab, and then we use for surgery or for traumatic breakthrough bleeds patients, we use recombinant factor 7A, which is, from my point of view, we have enough evidence that this is a safe and effective approach. So the first patient is Hamza. He was born in Iraq, and the name and details are a little bit altered, but he was born in Iraq. He had his severe hemophilia B mutation was unknown. The diagnosis of hemophilia B was at the age of 2, and he came to Berlin in 2015 with a joint bleed in the left knee. Communication was very difficult at this time point, and it was clear, yes, he has hemophilia B, but the previous treatment was a little bit unknown, and the parents said there were some reactions after intravenous infusions of factor concentrates or whatever. So the first question is, you have a patient, severe hemophilia B, there was some problems with the treatment before. Shall we go for factor 9? Shall we go for immediately for recombinant factor 7A or tranexamic acid? So what we did, we started with a factor 9 concentrate. He tolerated it quite well, but measuring factor 9, there was no increase of factor 9 after the infusion of 50 units per kilogram body weight factor 9. And there was no effect on the bleed on the left knee. So we concluded there must be some kind of an inhibitor, and our second choice for treatment was recombinant factor 7A that has a good effect. We made it in the laboratory. We made the Bethesda assay and saw there was an inhibitor titer of 7 Bethesda units. And after more exploration and translation with the parents, we found out that Hamza was treated in Iraq with plasma-derived factor 9, and he developed some kind of anaphylactic reaction, and there was already the idea there might be an inhibitor development. And for the ones of you who are familiar with factor 9, you know that 50% of patients who develop an inhibitor against factor 9 have an allergic reaction to factor 9 too, with anaphylaxis and in some cases nephrotic syndrome. So we started an on-demand treatment with recombinant factor 7A, which has a good response, but Hamza was quite a high bleeder. So even with a successful on-demand treatment, she had 2 up to 4 bleeds per month, mainly in the left knee and in the left elbow. And then there was a urologic surgery necessary because he had an undescended testicle, so you cannot wait for the surgery. And we discussed a little bit, shall we try immune tolerance induction before surgery, or shall we do the surgery with recombinant factor 7A? And we did a quite successful surgery with recombinant factor 7A, but with a high bleeding tendency. We said, okay, we will do immune tolerance induction with immunosuppression up front. You may be familiar, and due to the sake of time, we have a German protocol with rituximab and MMF to do immunosuppression in those patients who had anaphylactic reactions to factor 9. This was successful in this case. He tolerated factor 9 very well. We could initiate prophylactic treatment, but he had 2 relapses of the inhibitor in 2019 and 2022, where we treated again breakthrough bleeds with recombinant factor 7A, and he got 1 infusion of rituximab again, and the inhibitor disappeared. At the moment, he's doing well. He's on a prophylaxis with an extended half-life factor 9, no breakthrough bleeds. But in his case, for surgery and for the treatment during the time of the inhibitor, recombinant factor 7A was really effective. Second patient is an adult patient. It's Georg. He's born in 57, had severe hemophilia A with a missense mutation, so normally a mutation where you don't expect an inhibitor development. And he was on demand treatment with recombinant factor VIII. He started his treatment at the age of 5 years with cryoparticipate, and he developed his inhibitor very late in life. And we had, even with his severe hemophilia A, he had quite a low bleeding tendency and kept an on-demand treatment. Then what I told you, which I think is the main cause if you develop an inhibitor later in life, is he had hip surgery, got high doses of factor VIII, and after the hip surgery, he developed an inhibitor with 40 Bethesda units. You know, in Germany, we normally do ITI in those patients, so he got at this time point 2 attempts. It was in 2001, 2 attempts of ITI. One again, his first failed with high-dose ITI with the Bonn protocol. Second was with rituximab, again no success. And he was on demand therapy with recombinant factor VIIa since 2006. And he was referred to our center in 2015 for surgery of renal cancer. And he had a low inhibitor titer with second Bethesda units. And you know, so renal cancer, big surgery, high risk of bleeding, and we thought with a low inhibitor titer, maybe we are able to do the surgery with the replacement of factor VIII. And so we started to give him factor VIII, and the problem was in this case too, he had a severe anaphylactic reaction after the injection of 100 units factor VIII per kilogram body weight. And so factor VIII was not possible, and we did a surgery with recombinant factor VIIa. And of course, in such cases, you want to do a prophylactic regimen, which was not possible in his case. And he had a low bleeding tendency, and he continued with on-demand therapy with recombinant factor VIIa. And he had surely a low bleeding tendency because he had 1 bleed every 3 months or every 2 months. But with the advent of emicizumab, we switched him in 2019 to emicizumab, which was very beneficial for his daily life because he was completely out of spontaneous bleeds. He's on emicizumab up to now. He had 1 traumatic bleed after a bike accident, which we successfully treated with only 1 dose, additional emicizumab with 90 microgram per kilogram body weight recombinant factor VIIa. And he had 2 additional major surgeries, again, a partial nephrectomy and a spine surgery. And due to the treatment with emicizumab, we just added recombinant factor VIIa for 5 days during the surgery, and he did very well without any bleedings. So to summarize, recombinant factor VIIa is an effective treatment for controlling bleeds in patients with hemophilia and inhibitors. Important from my point of view is early treatment, because early treatment results in a more rapid recovery with fewer injections. You can use recombinant factor VIIa for all bleeds, independent of the severity. And if you treat early, it's always beneficial for joint bleeds, for all kinds of bleeds. From my point of view, recombinant factor VIIa in congenital hemophilia with inhibitors has demonstrated an excellent safety profile and tolerability over the years in the studies and real-world evidence. And I think from my point of view, there's no change in the benefit-risk profile if you use recombinant factor VIIa as indicated in patients who are now on emicizumab prophylaxis. So thank you very much, and I'm happy to answer any questions.
Thank you very much for the nice presentation. It was comprehensive, cover almost everything about hemophilia with inhibitor. I want to discuss with you, I have a patient who has a congenital hemophilia with inhibitor, more than 10 Bethesda unit, is a large deletion, and he presented to me intracranial bleed. The things about this patient, if we give him like recombinant factor VII alone, he did not respond. He usually responds to give both factor VIII and recombinant factor VII together. If like give one of them alone, patients just come with recurrent bleed again. Do you see patients like this? You have to give both even with the inhibitor.
Yeah, so there are some tricky patients where recombinant factor 7A alone sometimes doesn't work. I think it's a good idea to give it in combination, even with inhibitor in combination with factor 8. And we had some patients where we need combined treatment. We had one patient where we need to combine APCC and recombinant factor 7A. What I suggest, and I don't know if you're familiar, is normally you are more effective. And what we are doing is we are using always the high dose in those patients if we are not successful with 90 microgram per kilogram body weight.
Thank you. Any questions? Thank you very much.
Yeah, thank you. It was a pleasure. I wish you a nice congress, and thank you for
the
invitation.
Good evening, everybody. First of all, I would like to thank Professor Sarida for joining us in our meeting. I would like to thank the organizing committee and the scientific committee, Dr. Abdullah Al-Abbada, Dr. Ghadir Abdin, for organizing such a grateful meeting. And again, I'm very honored to see you again, Professor Sarida. Just a few days we were in Orlando, and always we're happy having you in our meetings. Let me introduce Professor Sarida. She is nowadays the head of Clinical Oncology Department at Institut Catalana de Oncologia Hospital in Barcelona, and she had previously been a senior consultant in De La Santa Seri Santa Pau, Barcelona, and senior consultant focused on lymphomas and hematopoietic cell transplant in Cambridge University from 2010 to 2012. Professor Sarida has focused her career on clinical investigation into the treatment of Hodgkin lymphoma, non-Hodgkin lymphoma, and multiple myeloma patients evaluating novel therapies such as immunotherapy combined with the stem cell transplant. Professor Sarida was appointed as chairperson of the Lymphoma Working Party of the ABMT from March 2004 till March 2010, and secretary of the same organization since 2010 till 2016, and she was elected co-chair of the Lymphoma Committee of the CIBMT and has served the organization in this position from February 2015 till February 2019. She was subsequently appointed as a member of the large non-US transplant center and advisory committee of the CIBMT. And Ana Sarida is a president of the Spanish Society of Hematopoietic Stem Cell Transplant and Cellular Therapy from March 2022. And now Professor Sarida, she is the president of the ABMT, and she is a regular reviewer of several peer-reviewed journals, including the Blood Annals of Oncology, BMT Journal, and the Hematology Journal, and the European Journal of Hematology, Annals of Hematology, and has co-authored more than 14 publications. We were very happy having you, Professor Sarida, talking on a very important subject on the use of checkpoint inhibitors in relapsed classical Hodgkin lymphoma in the context of allogeneic bone marrow transplant. The floor is yours. You're welcome. Please.
So thank you very much for your kind invitation, and thank you very much for the introduction. And I would be very happy to share my presentation, but the problem is that I am having technical issues, so I will need somebody to help me.
Okay.
Yeah, please help her to
Would you
share
please
it.
check the share at the bottom of the screen? The share button down the screen. At the bottom
Yeah,
of the
this
screen.
is what I have. This is what I have been doing for the last minutes, but it asked me to open the preferences of the system.
Did you agree about the permission? Because it asks you at the beginning of the to make some permissions.
Yeah, you didn't share your slides, Professor Serena? You can close and reshare again.
Or accept the permission.
But the problem is that I cannot. Well, I mean, I'm trying to accept it, but it takes me to the accessibility of my Mac. So
Okay.
it seems that as if I don't have, let's say, the access from the Mac point of view to share my presentation with this WebEx.
Okay. Okay. Would you please just stop the sharing and make sure that your presentation or the PowerPoint is running at the background, and then press the share and start the process of sharing.
Okay, so the presentation is in my background.
Yes.
And then if I go to share.
Yes. Is it running at the background?
Well, it's not in full screen.
Would you please run it before the sharing? It will help you much faster. It will be. Just run it and then start the sharing process.
But I don't know how to start it without, let's say, stopping the presentation.
Did you start the PowerPoint?
So I am seeing the first slide. It's
Did
not
you
in
start
full
the
screen.
PowerPoint? Did you start it? The PowerPoint?
Yeah. So I'm seeing the first slide.
Yeah.
But and I can, of course, I can run over the slides.
Okay. Once you press
try,
the share, it will give you some blocks. So select the right block which you will open it.
No, the problem is that it seems that I'm not. So I don't have.
Is your PC iMac or PC, the normal PC?
It's a Mac.
طيب ممكن تبعت لنا البرزنتيشن ونعملها شير.
ممكن.
Can you send us a presentation and we're gonna list the slides upon your request? We can do that. We can help you. There is no problem. Can you send the slides?
Yeah, please.
Yeah, probably this is the best thing because I don't know how to share the slides.
Yes, that's fine. There is no problem. We can list the slides for you.
Okay, so let me do one thing. I close the presentation here. I'm so sorry. So
to info at Josh, the Joe.
So to whom I have to send this slide?
Okay, we will send it by
the chat. We'll send the email by the chat now, just to make sure this is the right email. Please send the email, please.
Yes.
Second, you will receive the email on the chat.
And the WhatsApp chat.
WhatsApp chat. And you may log on your WhatsApp chat. Yeah, you can see the email, Professor Serena? It's on the chat.
No.
Yeah.
No, I cannot see it. Oh, yeah, sorry.
Yeah, you received it, yeah? Yes, please, can you send the slides?
Yeah, I'll send you the slides right now, and then, of course, it's not the best way, but I think that this is the only way that it will be working. So.
غريبة شو المشكلة بتكون؟ Did you receive the slides?
Wait a second, I'm sending them.
Sorry, I think we've missed, we have a typo in the email. Could you please recheck the email again in the chat area?
Okay.
We've missed part of the email. Sorry for this.
So have a look on the last email.
Okay.
Yes, yeah, for
Yeah,
the
yeah.
for the chat, yeah.
Yes.
Recheck that again.
هلا هو قنا مين اللي راح يمشي على السلايدز؟ اعطيني اياهم قبل بشيلها اياهم. انت بتاع؟
Okay, I have just sent the email. Just let me know.
We've had it. Just a second.
Just a second, we're going to open the slides and you're going to start your presentation. Sorry for that.
Perfect. No, it's I should have. I think that I should have checked that I was able to.
As I'm saying, face to face is better than virtual.
Yeah, absolutely.
Yeah, that's it. شو عملتوا؟ لسه مش واصل؟ Can you again, we didn't receive your slides yet. Can you make sure the last email you received? Sorry for this. انت كان بعت لها الايميل مظبوط؟ The last email.
Okay, I'm going to send them again, but I did not receive any. I mean, any indication that the email was wrong.
Huh? From Webex invitation. Let's see.
I have just sent them again.
كيف تعمل معها كونتاكت على الواتس؟
طب على الواتس اسهل شيء.
إذا ما بعت لها الإيميل مش معقول. هلا فينا نسكر الهاي ولا نفتحها ولا؟ I understand بس ما هي كمان بعتها؟ Yeah, we send the email again second time.
At the chat area.
In the chat area, in the screen in front of you.
Have you received them?
It is info at. You see the slide. You see the email, Professor Serena?
On the chat.
Yeah, and I have sent it twice.
Send it. بس في شيء بالايميل غلط. info at ايه؟ هدول for it.org. info at احكيلها اليوم.
يا زلمة ما هي شايفيتها الشات، ما بيقول لك بعت على الايميل نفسه.
اعمل ريفرش.
اعمل ريفرش للايميل تبعك يا.
طب تقدر تبعته على الشات هي؟ طب send us على.
Could you please send your email at the chat area, your email, so we can reply to you, so we can verify the email.
Just on the chat, send your email. We're gonna send you an email, and you're gonna reply with your presentation.
Okay.
بعتها؟
هيها بعتها.
يلا ابعتها. ميك شور ان الايميل صح يعني مرة واحدة خلينا نعمل. بعتها؟ وصل؟ طب يلا اعمل شير للسلايدز.
لما شير عندنا هون
من عندنا واحد بس تقول لك next you list the slides. هاي شب يلا اعمل شيرنج للسلايد. Yeah, sorry for this technical problem. 1 minute gonna be solved, inshallah. Thanks for your patience. شو المشكلة يا شباب؟ يلا خلينا نشوف السلايد. أنا اللي لازم أعمل سلايد
عشان
طيب
تناقش
طب فرجينا السلايدات هذه. نقبل هذه نقبل هي. يلا شير هلا. كمان اعمل لي ايش هاي. Yeah, again, sorry for this technical problem, and sorry and thank you for your patience. We again, everybody know Professor Sarida, and I will not introduce her again. Let's go with your presentation, Professor Sarida. So the role of checkpoint inhibitor in the setting of allogeneic bone marrow transplant, the case of the classical Hodgkin lymphoma. I'm gonna list your slides, Professor. Please.
Perfect. So thank you very much, and really apologize for all these technical inconveniences that have delayed a little bit the program. But anyway, thank you very much for your invitation to participate in this meeting. And I would like to discuss with you the role of checkpoint inhibitors in the setting of allogeneic stem cell transplantation. And to do that, I'm going to use basically the case of classical Hodgkin's lymphoma, because it's the hematological malignancies where checkpoint inhibitors have demonstrated more effectiveness. Next slide, please. So here you have my conflicts of interest. Next slide. And I would like to start with a clinical case. This is a 35-year-old gentleman with no past relevant medical history. And this patient was diagnosed back in June 2014 of nodular sclerosis, classical Hodgkin's lymphoma, stage 2A, but with 2 adverse prognostic factors, high ESR and 4 lymph node areas that were affected. The patient was proposed to be treated with ABVD per 4 cycles by involved field radiotherapy for 30 grays, but unfortunately the PET-CT that was performed at the end of chemotherapy demonstrated progressive disease, and these lymph nodes were biopsied and they were positive for classical Hodgkin's lymphoma. Next slide. The patient was treated with second-line therapy with IGF per 4 cycles from January 2015 to April 2015. The patient achieved a partial remission with PET-CT and was consolidated with an autologous stem cell transplantation in July 2015. But unfortunately, only 3 months after the autologous stem cell transplant, the patient experienced first relapse with a stage 4 disease, B symptoms, and skin involvement. The patient was treated with Brentuximab Vedotin, our third-line treatment strategy, demonstrated progressive disease after 2 cycles. At that time, an HLA-identical sibling was identified. Next slide. The patient was offered nivolumab as 4th-line treatment strategy, achieved a partial remission after 12 weeks, a complete remission after 24 weeks, but unfortunately presented disease progression 48 weeks after beginning the therapy. Fifth line of therapy was started with bendamustine, brentuximab vedotin. The patient achieved a metabolic complete remission, was consolidated with a reduced intensity allogeneic stem cell transplantation from the HLA identical sibling, and the patient is alive and well with an excellent performance status 5 years after the allogeneic stem cell transplant. Next slide. Next slide. In this slide, you can see the indications for stem cell transplantation in classical Hodgkin lymphoma, and that's the first aspect that I would like to discuss with you, basically to set the stage on how we can combine checkpoint inhibitors and allogeneic stem cell transplant. As you know, autologous stem cell transplantation has been the standard of care for many years for those patients with primary refractory disease, patients that relapse after achieving the first complete remission, and allogeneic stem cell transplantation has been always devoted for those patients that relapse after an autologous transplant. Next slide. Even with that, and even with the fact that the indications of stem cell transplantation for classical Hodgkin lymphoma have remained stable over time, as you can see in this slide that has been taken from some EBMT data, the numbers of allogeneic stem cell transplantation and eventually the numbers of autologous stem cell transplant have decreased over time. Next slide. But when we look, next slide, but when we look at the overall survival of patients that relapse after autologous stem cell transplant, we can say that the prognosis of these patients has significantly improved over time. This is a retrospective analysis that was published last year by the Lymphoma Working Party of the EBMT, looking at the overall survival after relapse after an autologous stem cell transplantation for patients with classical Hodgkin lymphoma in different time periods. So when you can see that for those patients that relapsed between 2006 and 2008, overall survival at 4 years was around 30%, while nowadays the overall survival of these patients at 4 years is around 60%. And the major benefit in terms of overall survival has been seen in those patients that have early relapses after autologous stem cell transplant, so less than 12 months. Next slide. And basically the reason for that has been because of the introduction of what we call new drugs in those patients that relapse after an autologous stem cell transplant. So in this slide, you can see that there has been an increasing use of brentuximab vedotin for those patients that relapse after an autologous stem cell transplantation, also an increasing use in checkpoint inhibitors, and also an increasing use of a second stem cell transplantation, in most of the cases, an allogeneic stem cell transplant. Next slide. So which are the treatment strategies that we have nowadays for those patients that fail an autologous stem cell transplant, but also brentuximab vedotin and checkpoint inhibitors? And the first one that we have been using for many, many years is allogeneic stem cell transplant. Next slide. This is the one that I will be discussing with you in the next few slides. Next slide. So allogeneic stem cell transplantation has been considered, and it's still considered nowadays, the only curative treatment strategy for patients that relapse after an autologous stem cell transplant. But we have to realize the numbers nowadays are decreasing. Next slide. So why are the numbers decreasing when we talk about allogeneic stem cell transplantation in patients with relapsed refractory classical Hodgkin lymphoma? You may remember that allotransplant was not very well accepted by the scientific community when treating patients with relapsed refractory classical Hodgkin lymphoma. And it was only in the mid-90s or the late 90s when reduced intensity conditioning protocols were introduced in this specific setting, physicians had a clear idea about the fact that the introduction of the reduced intensity conditioning regimens in the setting of classical Hodgkin lymphoma was able to significantly decrease relapse, the non-relapse mortality after allogeneic stem cell transplantation, and that translated into a better progression-free survival and also a better overall survival. Next slide. Nevertheless, even with the fact that allogeneic stem cell transplantation was giving interesting results in terms of long-term outcome in these patients, we were able to see the introduction of new drugs in this setting. And at least in Spain, in October 2012, we saw the introduction of brentuximab vedotin single drug to treat those patients that that had a disease relapse after an autologous stem cell transplant. Next slide. And here you can see the 5 years follow-up of the 102 patients that were included in the pivotal trial that gave the indication to brentuximab vedotin to those patients that relapsed after an autologous stem cell transplant, with a progression-free survival that had a plateau at around 20% and an overall survival median was around 40 months. Next slide. The second group of drugs that was introduced in the post-autologous stem cell transplantation setting were checkpoint inhibitors, and in Spain, nivolumab was introduced in November 2016 and pembrolizumab in March 2017. Next slide. As you know, classical Hodgkin lymphoma frequently harbors abnormalities at 9p24.1, and this leads to an overexpression of PD-L1 and PD-L2 on malignant red stem cells and also on the inflammatory cells in the tumor microenvironment. And this is the reason why, next slide, checkpoint inhibitors are really very effective drugs because basically they cut down this interaction between PD-1 inhibitors and PD-L1, and basically they release the brake that does not allow T cells to do their job in the setting of patients with classical Hodgkin lymphoma. Next slide. So we have two pivotal trials that gave the indication to both checkpoint inhibitors. CheckMate 205 was the pivotal trial that gave the indication to nivolumab in patients with relapsed refractory classical Hodgkin lymphoma. You can see here the long-term follow-up data that were presented by Stephen Ansel in ICML in 2021, with a median progression-free survival, which was a little bit higher than 3 years for those patients that achieved a complete remission with the drug, and really very interesting data in terms of overall survival, not only in patients that achieved a complete remission, but also in patients that achieved a partial remission or only a stable disease. Next slide. Note 087 was the pivotal trial that gave the indication to pembrolizumab in a similar population of patients. And here you can see the updated data that were presented by Pierluigi Cinzani at ASH 2019, with really interesting results in terms of median duration of response, and also a median overall survival that was around 14 months for the global population of patients. Next slide. So when we are now thinking about allogeneic stem cell transplantation in our patients with classical Hodgkin lymphoma, we have to admit that many of them would have already seen checkpoint inhibitors, and for sure brentuximab vedotin, because although still we consider allogeneic stem cell transplantation as the only curative treatment strategy for patients with relapsed refractory classical Hodgkin lymphoma after an autologous stem cell transplantation. And we know very well the long-term follow-up of these patients, and we have a very well identified risk-adapted patient profile. We have to recognize that allogeneic stem cell transplantation is still associated with significant morbidity and mortality. And in most of the groups and in most of the centers, those patients that fail an autologous stem cell transplantation, we prefer to test before brentuximab vedotin, and in those patients that fail brentuximab vedotin, checkpoint inhibitors. So in our clinical practice, many of our patients, before going on allogeneic stem cell transplantation, have already seen checkpoint inhibition. Next slide. So let's go back to our EBMT experience. I have already told you that the numbers of allogeneic stem cell transplantation have significantly decreased over time, and the major reason for that has been the introduction of new drugs. And the other important thing I want to mention here, taking this slide as an example, is that the numbers of haploidentical donors have been increasing over the last 10 years. And basically, classical Hodgkin's lymphoma is the lymphoma where we have more information regarding the effectiveness and the long-term outcome of haploidentical donors using cyclophosphamide after transplant as GVHD prophylaxis. Next slide. The other thing that we have to take into consideration when talking about allogeneic stem cell transplantation is that the long-term outcome of patients that received an allo has also improved over time. This is also retrospective analysis coming from the Lymphoma Working Party, and we were willing to see the evolution over time of patients being allografted in different time periods. So as you can see here, in those patients that were allografted between 1990 and 1994, overall survival was around 20%, while overall survival has increased up to 70% in those patients that have been allografted in more recent periods of time, between 2010 and 2014. Next slide. So back in 2018, we started to have information regarding the possibility to combine checkpoint inhibitors and allogeneic stem cell transplantation. And here you have some data that were published by Philippe Armand in the Journal of Clinical Oncology in 2018, looking at a population of 44 patients that were included in CheckMate 205, and that for whatever reason, these patients were taken out of the protocol and they were consolidated with an allogeneic stem cell transplant. And the authors specifically had to look at the long-term outcome of patients that had been treated previously with nivolumab in the context of a prospective clinical trial and were consolidated with an allogeneic stem cell transplant. You can see in this slide, transplant-related mortality was around 12%. Disease relapse or progression was lower than that. And there was quite a significant incidence of both grade 2 to 4 and grade 3 to 4 acute graft versus host disease, and also of chronic GVHD. Next slide. Next slide. Thank you. But the other important message of this analysis is that both progression-free survival and overall survival, although the follow-up was still quite short, were above 90%. And these results were considered extremely good for a population of patients that had already been refractory to different lines of therapy. Next slide. Another piece of information came from this retrospective multicenter analysis that was published by Merriman and co-workers in Blood 2017, where they were interested to have a look at the safety and efficacy of allogeneic stem cell transplant after PD-1 blockade in relapsed refractory classical Hodgkin lymphoma. Next slide. Here you can see the clinical characteristics of the 39 patients that were included in this retrospective analysis. As we may expect, it's a young population of patients, most of them 80% diagnosed of classical Hodgkin lymphoma, a heavily pretreated population of patients with a median number of 4 lines of therapy before receiving the allogeneic stem cell transplant. 82% of them had failed an autologous stem cell transplantation. They had received a median number of cycles of checkpoint inhibitors of 8. Most of them received nivolumab, and only 28% of them received pembrolizumab, and 36% of the patients achieved a complete remission after checkpoint inhibitors. Next slide. Next slide. Here you can see some clinical characteristics of the allogeneic stem cell transplantation. 64% of the patients went into the allogeneic stem cell transplant in complete remission. Most of the patients received a reduced intensity conditioning protocol, and the GVHD prophylaxis, as you may imagine, was quite varied. Next slide. 36% of the patients received an haploidentical stem cell transplantation. And the most important thing I want to mention here are the excellent results in terms of overall survival and progression-free survival, with an overall survival for this heavily pretreated population of patients of around 90% and a progression-free survival which was 80%. Next slide. In addition to that, you can see that non-relapse mortality was around 10%, and the incidence of relapse and progression was around 10% at 12 months. Next slide. So the combination of checkpoint inhibitors before allogeneic stem cell transplantation seemed to be really very effective and really giving excellent results in terms of overall survival and progression-free survival for these patients. But unfortunately, the authors saw immediately that there were some changes in the morbidity and mortality patterns of the patient that had been previously treated with checkpoint inhibitors. And as you can see here, 7 patients developed febrile syndrome that responded to corticosteroids. Some of these febrile syndromes basically were translated later on into acute or chronic GVHD, and there were 2 patients that died because of acute graft versus host disease. Next slide. So there were some alarms regarding the possibility to combine checkpoint inhibitors with allogeneic stem cell transplantation, and there were some classical guidelines that were given. And one of the guidelines that were given when trying to combine these 2 treatment strategies was to try to establish a washout period of around 2 months between the last dose of checkpoint inhibitor and the allogeneic stem cell transplant. Anyway, this clinical practice has been going on for several years, and here I am presenting a retrospective analysis that included more than 200 patients that was published also by Merriman on behalf of different colleagues coming from both US and European centers, and it was published in Leukemia in 2021. These analyses were looking at more than 200 patients, many of them being treated with an haploidentical donor allogeneic stem cell transplantation using cyclopost, but there was also a big group of patients where the donor was not an haplo donor, but cyclopost was used as GVHD prophylaxis, and these patients had been pre-treated with checkpoint inhibitors. It was a heavily pre-treated population of patients. And as you can see here, the median time from the last dose of checkpoint inhibitor to the allogeneic stem cell transplantation was 81 days. And almost 60% of the patients underwent the allogeneic stem cell transplantation in complete remission. As you can see in this slide, the GRFS of this population of patients was 50%, progression-free survival was around 70%, and overall survival was higher than 80%. And as you can see, this long-term outcome was significantly better. Next slide. To the long-term outcome, the progression-free survival that the Lymphoma Working Party was able to see in a retrospective analysis of a heavily pre-treated patient with classical Hodgkin lymphoma that underwent an allogeneic stem cell transplantation without checkpoint inhibition before, and that was published in Hematology 2008. Next slide. The results in terms of GRFS and in terms of progression-free survival were especially good for those patients that received cyclophosphamide after the allogeneic stem cell transplantation, independently on the type of donor, either with an haploidentical donor or a non-haploidentical donor. Next slide. And as you can see here, non-relapse mortality and relapse rate after the allogeneic stem cell transplantation were below 20%. So basically, in summary, the combination of checkpoint inhibitors and allogeneic stem cell transplantation is really associated with excellent long-term outcomes, although we have to take into consideration that we have non-relapse mortality, and this is below 20%, but this is one thing that has to be taken into consideration when we present these treatment strategies, and also a small proportion of patients relapse after the allogeneic stem cell transplant. Next slide. So the next step was to try to understand if the prior use of checkpoint inhibitors had a real impact in the allogeneic stem cell transplantation. And we have two examples that have been presented in the literature. This is a very small retrospective analysis that was published in Blood Advance by an Italian group, and it was looking at a group of 59 patients with classical Hodgkin lymphoma that were allografted using an haploidentical donor, and 30 of them did not receive any checkpoint inhibitor before allogeneic stem cell transplantation. 29 of them were pre-treated with a checkpoint inhibitor. As you can see here, you can see the clinical characteristics of both groups of patients. I want to mention that those patients that were pre-treated with checkpoint inhibitors before allogeneic stem cell transplantation had received more prior lines of therapy, so a range of 6 versus 4 lines of therapy for those patients that had not been pre-treated with checkpoint inhibitors. Next slide. So overall survival and progression-free survival was significantly better for those patients that underwent the allogeneic stem cell transplantation in complete remission and partial remission versus those patients that underwent the allo transplant only with stable disease or progressive disease. Next slide. Overall survival was not different for those patients that were treated with checkpoint inhibitors before allotransplant versus those patients that did not receive checkpoint inhibitors. But progression-free survival, as you can see on the right-hand side of the slide, was significantly better for those patients that were pre-treated with checkpoint inhibitors. Next slide. And the reason for that, as you can see in this slide, is that relapse rate after allogeneic stem cell transplantation was significantly lower for those patients being treated with checkpoint inhibitors before allogeneic stem cell transplant. Next slide. But nevertheless, we can say that these patients do not represent a big group of patients, so only 59 patients were included in this retrospective analysis. And that's the reason why the CIBMTR and the EBMT tried to better understand which was the impact of checkpoint inhibition before allogeneic stem cell transplantation in this retrospective joint analysis that was presented at the last EBMT meeting in Prague in the Presidential Symposium. Next slide. So the objectives of this analysis was to analyze the long-term outcome of patients, adult patients with classical Hodgkin lymphoma that underwent an allogeneic stem cell transplantation with or without prior checkpoint inhibitors. The primary objective was overall survival. Secondary objectives were engraftment, non-relapse mortality, acute GVHD and chronic GVHD, relapse or disease progression after transplant, progression-free survival, and potential prognostic factors that predicted the outcomes with checkpoint inhibitors before stem cell transplantation. Next slide. 1,700 patients were included, 1,300 that had not received checkpoint inhibitors before transplant, 347 receiving checkpoint inhibitors before allogeneic stem cell transplantation. There were some differential clinical characteristics. There were more males in the CPI-treated group, more APLOS, more patients undergoing allogeneic stem cell transplantation in complete remission or partial remission, also more patients receiving a reduced intensity conditioning regimen, and more patients receiving cyclopost as GVHD prophylaxis. Next slide. The trial was not positive because, as you can see on the right-hand side of the slide, the overall survival was not significantly different between those patients that were pre-treated with checkpoint inhibitors. But as we have seen with the small Italian trial, progression-free survival was significantly better for those patients that received checkpoint inhibitors before allogeneic stem cell transplantation, with a p-value of 0.0171. Next slide. And the reason for that, as you can see in this slide, is that relapse rate after allogeneic stem cell transplantation was significantly lower in those patients that were pre-treated with checkpoint inhibitors, while non-relapse mortality seemed to be a little bit higher in those patients being treated with checkpoint inhibitors. Next slide. This can be seen in the multivariate analysis that shows significant differences in progression-free survival and relapse incidence and grade 2 to 4 acute graft-versus-host disease between both groups of patients. Next slide. And additional factors affecting overall survival were basically age, sex, partial remission versus complete remission, refractory disease versus complete remission, the intensity of the conditioning regimen, as well as performance status at the time of allogeneic stem cell transplant. Next slide. Here you can see the causes of death between both groups of patients. This is one aspect that we still need to analyze a little bit more. But what I want to highlight is that the main cause of death was disease progression in those patients that did not receive checkpoint inhibitors, while those patients that received checkpoint inhibitors had less disease relapse, but they had higher deaths in terms of toxicity related to the allogeneic stem cell transplantation and also GVHD. Next slide. So let's move to the post-allogeneic stem cell transplantation setting. And I have to say that we have quite a few examples in the literature indicating the effectiveness of using checkpoint inhibitors in patients with basically relapsed classical Hodgkin lymphoma after the allogeneic stem cell transplantation. This is a retrospective analysis that was published in Blood 2017. It's a multi-center analysis. Next slide. That included 31 patients. 31 patients that were treated basically with nivolumab because of disease relapse after the allogeneic stem cell transplantation. 17 patients developed GVHD after checkpoint inhibition, and 14 patients did not develop GVHD after checkpoint inhibition. The only significant or clinical difference or significant difference in terms of clinical characteristics between those groups of patients is that those patients that did develop GVHD after checkpoint inhibitors were more frequently allografted from a matched sibling donor in relation to those patients that did not develop GVHD after checkpoint inhibition. Next slide. So here you can see some data regarding the outcomes of those patients that were treated with checkpoint inhibitors. Basically, in summary, and to make the story short, the use of checkpoint inhibitors for patients relapsing after an allogeneic stem cell transplantation is very effective, and progression-free survival and overall survival are really very encouraging, but we have to take into consideration the risk of patients developing acute graft-versus-host disease 2 to 4 and 3 to 4, as you can see in this slide. Next slide. As well as moderate to severe chronic GVHD. Next slide. And the other important thing that needs to be taken into consideration in this specific setting is that the incidence of both acute and chronic GVHD after checkpoint inhibition being used after allogeneic stem cell transplantation is quite high, and those patients are a difficult group of patients to be treated. So only 1 out of 10 patients developing acute graft-versus-host disease achieved a complete remission with steroids, and patients basically only responded to second or third line treatment strategies, and the same applies for those patients that develop chronic GVHD. Next slide. So the second piece of information that I want to share with you regarding the potential use of checkpoint inhibition after allogeneic stem cell transplantation is also this small retrospective analysis that included 20 patients that received checkpoint inhibitors before after allogeneic stem cell transplantation because of disease relapse or progression. Next slide. So next slide. So the learning aspects that we can take from this analysis is that GVHD after checkpoint inhibition represents an important side effect of the drug, that those patients that relapse early after the allogeneic stem cell transplantation and are treating earlier with nivolumab, in this case, have more probability to develop acute graft-versus-host disease than those patients that experience late relapse, that those patients that have a prior history of acute graft-versus-host disease after allogeneic stem cell transplantation, that relapse and are being treated with checkpoint inhibitors have more probabilities to develop acute graft-versus-host disease with checkpoint inhibitors, that usually acute graft-versus-host disease triggered with checkpoint inhibitors is being developed in the first 1 or 2 doses after the checkpoint inhibition. Next slide. And because of this, there were some recommendations that were published in Blood 2018 regarding the use of PD-1 blockade in patients that are being treated with an allogeneic stem cell transplantation. And basically the most important one for those patients that are being pre-treated with checkpoint inhibitors is to try to use cyclophosphamide after allogeneic stem cell transplantation, independently on the type of donor that we are being using. Next slide. Eventually to consider the use of bone marrow as peripheral as stem cell source instead of peripheral blood, and in those patients that are going to be treated with checkpoint inhibitors because of a disease relapse after allogeneic stem cell transplantation, it's important to start anti-PD-1 at a low dose and eventually to modify it depending on response and toxicity. Next slide. So basically, in summary, checkpoint inhibition is a very effective treatment strategy for patients with relapsed refractory classical Hodgkin lymphoma. The use of checkpoints before allotransplant allows a very good long-term outcome of heavily pre-treated and refractory patients. It might be associated to a somewhat higher non-relapse mortality, basically due to a higher incidence of GVHD. Checkpoint inhibitors are a very effective treatment for patients with relapsed disease after allotransplant, but nevertheless, they are really associated to a high risk of developing immune-mediated side effects, basically GVHD. So thank you very much for your attention, and once again, apologize for all the technical issues that have made the program being a little bit delayed. Thank you.
Yeah, very nice presentation, very nice overview about the use of checkpoint in the setting of peri-allogenic bone marrow transplant before and after. And always when we're considering patients for a transplant for allo, we're always thinking about immune-related side effects, especially GVHD. And we're self at King Hussein, we're running now a study, PI initiated a study on the use of PTCY after allogeneic bone marrow transplant. But to be honest with you, we're still using peripheral blood. But that's a good point. We may shift toward doing a bone marrow. The floor is open for 2 or 3 questions from the audience. Any questions, please? Any questions from anybody from the attendees? Yes, I have a question. I did one publication about the transplant in relapsed Hodgkin lymphoma at King Hussein. Though it is a single center study, I think we included 168 patients. And what we noted that the number of the transplant, auto and allo in particular, is increasing, which is against what we showed. I mean, opposite what we showed according to the ABMT. Though we are a member of the ABMT society, I mean, I didn't have any explanation for that, but maybe all of these transplants were before the era of approving brentuximab, Vedotin, and checkpoint inhibitors at King Hussein Cancer Center and in Jordan in particular. I don't know. Would you comment on what's the explanation for decreasing the number for allo auto? I know you did mention about the brentuximab and checkpoint and the second auto. Would you comment on that again, please, Dr. Salina?
Sure. Well, I think that overall nowadays, both in Europe and also in US, if we follow the data coming from the CIBMTR analysis, the numbers of allos are decreasing. And they are decreasing basically because we have new drugs, we have brentuximab vedotin, we have checkpoint inhibitors, and some of these patients are never being allografted, or eventually the allogeneic stem cell transplantation is being considered later on in later disease stages, and some of these patients never reach the allotransplant. The other issue is that we have prospective clinical trials where these patients can be included, and they fail brentuximab vedotin and checkpoint inhibitors. So definitively, I would say that in the last 4 or 5 years, the numbers of allos and eventually autos are decreasing. But the issue is that the world is not doing exactly the same. So I don't know exactly where this publication is coming from in terms of the center or the area of the world. But there are areas where it's more difficult to get new drugs for Hodgkin lymphoma, for instance, brentuximab vedotin and checkpoint inhibitors. And of course, allogeneic stem cell transplantation is still probably the only curative strategy for these patients that have multiply relapsed disease. And this might be the explanation, just to guess a little bit because I don't understand it very well, why the numbers of allos are being kept more or less stable over time. I can tell you that overall around the world, the numbers of allotransplants are decreasing because of that, for the treatment strategies, which might not be curative, but of course they are safer and they are associated to lower toxicity.
Thank you very much. Because
can I have a question?
The last question, please go on. Short question, please. Last and short. Thank you.
Dr. Salina, for patients failing auto transplant and they responded well to immune checkpoint inhibitors, do you offer for these patients to continue immune checkpoint till progression rather than going to allo transplant?
Well, I think that this is an excellent question. I'm not so sure if I will have the 100% correct answer. I think that if the patient does not achieve a complete remission, the patient only achieves a partial remission. I think, or at least what we are doing and what many centers are doing, we are offering an allogeneic stem cell transplantation to this patient as consolidation strategy. If the patient achieves a complete remission, you have seen that the progression-free survival is really very good for these patients. Even if these patients lose the response, they can be re-challenged again with checkpoint inhibitors or with chemotherapy, and it's quite easy for them to achieve another complete remission, and maybe the allogeneic stem cell transplantation has to be saved for patients that achieve another response after failing checkpoint inhibition. This is what is being done in many centers. We are normally considering, we are individualizing a little bit the treatment strategy for these patients. If we have a very young patient that has had a very refractory disease and that has only achieved a complete remission with checkpoint inhibitors, we are eventually still considering allogeneic stem cell transplantation for these patients, clearly discussing the pros and cons of the different strategies with the patient. If we have a more elderly patient with not such an aggressive disease, probably we are leaving the patient with a checkpoint inhibitor if the patient relapses after the checkpoint inhibition, then we are considering allogeneic stem cell transplant.
Thank you very much, Dr. Hussam. Thank you very much, Professor Sarida, and I will conclude with the session. And
thank you very much.
See you in Paris, inshallah, in the ABMT 2023. See you in Paris.
See
Thank you very much,
Professor Sarida. Thank you very much.
Bye-bye. Bye-bye.
Thank you.
Have a nice day. Bye-bye.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. It is a pleasure and honor to moderate this session. I am Majdi Al-Jaddai, the head of Medical Oncology Department at the Military Cancer Center, Real Medical Services, and Dr. Hanad Ta'ani, a medical consultant in King Abdullah Hospital. We are going to moderate this session. We are happy today to have a well-distinguished speaker, Dr. Mark David Menzel. Actually, Dr. Mark has a very rich and long CV, and I will try to summarize it. Dr. Mark received his MD degree from the University of Cape Town in 1976. His training was in London and Canada. He completed his postgraduate training in the Department of Medicine at the University of Ottawa. He is a medical oncologist at the London Regional Cancer Centre, where his activities include the management of lung, GI, and laboratory research. He is an associate professor at the University of Western Ontario in the Department of Medicine in the Division of Medical Oncology, where he received the Award of Excellence in Teaching in 2004. Actually, Dr. David has many specialty qualifications and many publications at different topics I have mentioned here. Now, just to inform you that from this session and the sequence one, there is a shifting of 15 minutes. This was before because of technical error. Just to inform you that if you have any question, please keep it until the end of the session. Dr. David will be talking about adjuvant Tagrisso, delivers a groundbreaking efficacy. Please, Dr. David, the microphone is yours.
Thank you. Can you hear me?
Yes. Yes.
Okay, so thank you again to colleagues in Jordan for inviting me to give this presentation, and thank you to AstraZeneca for making it possible. I'm going to be talking about adjuvant Tagrisso. These are my disclosures, and emphasizing the results from ADAURA, a global phase 3 study of resected EGFR mutant non-small cell lung cancer. And this is just the current indications, including approval now for the adjuvant treatment of completely resected patients with non-small cell lung cancer whose tumors contain the common mutations in EGFR exon 19 and point mutation exon 21, in addition to the previously approved indications, first-line treatment and also second-line treatment in patients with EGFR T790M mutation. So just to emphasize that EGFR mutated non-small cell lung cancer is very common in East Asia and South Asia, perhaps less common in Western Europe, Canada, North America, where it's about 10% of adenocarcinomas, non-small cell lung cancer, but it is fairly prevalent in the Gulf region. This is not initially specifically Jordan, but in your region in general, there is a series here where it is approximately 30% of adenocarcinomas. So certainly quite a common situation. Now, just the background a little bit, Osimertinib, also the generic name for Tagrisso, is the, as depicted here on the cartoon, you see the first, second generation EGFR TKIs are adept at blocking the EGFR mutation. They also lock in quite nicely to the normal EGFR, causing toxicity, and they're unable to block the T790M mutation. Osimertinib has been designed to get around those problems. So firstly, it interacts very well with the common EGFR mutations, but it can still interact and block and inhibit those mutations that have an additional mutation with the T790M. And the wild type, it does not bind so well, so that causes less in the way of toxicity. This is just a cartoon showing basically what I've just said, that gefitinib first generation can get into the native EGFR mutation and the wild type quite nicely. But if you develop this T790 bulky mutation here, there's a steric interaction and the gefitinib is pushed out of the binding site. Same thing with erlotinib. But the osimertinib has been designed so that if you have a T790 mutation or if you don't, either way, it's going to bind quite nicely. So it gets around that problem. Now, the AURA3 design was the first big randomized trial with osimertinib. This is in patients who had failed on first line EGFR TKIs with the T790M mutation, and they were randomized to osimertinib at the standard dose of 80 milligrams versus platinum pemetrexed chemotherapy. And the primary endpoint was progression-free survival. And you can see here that there's a very large progression-free survival benefit for osimertinib at 10 months versus 4.5 months. And that led to the approval, the initial approval in second line with the T790 mutation. Moving into first line then with the FLORA study, these are treatment-naive patients, again with the common mutations, 19 deletion and 858R. Randomized to osimertinib versus a comparator, either a gefitinib or erlotinib, and the crossover was allowed here. Overall survival was a key secondary endpoint, but you do see the very large progression-free survival benefit for all of these subgroups in the forest plot. This is 18.9 versus 10.2 months, a very staggering improvement actually. And you can see all of these are in the benefit for the osimertinib. And the survival actually was also strikingly better at about 38.6 months compared to just over 31 or 32 months, including crossover, by the way. This was statistically significant and has led to osimertinib becoming the first-line treatment of choice in patients with metastatic EGFR mutated common mutations. Now, the important subtext to this study was the very dramatic improvement in patients with CNS metastases at baseline, a hazard ratio of less than 0.5, a very significant p-value in terms of probability of progression-free survival. And this is extremely important. As we all know, patients who have brain metastases can become have experienced an extremely poor quality of life if this is uncontrolled. And so this is a very significant advance in the treatment of this disease. And all of this has led in totality to a very big trial program, and I'm going to be concentrating on the adjuvant setting, but there's also a big study of osimertinib versus placebo in stage 3 unresectable EGFR mutated non-small cell lung cancer, together with other studies such as FLORA2, osimertinib and chemotherapy, and so on. That's still to read out, and other studies combining with other drugs to address drug resistance mechanism. But I'm going to be focusing on the ADAURA study, which is the post-surgical resection situation in this EGFR mutated patient population. Now, there are a lot of unmet needs in resectable non-small cell lung cancer, which is in about 25 to 30% of non-small cell. And ideally, patients should be managed in the context of a multidisciplinary team, which includes respirologists, radiologists, thoracic surgeons, medical and radiation therapy oncologists, pathologists, nurse specialists, pharmacists, palliative care. Now, this is a big team. This is an expensive exercise to put together. It has to function very smoothly. And not everybody out there in the community has access to this. And this is why it's important to get early testing in these patients and referral quite early on. And we know that patients who are managed in the context of a multidisciplinary team tend to do better than patients who are not. And this is an important slide as well. Unfortunately, the standard of care being adjuvant chemotherapy after resection of stage 1B, 2, and 3A, These patients often, firstly, they don't receive adjuvant chemotherapy for multiple reasons. They may just simply refuse. They may have been told by the surgeon that they got it all and that it's all gone, and they don't want to hear about anything more. They have comorbidities that make it difficult to tolerate chemotherapy. They have delayed recovery from surgery. They have poor performance status. And furthermore, if they do get to chemotherapy, about a third to a half of them don't actually finish because of toxicity in the context of platinum doublet chemotherapy. And then even if they manage to get through all of that, there is still a considerable risk of relapse, and more than half of these patients will relapse, about 45% in stage 1B, but 2/3 to 3/4 of them will relapse with stage 2 and stage 3. Unfortunately, so they go through the surgery, they go through the adjuvant chemotherapy, and yet they still face this incredibly high chance of having a relapse, with the chemotherapy really having a kind of a modest effect with about maybe 10% improvement in mortality. And most of these recurrences are outside the thorax. About 70% of them are in disease sites such as the brain, the bone, the liver, etc., as well as a considerable number of them being within the thorax as well. So most of these recurrences occur metastatic outside, and generally speaking, except in the unusual situation where people have solitary metastases that can be irradiated, most of these are incurable. Now, we are advancing on multiple fronts, including the immune checkpoint inhibitor aspect, which is exemplified by this study, Checkmate 816. It's not the only study here, but it's just a good example. Chemotherapy with nivolumab prior to surgery. But these checkpoint inhibitors are not very effective in patients with EGFR mutations. And it is better to treat these people with targeted therapy if they have an EGFR mutation. So this study specifically excluded patients with sensitizing EGFR and ALK mutations, for example. Now, moving on to the ADAURA study, this was a study in patients with 1B, 2, and 3A EGFR mutated non-small cell, again with the common mutations, deletion 19 and a point mutation in exon 21. This was almost 700 patients. They had to have an R0 resection. And at the discretion of the treating physician and, of course, the consent of the patient, they could choose to have adjuvant chemotherapy or not. If they didn't, then they had to be accrued onto the study within 10 weeks post-surgery. If they did have adjuvant chemotherapy, they got through that initially and were allowed up to 26 weeks post-surgery to accrue onto the study. And they were then randomized 1-to-1 to the standard dose of Tagrisso, 80 milligrams, versus a placebo. So this is a placebo-controlled trial, and the primary endpoint was disease-free survival in patients with stage 2 and 3A, with subsidiary analyses to include the stage 1B. And the secondary endpoints were disease-free survival, overall survival, safety, health-related quality of life in the whole population. And I'm not going to go through these key inclusion and exclusion criteria, but just basically these patients had to have a centrally confirmed EGFR common mutation, and they had to have been completely resected, and they had to have recovered from surgery and or the chemotherapy if they had the chemotherapy. And exclusions were based on comorbidities, in particular patients with QTc prolongations, patients with a history of interstitial lung disease, and so on. So this was a type of population that is fairly commonly encountered in clinical practice. And this just shows the demographics with the 2/3 inclusion of females, average age young 60s, most of them non-smokers. The majority were Asians, but there were a considerable number of Caucasians as well. Good performance status, stage 1B, 2, and 3A, more or less equally split. And almost all of them had adenocarcinomas, and they all had either deletion 19 in the majority or in 45% and exon 21. And about 60% of them had adjuvant chemotherapy, but about 40% did not. And now in terms of the efficacy results, this was published in the initial publication of this in 2020 in the New England Journal of Medicine, showing a very significant and really massive and unusually substantive reduction in disease-free survival with a hazard ratio of 0.17 in the primary intent to treat population of stage 2 and stage 3A. These are node-positive, essentially node-positive cancers, all clinically resected, R0. But you can see there's just massive reduction in the risk of recurrence. And if you include the stage 1B in that as well, you basically see that this difference is well maintained. And if you just look at the 2-year landmark analysis, stage 1B, the patients alive and disease-free were 88% versus 71%, 91% versus 56% in stage 2, and 88 versus 32% in stage 3A. So remarkable efficacy here in preventing disease recurrence. This set of data was updated at the recent ESMO conference in Paris in 2022, showing again by stage. You can see the probability of disease-free survival. The top curve represents patients randomized to osimertinib or Tagrisso. The bottom one is the placebo. And you can see a very important difference even in stage 1B, but especially in stage 2 and stage 3A. So all of these patients, stage 1B, stage 2, and stage 3A, had a very substantive reduction in their risk of recurrence. And this is highly impressive and maintained. In fact, if you look at the entire population out to 48 months and beyond that, we don't really have enough follow-up. But the median DFS in the patients receiving osimertinib was 66 months compared to only 28 for patients on placebo, with a hazard ratio of 0.27. This is highly statistically significant. Now, if we just look at this updated curve, we do see, and I want to emphasize here that these are patients who were treated for 3 years with the osimertinib, and then they stopped, or the placebo. But what you see at 36 months, you see just a very gentle decline. But then after about a couple of months after the patient stopped treatment, you start to see the curve starting to bend down, which means that this is not a curative treatment for some of these patients. I think for some it perhaps is, but for some it isn't. It's a suppressive treatment. And it does raise the question of whether you should be treating these people, especially you can see how this kind of a bending of the curve, whether patients would benefit from ongoing treatment beyond 36 months. Now, that's not on label, and we just don't have the data, and we don't know. But this is a very interesting question, of course. And again, here, just as by updated here, according to this, the 8th edition, and you see the maintained benefit here, well out to 48 months, actually, and probably even beyond. And this is the updated DFS, and you can see the benefit in all of these subgroups, different EGFR mutations, whether they had chemo or not, by gender, by age, by smoking history. We know that a lot of patients who smoke can still get EGFR mutated lung cancer, and they benefit maybe even a little bit better than people who do not smoke. But essentially, there's a huge benefit in just about everybody. And this is an undeniable and now is a well-established fact. If you look at the CNS disease-free survival, you can see a massive protection in the central nervous system out to 36 months. Whereas in patients who just got placebo, by the time that you get to 24 months, 20% of those people have relapsed in the brain. Almost nobody has relapsed in the brain on osimertinib. So one of the characteristics of osimertinib is that it is CNS penetrant, and so this is a very big benefit of osimertinib. It gets into the central nervous system, but does not cause significant CNS side effects. So this is a huge achievement and a striking attribute of the drug. But again, once you stop the drug at 36 months, you see that patients do start to relapse in the brain. Of course, not everybody, but about 10% or more will start to relapse in the brain. And you kind of wonder whether for those people it would be better to continue beyond the 3 years. I'm not advocating it. I'm just saying it is a question. In terms of the recurrences, firstly, you see a dramatically lower rate of disease recurrence in people who'd been on Tagrisso compared to the control arm. In the control arm, most of these recurrences occur outside the thorax, whereas in those patients on Tagrisso, if they do recur, which is not many of them, it's mostly within the thorax and much less so outside the thorax. So there's not only a much lower rate of recurrence, but there's a different pattern in the way the recurrences turn out. This is another way to depict it here, just looking at the probability of CNS and non-CNS recurrence. The yellow lines are the placebo patients, and up here, this dashed line here is the placebo patients getting non-CNS recurrence compared to the Tagrisso patients getting non-CNS recurrence. But very interestingly, if you look at the dotted lines here, this is the CNS recurrence in the placebo group and the much lower CNS recurrence, and in up to 36 months, almost complete protection from brain failure out to 36 months. And only about 3 or 4 months later do you start to see, once they've stopped the Tagrisso, that the CNS recurrence starts to occur in these patients. Again, raising the important question of should you be continuing beyond 3 years. In terms of this is the disease-free survival, again, updated according to the various subgroups. And you can see that by stage, worse the stage, bigger the effect, the lower the hazard ratio, which is quite interesting. And then all these other groups benefiting as well. In those with and without adjuvant chemotherapy. Now, this is not a study about adjuvant chemotherapy. This chemotherapy was an individualized decision between the doctor and the patient. Of course, many patients with stage 1B would not have had the chemo. More patients with stage 3A would. So this is not about chemo versus non-chemo. It's just to show that you get the benefit of osimertinib in those patients who had adjuvant chemotherapy and in those patients who did not. So you're allowed to have chemotherapy if you think it's indicated, and just get onto the osimertinib after that. If you think patients aren't suitable for whatever reason, don't have adjuvant chemotherapy, you can just go onto the osimertinib straight away. And this is just to show, again, the sites of recurrence, and in the patients on placebo, the very substantial risk of CNS failure and the much lower risk of CNS failure in patients on osimertinib. And just generally showing the extrathoracic risk in patients who had the placebo. This is the disease-free survival in the overall population. Again, showing excellent protection out to 36 months. But after that, you do get a few people who start to relapse once you stop the osimertinib. Now, we don't have the final mature overall survival at this point. But what we do have is a intermediate analysis here. And what you see is that the overall survival here seems to be, at least initially, in favor of osimertinib. I think we will get, this is a hazard ratio of 0.4, by the way. It's not statistical at this point in time, but we are hopeful that we will get a more mature readout of the overall survival over the next 12 months or so. Now, just in terms of the toxicity, there are no surprises here. I think you're all familiar with the use of this drug in the advanced setting, and the kind of side effects really is what we get in the adjuvant setting as well. But of course, we are now giving it for up to 3 years. So it's critically important that if you're going to give a drug for 3 years, that it does not degrade patients' quality of life in terms of these toxicities. Now, you see, first of all, very, very few grade 3 toxicities. Possibly a little bit of diarrhea, bit of anorexia, a bit of stomatitis, but it's very unusual. It's sort of less than just 2% or less. And you can always manage that by dose reductions. What you see in the control arm, of course, is you see some people getting so-called toxicities, but in fact are just the symptoms, I think, of ordinary living. And some people get a bit of diarrhea, a bit of a cough and that kind of stuff, which is not unexpected. In terms of the grade 1 to 2 toxicities, there is a little bit of an excess in terms of diarrhea, paronychia, stomatitis. And for these patients, they will occasionally need to have a dose reduction. So these are people started out in the 80 milligrams, which is the standard dose, but you can take people down to 40 milligrams. There's a 40 milligram preparation available, so it is not a problem to dose reduce. This is the all-cause side effects. A mild rash, you can often respond to a little bit of a 1% hydrocortisone cream applied sparingly. You do have to watch the QTc prolongation, but this bar graph is really for patients with more than 10% of patients getting these toxicities. There are rare toxicities that you must be aware of as a treating physician. One of them is QTc prolongation, so it's important to get a baseline ECG to make sure these patients do not have a QTc more than 470 or especially 500. And also if they don't have a history of interstitial lung disease. These people were excluded from the study if they had baseline interstitial lung disease. And patients, there was about 3% of patients who developed interstitial lung disease on osimertinib, but it is a mostly grade 1, grade 2. But again, it's not nothing. And as a treating physician, you have a responsibility to pay attention to this. And this, I've mentioned the dosing that is 80 milligrams standard. And by the way, for people who have trouble swallowing, you can dissolve a tablet in 50 ml of non-carbonated water. You can just stir until it's dissolved, or at least broken up into small pieces, and then that can be ingested more easily in some people, but it can also go in through a nasogastric tube as well. And I've had to do that once or twice. And of course, it can take in at home and with or without food. Now, I just want to emphasize the critical importance about doing reflex testing. Certainly with the initial biopsy, if you have enough tissue to do that. You don't always have enough tissue, of course, in this disease. But certainly once you have a resected tumor, that should be tested for EGFR and ALK and so on, and PD-L1 as soon as possible, and done automatically, so that you have a relationship with the pathologist, that they should know that if you have either a biopsy specimen or a resected specimen of non-small cell lung cancer, they should test immediately for EGFR, ALK, and PD-L1, and other driver mutations potentially as well. Because the more you know, the luckier you get, and the better your patients do. So test early, know what you're dealing with, and then if it is an EGFR mutation in the adjuvant setting, this has become endorsed now by the NCCN as the standard of care. And the NCCN in particular recommends here osimertinib as an adjuvant therapy. This is now on the NCCN website. It's been updated for patients 1B to 3A completely resected, EGFR mutation positive for the common mutations. But it is, of course, dependent on a test. And so they do recommend that testing be done early on for PD-L1, EGFR, ALK, and if you have the ability to do that for potentially other driver mutations. So just to summarize, basically, this is an overwhelmingly positive study. I think it's quite clear from the disease-free survival point of view, from the CNS protection point of view, that this applies to stage 1B to 3A patients with the common mutations. Adjuvant Tagrisso significantly protected against the risk of disease recurrence, especially systemic disease recurrence, and especially in the brain. And it is a drug that has been shown to be well tolerated and safe for the vast majority of people over 3 years, but which does have occasional issues like any drug that you have to be aware of. But this drug has attributes. It has excellent and proven track record in the first line and in the second line with T790 mutation. And of course, one of the big benefits you're seeing here in the adjuvant setting is the suppression of T790M, so that it just doesn't come up. It is less toxic than other available drugs. It can be combined safely with chemotherapy and VEGF inhibitors in the advanced setting, and that's experimental right now. It's probably safe to combine with radiotherapy or close to radiotherapy. And there's a very large international clinical trial program ongoing. But you do have to watch out for patients with interstitial lung disease or who may develop shortness of breath that might be suggestive of an interstitial lung disease. It's very uncommon, but you should be aware of it. Likewise, QTC prolongation is something that's reasonably common. You should just be aware of it. When I say reasonably common, it should be screened for in the general population. But the actual development, once you've excluded patients with baseline QTC issues, only comes up in about 3% of patients, but it's probably worthwhile getting an ECG from time to time. Keratitis is rare, but again, if people have ophthalmic symptoms, get them to an ophthalmologist and either cut down or hold the drug until you know what's going on. And elderly patients over 65 and patients who have low body weight, less than 50 kilograms, may be more susceptible to toxicity and may benefit from a dose reduction. And of course, Tagrisso is an agent that may cause fetal harm, so generally steer clear of it in the case of pregnant women, unless you really don't have any other choice. And with that, I'm happy to bring my talk to a conclusion, and I'm very happy to answer any questions if there are any questions, and if there's any time. So, Mr. Chairman, I'm in your hands.
Thank you, Professor Mark, for this interesting and excellent presentation. And I think all of us agree to EGFR test for our lung cancer patients for the use of adjuvant and as metastatic. And based on the result that we saw, I think we have one question, time for one question, because we have short time. Any questions?
Actually, I have a question that is out of the scope of this session. In patients with EGFR positive and PD-L1 positive, when he consumed all anti-EGFR modalities, could he have any benefit of using anti-immunotherapy agent?
Yeah, if you have a patient with an advanced disease, I think that's what you're referring to. The first treatment of choice, of course, would be an EGFR TKI. There are patients who have been shown to benefit from anti-PD-1, anti-PD-L1 treatments, but there are a couple of considerations. Firstly, most patients with EGFR mutations don't seem to benefit strongly from EGFR, from anti-PD-1 drugs, anti-PD-L1. There's also a safety consideration that if patients have a PD-1 or anti-PD-1 first, and then go on to an EGFR blocking drug, while the PD-1, PD-L1 antibody is still in the bloodstream, or if you combine the two together, there's a significantly higher risk of serious pneumonitis. So you should never give these drugs together or even close together. Now, you can give the osimertinib first, stop the osimertinib, it gets out of the bloodstream fairly quickly, and then go on to a PD-1 if you want to do it. The other way is more dangerous because the PD-1 or the antibody will stay in the bloodstream for quite a long time. And then to give a TKI straight after PD-1 is dangerous. So if you're going to do this, you have to be very careful how you sequence it to make sure that you don't have both of these drugs in the bloodstream at the same time.
Excuse me for another question, if possible. If you look for the data of our study, patients who received treatment with no adjuvant chemotherapy, placebo. The data disease-free survival is better for patients who not received adjuvant chemotherapy versus patients who received placebo. Any explanation of this?
Yeah, this is a confounded kind of a situation because the patients who did not get chemotherapy are more like stage 1B. So whether people got chemotherapy or not was at the decision of the doctor. It wasn't a randomization thing. So we can't really say whether it's a good idea to give chemo or not. All we can say is that you get additional benefit with the osimertinib, whether they had chemo or whether they didn't. And so what you found is that the survival looks a bit better in the people who don't get chemo because those are mostly stage 1B patients who generally have a better survival anyway, even if you do nothing. Whereas those who had more chemotherapy were more likely to be stage 3 or stage 2 at a much higher risk. So the decision about chemotherapy here remains up to the physician. Right now, if we have patients who are stage 2, stage 3, we generally do advise them to have some chemotherapy, some adjuvant chemotherapy, and then to have the Tagrisso after that. But in patients with smaller tumors, negative nodes, it's more of a discussion with the patient. More than 4 centimeters, less than 4 centimeters. If it's less than 4 centimeters, I generally advise against chemotherapy. Between bigger than 4 centimeters but negative nodes, it's a bit of a discussion with the patients. It's a bit of a gray area. And then, of course, it's whether the patient is fit enough for chemo, whether they can tolerate chemotherapy, how easy it is to deliver, and so on and so forth.
Thank you, Dr. Mark, for the lecture, and we hope to see you soon in Jordan as soon as possible in another meeting. Thank you so much.
Thank you very much. Thank you. Have a good conference.
Good afternoon. Good afternoon. It's my pleasure to welcome you all for the Breast Cancer Symposium sponsored by Pfizer, and I would like to thank Pfizer for sponsoring this event. And it's my pleasure to also welcome our guest speaker from Saudi Arabia, Dr. Abdullah Litwerji, Dr. Abdullah, he is the chairman of Medical Oncology Comprehensive Cancer Center at King Fahd Medical City in Saudi Arabia. Actually, I am impressed with his CV with lots of awards and publications, although he looks very young. And Dr. Abdullah did his training and fellowship in Queen University in Canada, his subspecialty mainly in lung and breast oncology. He is active member in many professional committees in Saudi Arabia. He is editor and reviewer in a number of local and international academic journals, and he is a member of many societies in ESMO, ASCO, and the Canadian Society. Dr. Abdullah will update us about the management of luminal type A, what's the update about the role of CDK4/6 inhibitors in the management of luminal type A metastatic breast cancer. Please join me in welcoming Dr. Abdullah. Dr. Abdullah, the floor is yours to start your lecture.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Doctor, for such introduction, and really thank you for being part of such an event. And
Abdullah, can you raise your voice a little, or? Okay. We can see your slides.
It's okay. Yes, so you can hear my voice now?
Yes, it's better.
Okay, so today I'm trying to give you more kind of an update on a very important agent that we are utilizing right now in hormone-positive breast cancer. Those are the CDK4/6 inhibitor. This is my disclosure. So first, I will try to give you more kind of a brief introduction into the CDK4/6 and luminal breast cancer, and maybe I will start with real case scenarios, but most of the discussion will be mostly on the efficacy data that we have with those drugs, starting from clinical trials. I will try also to support that as well with real-world data. Definitely, efficacy is important, but in a disease where the intent is palliation, the quality of life also is really important for those patients. And also sometimes in a situation where you have different options, different drug, similar indications, the toxicity profile is also something it can differentiate between different agents and try to help you in a way to select which drug is really an optimal for different kind of scenarios. At the end, I will try also to give you also an update about the role of CDK4/6 beyond progression, and this is something came up over the last year at ASCO as well as last San Antonio as well. Let's start with this kind of real case scenario. This is a lady, she's a 52-year-old who has been presented with left breast cancer. It was clinically staged as a T2N1 hormone positive, HER2 negative. Her initial...
Can you move your slides? They are not moving, the slides. You start with the case, right?
Yes.
But still the first slide.
Let me just try to share again.
Would you share it, please, again? Yes.
Yeah.
Okay. Yes.
Now
it's moving now. So this is a lady who I started with she has a left breast cancer, locally advanced, hormone positive, HER2 negative. Her initial diagnosis in 2017. She was treated with the neoadjuvant chemotherapy, then modified radical mastectomy in late 2017, radiation. She was also treated with tamoxifen because she was in a kind of perimenopausal patient. 2 years later, she came with bone pain, abdominal discomfort. She lost also a bit of weight, and by the time it was 2 years, she already post-menopausal. Her clinical examination was okay. Her performance was reasonable with ECOG of 1. And this is her baseline staging scan. We have quite extensive bone mets, and there is also one liver region that are measuring 1.4 centimeter, giving the small burden of the disease in the liver. The patient was not really in a true visceral crisis. So patient underwent for a CT-guided biopsy from that liver lesions, and the pathology was quite consistent with invasive ductal carcinoma. The grading was 2. She was still hormone positive, highly expressed, HER2 negative. The Ki-67 was kind of lowish in a range of 15%. So for such scenario, with a 52-year-old postmenopausal lady with hormone positive metastatic breast cancer that are extended to the bone and liver, she relapsed while on an adjuvant endocrine. What would be the best first-line treatment for such scenario? Definitely in the treatment options that we can select for a hormone-positive metastatic breast cancer is not as an easy decision. There is many things you need to look at in terms of first start with biomarkers. The most important biomarkers that we always look at, and that's why repeating biopsy is really important, is the hormone positive, HER2 negative, HER2 status, as well as BRCA also becoming an important, because this is also becoming an option in a BRCA positive population. Also PIK3CA is also something quite important, especially in a subsequent line to a CDK4/6. PD-L1 might be more relevant to triple negative than hormone positive. Prior therapy is also important, because you need to look at what's really the prior therapy in terms of endocrine, which endocrine patient relapse on, in order to select the next appropriate options, and whether a patient has significant toxicity to the prior therapy or no. Disease-related factors, including the disease-free interval, the tumor burden, whether patient in visceral crisis or not in visceral crisis, not only the disease-related factor, but also the patient-related factor, which is the performance, menopausal status, any existing comorbidity as well. So at the end, as much as we are really careful in a way to improve the quantity of life, which is the survival, but also we need to maintain the quality of life, and that's really important, as well as the survival that we are looking for. So it's not the decisions that we made for those patients is not our own decision, but also it have to be shared also with patient. One of those important factors that can help us to make those decisions, definitely the efficacy matters. The improvement that we might observe with the efficacy parameters, including the PFS, survival prolongation, is really important in a way to select a different drug from the others, but also we should not overlook the other important factors that also might be really important in those situations: the toxicity, the convenience, the tolerability, the quality of life, how much we can delay the chemotherapy, how much those patients will be adherent to the treatment that they might get in order to improve their disease nature. So hormone receptors is really important. It's really it's a common thing to have. In almost most patients, they will have hormone positive expression. It's not just predictive, but also prognostic. Most the ASCO guidelines for defining, or the cutoff for positivity, is 1%. However, we do believe that they are a subgroup who are we call them the low positive or the weak positive, up to 9%, and those are, though they has been defined as a positive by ASCO, but they are there are a number of reports showing that those patients they might be similar to the triple negative disease, where they have less sensitivity to endocrine, and that's why they might not have also the outcome that we do see with hormone positive, for example, 10% or more. There are also subgroup, what we call it the PR positive, ER negative, and those are extremely rare. And we are not sure whether this is a true disease or it's more kind of technical artifact, but in general, they do behave as well as the hormone negative or the triple negative disease within in kind of disease nature or the course of the treatment in the long term. Knowing the metastatic disease biology is really important, and once you have disease that recur, it's always important to rebiopsy, because rebiopsy is really important, not just to define this is a cancer or this is a primary or mets, but also you need to look at the biology of the disease, and many reports, in fact, showing that the biology might change and the discordance rate is quite high, especially when it comes to hormone receptor discordance, and some report the ER or estrogen discordance rate can go up to 50%. Majority of those discordance are related to loss of those receptors, but around 30% of them might also having a gain in those receptors. So, and that's really important, because this discordance rate might also add options for those patients who did not have exhibition in those receptors to start with. The HER2 also is really important, and the discordance that has been reported in those patients up to 8%, and most of or half of those discordance might also gain rather than loss, and that's also another important, because having a gain in HER2 status also give you an option. And nowadays also we are looking at not just HER2 expression, but also the HER2 low, because also we have also more options that we can deliver for such patient population. The hormone positive breast cancer are quite heterogeneous from molecular subtypes, because we know it's hormone positive, but when you look under genomic perspective, you can see that we have luminal A, we have luminal B for those hormone positive, and that's are genomically different than what we have also with hormone negative, where we have only basal and HER2. So hormone positive is usually represent 80% of all breast cancer, but those can be divided in a luminal A or luminal B. Luminal A are more kind of the commonest. It's almost represent 60% of breast cancer. They do have higher expression of estrogen, and they also have lower expression of genes that are linked to proliferations. But from immunohistochemistry perspective, we can see that the luminal A are mostly grade 1 or 2. They are strongly ER and BR, and usually HER2 negative, and the KI usually below 15 or 20%. While the luminal B seem to be more aggressive. It's less in percentage, and at 20%, they have higher expression of the proliferative genes, and they can be either HER2 enriched, where they might express HER2, but also they might also HER2 negative with presence of high proliferative biology, where you might see high Ki7 of more than 15 to 20% in those situations. And they do have also higher prevalence of TP53, which is kind of poor prognostic biomarkers for such kind of biology. So it's quite heterogeneous. The other issue is apart from the presence of hormone positivity and HER2, and which is really the only predictive biomarkers that we have in those patients, but and we don't have really right biomarkers in a way to decide between different endocrine like tamoxifen or aromatase inhibitors. We don't have also biomarker to help to use or against fulvestrant, and definitely we don't have any biomarker in a way to select the patient who benefit from a CDK4/6 inhibitor or mTOR inhibitor as far as indicated. But ES are now becoming really important, and just really it might be useful in those patients who might have who may acquire resistance to AI, though in a real life or practice it's not really changed much. But as we can see in current clinical trials, we start to see the ESR1 role is becoming important, especially with the availability of a newer oral estrogen modulator, and this is something came up over the last couple years. So it's quite heterogeneous. Though the luminal A and luminal B are different disease, but they also have quite different biology behind that, and mostly because higher exhibition of TP53, but they also have different genomic background that might also help in a way to dictate their prognosis, and also it might also help in a way to select the right therapeutic approach. So from economic, they are heterogeneous, but also from a clinical perspective, those tumors are quite heterogeneous. Most of the time, we have different extreme of presentation of hormone positive metastatic breast cancer. We have those who might present in a more kind of a visceral crisis, those probably 10-15% at the maximum, but also on the extreme, we have those patients who have a slow or low tumor burden. But the majority of what we do see in our practice is something in between those two extreme, and the treatment decisions might also, or the having this clinical heterogeneity might also impact on the way we treat those patients in the real life setting. Still, endocrine therapy is the way to go, and that's it's the best options in the presence of visceral disease, unless we have a visceral crisis. However, as you know, visceral crisis is more kind of a gray zone where it has been defined in a more kind of in a different guidelines, including the ABC. And it was defined as either signs, symptoms, lab, or rapid disease progression. And that doesn't mean that they have to have only presence of visceral mets, but what's really important in a way to define visceral crisis is you need to have a more kind of organ compromise. And that has been defined better in an ABC5, where they have tried to specify different visceral crises related to each organ. For example, in liver mets or in the liver visceral crisis, the bilirubin have to be more than 1.5 times the upper limit of normal, providing this patient have no Gilbert syndrome or no biliary tract obstruction. And the same thing also with lung visceral crisis, where it has been defined as significant respiratory symptoms that cannot be alleviated by a pleural effusion, because if you have a pleural effusion, you can drain that and get away. And the same thing with the liver, if you have a biliary obstruction, you could drain that, and you might also have a faster symptomatic relief, but that's not a visceral crisis. The CDK4/6 pathway is one of the important pathway that has been found in a number of cancer, and one of them is breast cancer, and those drugs really work on this on hormone positive breast cancer by impacting on the cyclin D, and that's really can impact on the cell cycle arrest, especially in the G1, and those drugs can impact on the cell cycle, and the cell cycle by the impacting the cells on the G1 phase, which is really important to stop the cells from cycling. So those drugs are stop the cell from dividing, and at the end, those tumors or those cells, they will go in a senescence, and then those cells will die as we move forward. The rationale for combining CDK4/6 to endocrine therapy has been illustrated in many reports. Partially, we have seen that almost a third of hormone-positive breast cancer, they do have more kind of de novo resistance to endocrine therapy, and in fact, many of them also, if they don't have de novo, they will develop resistance as we move on, and that's why addition of CDK4/6 can also impact on the de novo. Also, they will delay the development of resistance that might happen with the endocrine therapy, and at the end it will improve those patients or can control the disease for a longer period of time. Right now we have almost 3 drugs that has been approved in hormone-positive hormone-positive metastatic breast cancer. All of those drugs are CDK4/6 inhibitor. The approval that we have is mostly with the endocrine therapy partner. We have palbociclib, we have ribociclib, we have the abemaciclib. Majority or all those drugs has been approved in combination with endocrine. The only exception is probably abemaciclib, where it have more kind of approval also in a single agent immunotherapy. The partner that has been used either AI or fulvestrant. We have Paloma trials for palbociclib. We have Mona Lisa trial for ribociclib, and also we have the Monarch trial for the abemaciclib. If we look at those trials that have addressed the role of CDK4/6 in a first-line setting, utilizing all those drugs, the ribo, the palbo, and the abemaciclib, we can see that we have almost consistent benefit when it comes to progression-free survival that are estimated in a range of 10 to 14 months. All those drugs also showed almost consistent hazard ratio, as you can see here, that are almost in a 0.5 across all those trials that have addressed those agents in a first-line setting. We have Paloma 2 for palbociclib with letrozole. We have Mona Lisa 2 and 3 that have addressed ribociclib with either letrozole or fulvestrant, and also we have ribociclib for premenopausal, and also we have abemaciclib in Monarch 3 in a postmenopausal. All of them have shown similar PFS when it comes to first-line setting. Few have shown survival benefit, and the one that have showed survival benefit to date are the Mona Lisa trial. First, the Mona Lisa 7, which have addressed the role of ribociclib in a first-line setting for premenopausal. And also we have seen Mona Lisa 2, which also have looked at the ribociclib in postmenopausal. And also we have the Mona Lisa 3, which is looking at fulvestrant plus ribociclib in a first and second line, because it's a combination of both. But if you look at those 3 trials, all those trials have showed consistent survival benefit at exceeding 1 year, and this is not something we have seen it, in fact, with chemotherapy before. Monarch 3 is also trial that have looked at the abemaciclib in the first-line setting, utilizing abemaciclib with letrozole, and this trial has been presented at last ESMO, and however they have presented only the interim analysis for this trial, and it showed that there was trending for a benefit, but this did not, the p-value did not really reach to the statistical significant threshold that has been defined. However, further follow-up is warranted, and we'll hear more about this in the future. Paloma 2, also another trial that also have presented last year at ASCO. This trial have also looked at the palbociclib in combination with endocrine therapy. It was letrozole in a first-line setting. Primary endpoint across, it's similar to the primary endpoint that we have with other trials, and this trial have also showed consistent benefit when it comes to the PFS. However, in last ASCO, they have updated the data with regard to survival, and as you can see here, there was no survival benefit that was seen with addition of palbociclib. There was only numerical difference, but this was not reached to the statistical significance that has been looked in this trial. And there is many questions came at that time why we haven't seen such difference in the survival compared to the other trials, namely the Mona Lisa trial. However, when you look at the primary endpoint for those trials are not the survival, but it was the PFS, and And we can see that looking at the primary endpoint, we have seen a quite identical difference or benefit in the PFS with addition of palbociclib with this trial. However, survival difference is quite frustrating not to see the survival benefit with this trial, but there are many reasons that has been highlighted at last ASCO. One of them is because there was some missing data in the control arm, and that might also implicate on the outcome when it comes to survival. There's also some difference in patient population that was also highlighted. One of them is probably the Paloma trial have more kind of worse subgroup, especially those who have short disease-free interval, less than 12 months. So mostly or part of those might be resistance population rather than, and that's not something comparable with other trials. But at the end, there might also be a difference, a real difference between the palbociclib and other CDK4/6, but it's quite difficult to prove such difference since we don't have really head-to-head trial comparison compared those different CDK4/6 that I have highlighted a minute ago. So we have seen quite similar efficacy when it comes to PFS. We have seen survival difference with the specific agent. What about the quality of life? The quality of life also showed was in the line of the efficacy data. We have seen the quality of life either improved or maintained with addition of a CDK4/6 inhibitors to endocrine therapy, and this was seen across different drug. For example, here we have Monalizumab for the premenopausal, we have Monalizumab for postmenopausal, and also we have Paloma-2 for the postmenopausal with addition of palbociclib. All of those trials showed either improved as what we've seen with Monalizumab or either maintained and as what we've seen with also Paloma-2. And the same thing we have also seen with trials like Monarch 3. All those trials showed there's no detrimental impact on the quality of life, and this is something we need to keep in mind. We also those drug also has been tested in a second line. In fact, the initial trial for the CDK4/6 was addressed the subsequent line, and we have 3 trials. We have Paloma 3, we have Monarch 2, and we have the part of the Monalisa 3 that also addressed the second line treatment. And here we can see that also there was a clear, consistent benefit when it comes to the PFS for the addition of palbociclib to a fulvestrant in a second line. This was seen in a Paloma 3, Monarch 2, as well as Monalisa 3. The only difference here, you can see that the baseline or the control placebo, the control arm in the Paloma 3 have 4 months compared to a 9-month with the Monarch 2 or Monalisa 3, and that's because patients that were included in Paloma 3 he's been heavily pretreated, multiple line, including chemotherapy. However, when you look at the hazard ratio, it's almost identical for palbociclib as well as abema and ribociclib, showing that there is a clear class effect among all those drugs. Quality of life or the survival also has been shown in a second line utilizing CDK4/6 in addition to fulvestrant, and here we can see also there is a clear survival benefit across all those trial, Monarch 2, Monalisa 3, and also the updated for the Paloma 3, and thus such benefit also has not been even seen with chemotherapy for such disease situation. Quality of life also in the line with the quality of life that has been observed with the first line setting across different trials. Here we have Paloma 3, we have Monalisa 3, and we have also the Monarch, and all those trials showed improved quality of life, like for example in Paloma-3 we have seen improved quality of life in favor of palbociclib combination, while in the MONALEESA-3 and other trial we have seen, and the Monarch we have seen maintained quality of life, and that's really enforced that addition of CDK4/6 really impacted positively in the quality of life, or at least maintain the quality of life, which is something quite important to keep in mind with such a disease. The other questions is the role of CDK4/6 in a premenopausal patient with metastatic hormone positive breast cancer, and we only have one trial that have addressed this in a pure clinical trial, which is the MONALEESA-7, where they have addressed premenopausal as a specific subgroup in a trial that have addressed the role of CDK4/6 with ribociclib and addition to endocrine and with LHRH, and this trial was positive, as we have highlighted a while ago, with PFS, survival, as well as quality of life. But if you look for the other trials, looking at the other agent like palbociclib and the abemaciclib, you can see that premenopausal has been included in a small proportion of those patients, either 20% in Paloma-3, also around 17% in Monarch 2. And in those trials, we have seen that also there are those patients, they did quite well, and they have also achieved a similar benefit when it comes to the PFS and survival. For premenopausal, what's really matter, in fact, is they need to be considered for a chemical castration, gozulin, or other LHRH in order to utilize the options that might be also valid for postmenopausal, including AI, fulvestrant, and definitely the addition of CDK4/6 combination. So most of the clinical trials is really important, and most of the decisions that we have with approval and new drugs, and just to have a clear concept on the benefit of each drug, it need to come from a clinical trials. However, one of the limitations for clinical trials is in clinical trial they cannot include everyone, because in real life practice we have seen that there are many patients who might not be eligible for clinical trials, but at the end you need to treat them. So the real world data can help us in a way to assess the effectiveness of a drug in a patient that might not be represented very well in the randomized control trials. Definitely there is also a limitation with the real world data, because there is always a bias, since there are many confounding factors. There is lack of randomization and blinding, the way we do see with the clinical trials. So I would say real world data is more kind of supportive and also enforce the benefit that was seen in clinical trials, and also address the population that might not be well representative in a clinical trials. Palbociclib, in fact, is one of the drugs that has been introduced earlier in our practice, and that's why when it comes to palbociclib, we can see there are many real-world data that has been addressed thousands of patients, and you can see this is just an example of real-world data that have looked at this drug in the real world setting from different countries, from different almost 12 countries across the world, and I will not go through all of them, but I will go with one of them, which is the P-Reality X, which is also a more kind of a real-world data retrospective cohort analysis for one of the US database to including those patients who are postmenopausal, those who has been treated with AI and palbociclib. There are a number of endpoints has been looked at, but mostly the survival, which is the primary endpoint. There is also a number of secondary endpoints. As you know, when you deal with real-world data, there's always limitations. One of those is there might be imbalance between those arms, especially when you look at the palbociclib combination with AI versus AI, and to overcome this, you need to look for, they did for more kind of statistical way of statistical adjustment, and one of the statistical modality they have used is as a stabilized inverse probability weighting. The importance of this kind of statistical model is try to balance the factors that might be imbalance between the two arms, especially when you look at the AI versus AI and palbociclib. Here, for example, one of the important factors that might impact on the outcome, we have visceral disease, we have the age of patient, and also we have the performance. If you look at the arms before the adjusted, you can see here there are more visceral disease in one arm. And the same thing when you look at the age distribution is quite different among those arms, and the same also applied for the performance. So by adapting this kind of statistical model, you can balance those important prognostic or predictive factors. Here you can see that the visceral disease is being balanced between AI and AI with palbociclib, and the same also concept with the age distribution is being balanced once you adapt this statistical model. And also the same thing with performance, and you know performance is one of the important prognostic factor that might also help with that. After they adjust those analyses, what has been shown with this database that there was a clear survival benefit in favor of palbociclib with AI compared to AI. This was seen in the unadjusted analysis, but also with adjusted analysis, there was a clear benefit with the survival that was not even seen earlier with the clinical trial that I have highlighted. So this real world is showing that the AI with palbociclib is more effective, and in fact it showed survival benefit for those patient population. We have highlighted that the efficacy is really important. The PFS seem to be quite consistent. We have seen few difference with the survival. We have seen quite consistent benefit with the quality of life. The other important point and a way to differentiate between those drugs is the toxicity, and we have seen quite different toxicity profile with those three drugs. The most common side effect that we do see with those drugs is the bone marrow suppression. It's quite common across all those three drugs, but it's more pronounced with palbo and ribociclib, less with abemaciclib. GIT symptoms, like especially the diarrhea, is more common with abemaciclib compared to other CDK4/6. QT prolongation is somehow classical to the ribociclib. At the end, fatigue is more kind of classical symptoms or classical side effect that happen with all those CDK4/6. If you put this in number, you can see that the side effect or the neutropenia is quite common. When you look at the grade 3 in particular, you can see that the grade 3 fibroneutropenia is more than 50% with palbo and ribociclib, while it's less than 20% with abemaciclib. QT prolongation is somehow classical for ribociclib, but it's really small percentage, in a 3%. Diarrhea also is quite common with abemaciclib. Grade 3 is almost 9% in those patient population. Liver toxicity is seemed to be more pronounced with ribociclib as well as abemaciclib, but less with palbociclib. And at the end, fatigue is quite common across all those drugs, but the side effect or the grade 3 is less than 2% across all those agents. So those side effects is really important. In a way, if you know them ahead of time, you may be able to try to be proactive and try to control and monitor them. Diarrhea is really important, especially with abemaciclib, but it might happen with other drugs. And you need to be careful with that and just try to use antidiarrheal treatment ahead of time and keep the patient around you for any or at least you have their contact number in a way to adjust their treatment in case if you need. Hepatotoxicity is something more common with abema, ribociclib. Liver enzymes need to be assessed periodically, especially in the first 2 months. QT also is really important. For ribociclib, count or bone marrow suppression is something common across all those drugs. It's really important to watch that in the first few months. VTE is something classical for abemaciclib. ILD is quite uncommon, but it can happen with any one of those drugs. Starting with bone marrow suppression, and first thing, I think it's really important to monitor CBC in the before starting the first cycle, but also you need to assess that in the first few months. And most of the time you don't have to reduce reduce the drug unless the count go below 1,000, especially if this is more kind of a persistent with fever. Otherwise, the neutropenia is here with CDK4/6. It's not like the neutropenia that we do see with chemotherapy. So once you hold the drug, the count will recover, and then you can resume at the lower dose once you have kind of a grade 3 or grade 4. Diarrhea also is something common with abemaciclib. So those patients, they need to have loperamide ahead of time, and they need to also have to contact you within the first few weeks, because most of the side effects happen in the first few weeks, and once it developed, then you need to grade that, and based on the grading you can adjust the dose or hold the dose for a few weeks till it's recovered, and then you might go to the next dose adjustment that might be required for such indication. QT prolongation is something quite uncommon, but it happened with the ribociclib, and it's really mandated to have an ECG before you start the treatment, and then twice for the next few weeks, especially before the second cycle as well. And the important point when you look at the QT prolongation is try to avoid those drugs that might also have more kind of that can also impact on those QT prolongation that might happen with the ribociclib. So the concomitant medication is really the most important part when you look at the ribociclib, and that's what's one of the concern with this drug when you use it in practice. The other side effect is hepatobiliary, which is also something less common, but it might happen with ribociclib and abemaciclib. And based on the grade, you can also adjust, hold, and but for a grade 3 or 4, you may have to discontinue the treatment for those indications. So at the end, when you look at the guideline, from a guideline perspective, we can see that the ESMO have looked at what we call it magnitude clinical benefit of scale, which in this scale they have looked at different drug, looking at efficacy data, including survival, PFS, as well as quality of life, toxicity, and the only one that have scored 5 was ribociclib for a premenopausal. But when you look at the other drugs like palbociclib, abemaciclib, and others, they have scored 4 and first, as well as 4 or 3 in the first or second line setting. NCCN guideline also have shown that all those 3 drugs as an option in a first or a second line setting. However, they only categorize ribociclib and abemaciclib as a category 1, but palbociclib is also still as an option that can be used in a first as well as second line setting. CDK4/6 beyond progression is also something has been looked at recently. Initially, we have one data, which is the maintain trial that has been presented at ASCO. Those patients who were included are those who has been on CDK4/6 and progress, and most of those CDK4/6 was palbociclib. When they progressed, they has been shifted to ribociclib plus different endocrine therapy or endocrine therapy plus palbociclib. So it's more kind of maintaining CDK4/6, but switching kind of the particular CDK4/6. The primary endpoint was PFS. This was a small phase 2 clinical trials. What we have seen here in this trial that there was a small benefit that has been observed with kind of maintaining CDK4/6 with the ribociclib, but it was quite small. The benefit was small. It's not really, cannot drive any clear conclusion. And it's not really changing the practice. We also have another trial that have also addressed it plus San Antonio, looking at the combination of or the continuation of palbociclib beyond progression. There's also a third arm which have looked at the addition of immunotherapy, which is avelumab. The result of this trial did not really show that addition or the continuation of palbociclib at benefit. However, it have shown that with addition of immunotherapy like avelumab, you may have also additional benefit that are also modest for this kind of a small clinical trial. So at the end, let's go back to our case scenarios. This patient, the one I have presented earlier, the 52-year-old postmenopausal lady with hormone-positive metastatic breast cancer. She relapsed while on adjuvant tamoxifen. She was started on CDK4/6 plus letrozole. The CDK4/6 was palbociclib, and this was started in November 2019. And after around 6 months, patient was have a complete response in her liver. Also, she has a remarkable response in the bone lesions, and she's right now she's still maintained on the endocrine therapy combination for almost 3 years. She only required 1 dose adjustment for a grade 3 neutropenia. Otherwise, she's doing well with this combination. So the take-home message, I would say, it's CDK4/6 substantially changed the natural course of hormone-positive metastatic breast cancer. Yes, we have seen unprecedented survival benefit with selected CDK4/6 inhibitor, but the real-world data, in fact, also supporting the clinical trial finding that we have seen. We also have seen maintained improved quality of life. The toxicity are bit different among CDK4/6, and that might be another important distinction between those different drugs, and also it might help you to make those decisions among the right agent for the right patient. Still, there is quite limited role for the CDK4/6 beyond progression, and there are many options right now. It's been addressed, including mTOR inhibitors, and as well as other AKT and other pathway that also might be more important than in the continuation of CDK4/6 for such indications. Thank you so much.
Thank you, Dr. Abdullah, for this comprehensive overview. And we have time for 2 questions or 3 questions from the audience. Okay, can I start with the first question? I know it's difficult to answer, but regarding the overall survival data that we have with ribociclib and the NCCN guideline showing category 1, as you mentioned, 2023, do you think they are the same, the CDK4/6 inhibitors? What's your choice as first-line treatment? What's your comment about the different CDK4/6 inhibitors and the overall survival that reaches more than 5 years?
Yes, thank you so much. I agree. That's a quite difficult question, and I understand that the CDK4/6 in the past, we think they are the same, but right now we understand they are different. It's not just the difference in the data that we have in advanced setting, but also we have more data in the adjuvant setting that also might also give us the same concept that probably we are dealing with a different agent. However, when you look at the drugs, when you look at those agents, we can see that there is quite significant efficacy data when it comes to the PFS. There might be a quite also distinction in the toxicity. Yes, we have seen survival benefit with ribociclib, but we fail to see this with palbociclib, and still we are looking also for the survival with abemaciclib. Many things came up from as probably why we haven't seen that benefit with palbociclib. Most of them have to do with some changes, or some genuine things with the clinical trials, but I don't think from those trials we can say that one of them is superior to the other, because I don't think we have trials that have compared those agents in a phase 3. So most of the time we just do cross-trial comparison, and sometimes we might have this might give us that, or at least can highlight that there might be difference, but it doesn't really prove the fact that there is a clear difference between those drugs, since we are lacking comparative clinical trial addressing those differences.
Okay, any questions from the audience? Okay, by this, I would like to thank Dr. Abdullah for this comprehensive overview about the role of CDK4/6 inhibitors in the management of advanced breast cancer. Thank you, Dr. Abdullah. Hopefully next year we'll see you face to face. Thank you. We'll move to the next session.
Hi, Lucy.
Hello, how are you? Nice to see you.
Can you hear me?
I can hear you and I can see you. Thank you for having me.
Good to see you. It's unfortunate we made this as a virtual online meeting, but logistically it's much easier, and since there are lots of traffic restrictions, so we thought, travel restrictions, I thought we make it virtual is much better.
I understand.
Okay. Well, it gives me a great pleasure, dear colleagues, to present Dr. Lucy Godley, who is familiar to almost all of you because she was here 3 years ago during one of our meetings. And since Chicago and Amman are twin cities, obviously we would love to see twinning also between our institutions and her institutions. Dr. Godley received her scientific training in Marchese, Yale, Wiley, Harvard, Barmus, UCSF, NIH, laboratories, and medical training in Northwestern University, after training in internal medicine and hematology oncology at the University of Chicago. She obviously loved Chicago, so she joined the faculty in Chicago, where she has been studying the mechanisms of inherited hematopoietic malignancies and the new agents, how this can potentially improve the patient life and patient treatment plans and roadmaps. Well, Dr. Godley, the floor is yours. We welcome you to Amman. Hopefully we will see you next time.
Well, thank you so much for having me virtually, and I also would love to be there in person. So hopefully travel will get easier over the next year and we can see each other in person. Let me share my screen. Let's see, this is the one I want. And let's see, how do I go to play from start? Okay, hopefully you can see that now in the right mode. If not, just let me know. So I'm going to talk to you about germline or inherited predisposition. Actually, those terms mean something slightly different, so I thought I would just explain that right at the beginning. So germline means that this DNA change is in the germ cells, either the eggs or the sperm, so that that individual who has a germline predisposition allele can pass it on to their offspring. Inherited means that that DNA change was inherited from the parents. So the distinction can mean that we have de novo DNA mutations in some individuals, meaning their parents were normal, so to speak, but in the formation of the embryo, there has been the perpetuation of some DNA change. And I just had an email this week, actually, from an investigator who used DNA sequencing to prove that the parents were actually the parents of the patient. The parents did not have the germline variants, but the individual did. So this was a bona fide de novo DNA variant. And I think at least I a priori think that de novo DNA variants would be very rare. Actually, we see them pretty frequently. So there is a slight distinction between these terms, germline and inherited. So just to begin, I always like to say thank you to all of you for including me, and then most importantly to my patients. I was not studying germline predisposition to hematopoietic malignancies, but as I took care of my patients with leukemias and other hematopoietic disorders, I became convinced that they were programmed for these diseases. And that really led to all the work that I'm going to share with you today. In the lab, we have a lot of people really dedicated to this topic, and so I really thank them, as well as my colleagues at the University of Chicago, Soma Das especially, who developed the testing platform that I'll share with you, Jeremy Siegel and James Vardaman in our Department of Pathology, and we work very closely with them. We have a separate, what I would call tumor-based molecular profiling assay to prognosticate for hematopoietic malignancies. And we toggle between the molecular profiling of the hematopoietic tissue with the germline testing, and we can talk about that as well. So to start, I have this sort of layered way that I think about patients. I think probably a lot of you share this as well. Everyone begins with their baseline genetics and epigenetic changes, what we call the germline. Over time, we develop, acquire somatic DNA changes in our hematopoietic stem cells, actually in the stem cells of all of our organs. Within the hematopoietic tissue, we now call that clonal hematopoiesis. And that then in turn leads to additional acquired variants that eventually give us this hematopoietic tumor. And now we use the tumor-based profiling to really prognosticate and to choose particular therapies. And then the last layer, maybe it's not the last layer, but an additional layer that I think is going to play more of a role in the future is understanding the microbiome. So all of the bacteria in our intestines, on our skin, and probably throughout our organs are metabolically active organisms that are producing chemicals that also have an impact on our cancer risk. And that's also influencing our immune system, which plays a very important role in surveying for cancer. So I think really when we put all of this together, we're really going to be able to do well for patients. And I'm going to give you one example where we've really tried to do this. So this is right now how I think about the different genes in which deleterious variants give risk to hematopoietic malignancies. And I have to say the category that these genes go in changes over time, usually moving more from the left into the columns more on the right, because for all of these disorders, the initial clinical description is too narrow. And we see this again and again. As we're doing more and more agnostic molecular testing, we are seeing people who have tumors that were not in the initial clinical description, but it's hard to imagine that these germline mutations are not playing a role. So all the way on the left, these are genes that right now deleterious variants are recognized to give risk for myeloid malignancies. In the next column, genes that give risk for lymphoid malignancies or immunodeficiencies. And I do have a bias that if a gene gives an immunodeficient phenotype, it will also predispose to lymphoid malignancies. That's still to be proven for some of these. In this third column here, we have genes that give risk to both myeloid and lymphoid disorders. And finally, all the way to the right, genes that give risk to both solid tumors and hematopoietic tumors. And as I said, genes are tending to move from the left into the columns more to the right. So one problem with this field is we're learning more and more, and so our knowledge keeps changing over time, which can be difficult. So I want to give you a real case that came to me and really kind of crystallized for me what is possible these days. So one of our oncology nurses was diagnosed with breast cancer. This was diagnosed on a routine mammogram. And when she went for the evaluation of that breast cancer, they took a family history. And this is what the family history looked like. This is our patient with breast cancer. Her mom had been diagnosed with breast cancer in her early 50s. And there was a sister of her mom, the aunt, who also had breast cancer. And her maternal grandmother had been diagnosed with ovarian cancer. So based on this clustering of breast and ovarian cancers, she was recommended to have germline genetic testing. And that germline genetic testing revealed a CHEK2 I200T, or you may know it as the I157T allele. Now, this allele in the breast cancer field is considered a weak risk factor for breast cancer. But as I'm going to show you, in our patients, we ascertain on heme malignancies, half of our families have this exact allele. So I'm not convinced that this is a weak allele for heme malignancies. To me, it's a strong allele. But amazingly, this nurse came to me and she said, Lucy, I have this CHEK2 variant that I think you talk about a lot, and I think you made a mouse that has my mutation. And I want to know what you learned from your mouse. What does it mean for me? I don't want to have any therapy until I learn, what do you know about this allele? And this was pretty amazing to me that this nurse, first of all, even remembered that we had made a knock-in mouse of this allele and really wanted to know what we knew about this allele before she had any therapy. So let's just take a break from the case for a moment and talk about CHEK2, actually the entire homologous recombination DNA repair pathway, starting with double-strand DNA breaks, activating ATM kinase, which activates CHEK2, and then CHEK2 has a bunch of downstream targets that are all of our friends in terms of germline predisposition in cancer, P53, BRCA1, BRCA2, that activate cell cycle arrest to repair that double-strand break by homologous recombination, which is using the normal strands on the other chromosome to correct the defect. And this is the best kind of DNA repair. It makes the fewest errors. But our concern, of course, is if someone has a germline mutation in genes in this pathway, that homologous recombination DNA repair pathway will not be very good. And the hematopoietic cells will start to use backup DNA repair pathways that are very error prone. We'll talk about the implications of that in a minute. So this is what we see, and it's biased. You know, I'm a leukemia doctor, so I see patients with hematopoietic malignancies, but this is the kind of thing that we see. So on the left, I give you a representative pedigree, and this is actually, I would say, CHEK2 family number 1. The proband here was a young woman. She was 35 years old when she was diagnosed with myelodysplastic syndrome. And now I hope that age and MDS, 35 and MDS, would ring some bells for you as to why in the world is a young person getting MDS. We'll talk about that too. And she's a physician, actually. And so when she was diagnosed with this CHEK2 variant, she didn't like the sounds of that. And she went on to have an allogeneic stem cell transplant. She did very well. And as she was recovered from her transplant, she was concerned about the solid tumor risk associated with the CHEK2. So she had a breast MRI, which is obviously more sensitive than mammogram. She was found to have a small left-sided breast cancer, had that removed, then had a thyroid ultrasound, had a small thyroid cancer. And so it does feel a bit like whack-a-mole. These people, you know, have this variant in all the cells of their body. They are continually at risk for cancer. But with increased surveillance, we can detect those cancers at a very early stage, and those procedures can be curative. So she considers us to have saved her life 3 times. you'll see that her mother died of multiple myeloma. She also had the CHEK2. Her uncle also had the CHEK2 variant, had a B-cell lymphoma, and then there's great aunts with breast cancer. So this is very typical of what we see in our CHEK2 families, a mix of myeloid and lymphoid hematopoietic malignancies with solid tumors in there as well. And when we look across all of our pedigrees, again, ascertained on heme malignancies, we see many, many, many types of alleles in CHEK2, and half of them have this I200T or this I157T allele. So this says to me that there has to be something about this allele that keeps reading out as heme malignancies. Or you could argue it's just common in the population. So of course you're going to see it because it's common in the population. And Amman and Chicago are sister cities. That's true. We are also the third largest Polish city in the world. If you look at people of Polish descent, and the I200T is relatively common in the Polish population. So you can argue that we're only seeing this allele because of population statistics. So then we did a burden calculation. We said, are we seeing this I200T just because it's common? Or is it actually enriched because there's some association of this mutation with heme malignancies? And you can see the p-value here. Essentially, we are seeing an enrichment of the I200T. This is not just a function of population. And we bias this calculation using the population frequency of this variant in the most common, in the population in which it is the most common. So we tried to make the calculation as difficult as possible to show this enrichment. We also see the enrichment for the S428P allele. This is the Ashkenazi Jewish founder allele. And when we did these statistics, we actually did not see it for the 1100 del C. This is considered a stronger allele for breast cancer. After we've done this calculation, we actually have a few more patients with heme malignancies with this allele. So maybe if we redid the calculation, we actually would have statistical significance now. But I think this suggests that the CHEK2 variants are context dependent. The I200T or I157T may be relatively weak in the breast. It's a stronger allele in the heme malignancies or in the hematopoietic tissue. And maybe 1100 del C is stronger in the breast and a weaker allele in the hematopoietic tissue. So that's maybe something for the future to look at. But I do think this the I200T is a strong risk factor in the hematopoietic space. When we put all of the observations together and we look at the type of malignancies that we see, you can see we see primary myeloid malignancies, therapy-related myeloid malignancies. We see solid tumors, we see lymphoid, we see myeloma and other non-Hodgkin's lymphomas. And the age at which these present spans the entire age range of life, from young, mid-20s, out into the 80s. And this is a very, very important point, I think, because when we learned cancer biology, we learned if you have a germline mutation, you will present young for your disease. And I think people took the other side of that coin to be, if you present in an average age or older age, the germline is not playing a role. And this is absolutely not true. The germline alleles are playing a role throughout our entire lifespan, which is a little difficult to think about exactly how does that work? How is the germline affecting you way, way out in age? But I think that's what we're observing. We'll come back to that in a little bit. Now we look at the heme malignancies and we say, is there anything special in the heme malignancies? Is there any signature of these defects in CHEK2? Remember, CHEK2 is essentially recognizing double-strand DNA breaks. So we were then not that surprised that there's actually no mutational signature that we can see, but we see a cytogenetic signature. So we see reciprocal translocations more commonly in the CHEK2 mutation carriers. This makes sense because if the cell is having trouble repairing the double-strand DNA break, it's just going to glue ends together and you get a translocation. Now, let's talk about clonal hematopoiesis for a second. People are very interested in clonal hematopoiesis. They're very interested in what are the risk factors for an individual developing clonal hematopoiesis. And people have done population studies and said, what are the germline variants in the general population that are giving risk to clonal hematopoiesis? And the number one gene is CHEK2, and the allele I200T reads out. Not a surprise, because if you have a DNA change that's been acquired in the hematopoietic stem cell and you try to fix it, but you have a germline mutation in CHEK2 and your homologous recombination DNA repair pathway is not functioning perfectly, you're going to use backup DNA repair pathways that are error prone. So you're going to not fix that mistake, or you're just going to make more mistakes as you try to fix it. And that's clonal hematopoiesis. You're going to perpetuate acquired DNA changes in your hematopoietic stem cells. And once you have that change and you can't fix it, now you're on your path to getting a hematopoietic malignancy. So when we kept seeing these CHEK2 changes and we knew the solid tumor cancer field didn't think CHEK2 was a big risk, we thought, how are we going to test that the CHEK2 is actually more deleterious in the hematopoietic space? So that's where we got the idea, make a knock-in mouse. And a lot of people these days, when they make these knock-in mice, they do very fancy things. They turn the gene on and off in different tissues, but that's not what people do, right? People are just either born with these variants or not. So we made an old-fashioned knock-in mouse. The mouse looks like the people. It has this variant in all of its tissues. It's expressed like the regular CHEK2, and the equivalent allele in the mouse is I161T. So this mouse kind of looks like the people. We put it on the shelf, we let it live its life, and we ask, does it get breast cancer, colon cancer, thyroid cancer, or heme malignancies? Throughout its life, it has a relatively high white cell count, a high lymphocyte count, and neutrophil count, either when it's in the heterozygous or homozygous state, and people too can be homozygous for this allele. It's consistent with life. What happens to the mouse? You can see it here. It starts dying about 1.5 years into its life, either heterozygous or homozygous. And the big question is, why were they dying? Breast cancer, colon cancer, etc. This mouse only gets, well, here's a question. First, you're going to ask me, does it get clonal hematopoiesis like the people? I don't know the answer to this yet. We've tried to answer this a couple different ways. It's actually not that easy to answer this. So we're still in the middle of trying to answer this, but I can tell you why the mouse dies. The mouse dies of every type of heme malignancy you can imagine. Myeloid malignancy, lymphoid, T-cell, B-cell, has never gotten colon cancer, solid tumor, breast cancer, thyroid cancer, etc. We've only seen heme malignancies. Now, some people push me a little bit on this and say, okay, the mouse was the C57 black 6 background. That background of the mouse makes heme malignancies kind of easily. So it's possible that the genetic background of the mouse did bias us to getting the heme malignancies, but I think it's the best we can do. We have not back-crossed the mouse to other strains, but this is the model that we have right now. I think it's pretty good argument that this allele predisposes to heme malignancies, at least as best as we can test. When we look at our patients with heme malignancies and we look at germline predisposition, we keep coming back to homologous recombination DNA repair. We see so many patients with mutations in this pathway. This first came apparent to us as we were testing women who had developed therapy-related leukemia after breast cancer, and many of them had germline BRCA1 mutations, made us think that BRCA1 had an important role in the hematopoietic space. At the time, BRCA1 was not recognized to be a Fanconi anemia gene, and our work showing that BRCA1 knockout in the bone marrow gave a mitomycin C sensitivity exactly like Fanconi genes was part of the evidence that led to the definition of BRCA1 as a Fanconi gene. And we're actually trying to publish right now our observation on germline BRCA1 and 2 mutation carriers that half the time they develop a heme malignancy before a solid tumor. Again, when we ascertain on heme malignancies, I have to tell you, it's been amazingly difficult to publish this observation. The BRCA field, from my perspective, is a little bit nervous that we're essentially saying that heme malignancies should be considered within the tumor spectrum of BRCA mutations. And I think the field is a little resistant actually to this idea, which is surprising to me. But I think it's another example of where clinical descriptions are too narrow. And over time, we learn that more and more tumors are part of the tumor spectrum of the disease. So for me, BRCA 1 and 2 are extremely important disease, germline disorders in the bone marrow, and even the heterozygous state can predispose to heme malignancies. So let's come back to our case. What did I do for my colleague? So I told her, you have a defect in homologous recombination DNA repair. You are at risk for clonal hematopoiesis. If you have clonal hematopoiesis and we give you chemotherapy for your breast cancer, we will select for that TP53 mutant clone, and we will set you up for a therapy-related leukemia. So let's ask, do you have clonal hematopoiesis? If you do, we have to be very careful what chemotherapy we give you. If you don't, we still have to watch you closely, but I think you can feel very comfortable to get whatever chemo you want. So we assessed for clonal hematopoiesis. Fortunately, she did not have it. And she elected for bilateral mastectomy, cytotoxic chemotherapy. We will follow her very closely, of course, but we felt very comfortable first assessing her for clonal hematopoiesis. A much more difficult question would have been, what would you have done if you found a TP53 mutant clone already? What kind of chemo would you have given her? And I think this is the challenge for the future, to enroll these patients in studies and really watch, what are we doing now that we understand more about the relationship between solid tumors and hematopoietic tumors, the relationship of chemotherapy and radiation to that process. So age, what does age tell us about disease mechanism? So we had this bias, right, that we had from learning cancer biology, that if you're young, getting an old person's disease, there has to be some reason. So this was back in the day when we were trying to determine what's the frequency of germline predisposition alleles. We decided to pick a population where we would be enriched for these germline mutations. So we decided to look in MDS arbitrarily in the young. And because I'm an adult oncologist, we picked from 18 to 40, so way down here. It's very rare to be diagnosed with MDS in this region, age range. And so we thought maybe these people have these germline mutations. So again, arbitrarily chosen the age at which you were diagnosed with MDS. We did allow aplastic anemia because of the diagnostic overlap with hypoplastic MDS. You can see the breakdown here. We had many, many colleagues around the world who contributed samples. We had about 120 samples. Most of these were bone marrow aspirate samples, and we grew out the non-hematopoietic mesenchymal stromal cells to be able to determine germline alleles. And here I want to make the point about variant curation. So be very careful when you read the literature these days on the germline, because people are a little bit sloppy in how they're doing their variant curation. They're using automatic programs to tell them whether a variant is deleterious or not. Generally, these programs overcall the pathogenicity. And I want to emphasize that these variants were hand curated. So we did not use any computer programs, hand curated the variants. And so you can really believe that these are likely pathogenic or known pathogenic. The truth is probably higher than this. We called these variants very, very conservatively. In genes, you would not argue about. With pathogenicity, you would not argue about, but my heart says the truth is really higher. We probably called some variants of uncertain significance that are actually pathogenic. So even with that, I would say it's a lower estimate of the truth. About 20% of MDS in this age group is germline. about 15% of aplastic anemia. And if we compare this to what our pediatrician colleagues were doing, they were doing exactly the same experiment with people in their age ranges. We see that the age of presentation, at least of MDS, but I would argue to you all heme malignancies, is just a surrogate for biological pathway. If you have a very young person with MDS, it's probably SAMD9 or D9L. In the teenage years, we get into GATA2. In the young adult, DNA repair and telomere biology. And if someone presents in the average age range for MDS, older, DDX41, we'll come back to that in a minute. So you can almost predict the gene by the age at which they present with MDS. But obviously here we have a gap and we wanted to fill the gap. And the way we filled the gap, or at least started to fill the gap, was we talked to the International Bone Marrow Transplant Registry. And the CIBMTR has the MDS patient and the relative who was the donor for the patient. And because you have that family structure, if you see the same variant in the patient and the related donor, you can call germline. We do that by segregation. So it's not an ideal experiment because we're using peripheral blood, and peripheral blood is not ideal for looking for germline because of somatic reversion. But again, it's going to give us a lower estimate. So we took 400 MDS patients, 400 related donors, did our sequencing, did our variant curation. Here we curated 20,000 variants by hand. We did 300 real-time PCRs to look for copy number variants. And this is very important because copy number variants are common germline alleles. So it's very important when you're looking at the germline to think about the copy number variants. And so the other thing that's really important is to think about the mode of inheritance. So if a syndrome like Fanconi anemia is autosomal recessive, you have to show that the two deleterious variants are on different chromosomes in trans. So we would only call an autosomal recessive condition if we could show two deleterious variants in trans. And we actually had another pair we could not show because of the distance of the alleles that they were in trans, so we didn't count it, but we know that it's probably there. So we were very, very rigorous about matching the type of inheritance, autosomal recessive to in-trans deleterious variants versus autosomal dominant. And here again, I would say pay attention to the literature because many of the papers that you see published now are calling heterozygous recessive variants as deleterious, and that is not okay. So be very careful. So what was the answer? The answer is everybody together, 7% of MDS going to transplant with a related donor is germline. Again, very conservatively called. The important thing is that if you look at the age range, the positive rate is over 5% at all ages. Yes, there is a peak in the younger patients, but this tail is over 5%. This means germline predisposition exists across the age range. Again, it's different from what we were taught. The problem with the experiment is, or the study, is that we had a smattering of everything. So we really can't look at outcome. If you put everything together for outcome when you use these deleterious donors, we don't see a signal for poor outcome in the recipient. But I think the devil's in the details. We don't have the power in any particular disorder to say whether the outcome was bad. So we need a much larger study. Again, the mutational spectrum, which we can call because we had MDS blood from the patient, is nothing that screams out at you. There's nothing special about it. Are the genes the same as what we saw actually in the 18 to 40-year-old study? So we pull that bubble of DNA repair and telomere biology out into the whole adult age range. Now let's talk about DDX41 just for a minute. It's such unique biology, and for those of you who are adults, hematologists, oncologists, DDX41 is, for most populations, the most common germline predisposition disorder. So it's very, very important. You see here at the top all of the germline variants that have been identified to date, and you can see this pileup in certain regions, and these are very population-specific variants. So the A500 frameshift is common in Japanese and Korean populations. The D140 and the M1 question mark are more common in Northern European. And I have a bias here about the P78 frameshift. You can see right here, you can see two bubbles here. One of those is a Jordanian American family. And I know that in your center there at the King Hussein Cancer Center, you have another family with the P78 frameshift, at least one other. So I do wonder if the P78 is maybe a Jordanian specific or maybe a Middle Eastern specific mutation. We do see these population the certain deleterious variants more common in certain populations. So I think it's very important when we think about DDX41 that we think in population-specific ways, and that we realize that in the databases, like in UK Biobank or in the United States All of Me databases, you can see deleterious DDX41 variants. They are that common. Now, what happens in the heme malignancy is it acquires a mutation on the other allele, or it can just lose chromosome 5. So you lose the wild type allele. Here we see it overwhelmingly common, the R525H acquired allele in the heme malignancy. So there are a couple of others where you can see these hot spots, but R525H is the most common. Now, what's really interesting about DDX41, it challenges this idea that a germline mutation gives you disease in the young. We see the tumors in the older people. It is very rare under the age of 50 and extremely rare under the age of 40. Everything happens after 50. What is the biology driving that? We really don't know. Now we've been dividing our pedigrees by those that have only heme malignancies and those that have solid tumors. And I don't have the numbers really concrete yet for you, but essentially what you can see is when you have the families with the heme and solid tumors, it's very common for them to have second germline variants that are driving the solid tumor. It's DDX41 with CHEK2, or DDX41 with BRCA1, or APC, or CDKN2A. It's really fascinating. And families that just have the heme malignancy just have the DDX41. So this is, again, something to think about in terms of biology and for us to model and test. This is the model that we have in the heme malignancy. When you have the germline DDX41, you have to knock out the other allele to transform. You either do that by losing chromosome 5 or you gain the R525H or one of the other mutations. And then probably your immune system is defective because of that germline mutation, and that fails to suppress this transformed cell. We think DDX41 is pro-inflammatory. I'll show you that in a second, which perpetuates this mutation. Now, on the solid tumor side, we do not see the acquired R525H in the solid tumors. This is what gave us the idea that something else is driving the solid tumor. Say it's CHEK2, BRCA1, that's driving the solid tumor. And maybe the DDX41 in the immune system, that pro-inflammatory state, is failing to suppress and contributing to that malignancy. It's also possible the DDX41 is not playing a role at all in the solid tumors, but I suspect that it is. Again, it's just a model for testing for the future. Now, why do I say DDX41 is pro-inflammatory? The reason I say that is actually from what we see from allogeneic stem cell transplant. So for most of these germline disorders, when we transplant people with wild-type donors, all of our trouble goes away. And that's what I told our patients with DDX41. We're taking you to transplant. We're using a wild-type donor. You have nothing to worry about. Then they died of graft versus host disease. Absolutely awful GVH that you could not control with any of our modalities. So I felt terrible and started talking to my friends who were genotyping for DDX41 around the world heading to transplant. Half of my colleagues said, oh, we see the same thing. The other half said we never see it. So we compared the transplant regimens in these two groups. And essentially what we could see was the use of post-transplant Cytoxan ameliorated this situation. What I think is happening is that the germline DDX41 is pro-inflammatory. And as these normal T cells are developed, they're coming out from the graft, they're exposed to this inflammation from the DDX41 and the T cells go crazy and give you this GVH, but you can suppress it with post-transplant Cytoxan. So now I feel very, very strongly that if someone has a germline DDX41 heading to transplant, they have to have post-transplant Cytoxan. And I know those of you who are transplanters may think all patients anyway should get post-transplant Cytoxan, but I think definitely for the germline DDX41 mutation carriers. So this is just a summary of what we know. They're very unique aspects of DDX41. One thing I didn't mention yet, but what we have found is that we do not see clonal hematopoiesis decades before malignancy. It may be, again, that the DDX41 malignancies happen so late, the presence of clonal hematopoiesis acts like a molecular clock, if you will. And we may be looking too early, possibly. Malignancies develop later in life, myeloid more than lymphoid, and men more than women. That's also really interesting. We don't understand the basis for that. Be very careful as you're taking these people to transplant, use post-transplant Cytoxan, and do very broad mutation testing, especially if your family history has solid tumors, because many of them have second deleterious germline variants. So just very, very briefly at the end, these are the criteria that we use for clinical germline testing. People with multiple cancers, doesn't matter the order, whether they have the heme malignancy first or second, doesn't matter. If they have a heme malignancy at a very young age compared to the average, but still presenting at an average age does not preclude the role of the germline. Obviously, DDX41 is the important issue there. We pay attention to family history, we pay attention to other heme malignancies, and we pay attention to molecular profiling that's happening in the hematopoietic cells. If there's a DNA variant that could be germline, we prioritize that individual for confirmatory germline testing. I think very soon we're going to be testing all heme malignancy patients and their donors. The unrelated donor pool also has these deleterious variants, especially DDX41 and CHEK2, that are relatively common in populations, as we've discussed. There are many examples now of unrelated donors with these deleterious variants being used. I just talked to a family earlier this week that has a deleterious ARTEL1 mutation, a short telomere syndrome, and the patient's son has already donated through the registry to an individual patient. So I think our donor pool is at risk, if you will, and I'm a big proponent of doing this in all donors. This is the algorithm that we use. I've shared this with you before, so I won't belabor it too much. We do use an augmented whole exome platform that can detect single nucleotide variants and copy number variants. Again, those copy number variants are very important. A lot of people ask, well, we're already doing the molecular profiling of our heme malignancy cells. Why can't we just use that for germline? And the most important reason is, let me just get to it here. Hematopoietic tissue undergoes somatic reversion easily. So if you test heme tissue, you can get a false negative. This is very, very common for SAMD9 and D9L. Most of the platforms that are being used for tumor-based sequencing are panel-based, exon-based. They're not designed to find copy number variants. So you're going to miss a lot if you just use a panel-based molecular profiling assay for the germline. The germline testing should be done on non-hematopoietic tissue, which undergoes somatic reversion much less frequently. It has to cover non-coding regions where we know these variants can exist. It has to be able to detect copy number variants. And so if you see something in the hematopoietic tissue, you can't ignore it. But if you don't see anything, there still can be variants there. We have many, many examples of that. Remember, certain alleles in CHEK2 and DDX41 common in the population. They've only been seen as germline variants. So if you see them in the hematopoietic cells, really, really think about the germline. The same can be true of BRCA1 and 2. Those are not typically acquired mutations in hematopoietic tumors. Clonal hematopoiesis, really interesting question. Does it set a molecular clock? If you see it, does it predict hereditary heme malignancy for the future? We don't know the answer. We do know for some disorders like germline RUNX1 and GATA2, clonal hematopoiesis is very common. Less so in DDX41, but again, our whole clock is shifted in DDX41, so that's for the future. We do give very particular surveillance recommendations based on the disorder, looking at the solid organs as well, so really giving comprehensive recommendations. And this is just my summary slide. What have we learned? These germline predispositions to all cancers are common. There's really no difference between solid and liquid cancer syndrome. So consider these in all your cancer patients. Testing is complicated. It's complicated because of the platforms and the types of mutations that exist. You have to interpret your tumor profiling carefully. Think about these disorders as you take someone to transplant. And I think the future is going to be that everyone with cancer is going to have this kind of analysis. I do think our donor pool is at risk. And I think also our future is going to be to really layer this information together like we did for our patient and really give people comprehensive plans. So with that, I will stop and I'm happy to take questions or comments.
Thank you, Dr. Godley, for this superb and excellent presentation. Rather new for us and for many of the researchers in the field. The floor is open for questions. If I may ask you the first question, please. What is the role of epigenetics in the phenotypic manifestation of these germline mutations?
Yeah, it's a great question. We really don't know what the role of epigenetics is, but one thing that we didn't talk about is this observation that we have of anticipation. So as we go from generation to generation in the family tree, we see the heme malignancies happening earlier and earlier. And it is possible that there's an epigenetic mark that sort of marks the generations and contributes to this phenomenon of anticipation. So I think the epigenetics, the epigenetic profiling is something that we still need to look at. We don't fully understand the role.
And traditionally, we've learned, we've always thought that certain drugs are more leukemogenic than others.
Mm-hmm.
Do you think the situation will be different when we look at the germline predisposition?
It's a great question. What's the contribution, the germline and the environment, what you're exposed to, either drugs or radiation through your lifetime? Are there particular sensitivities if you have a germline predisposition? We don't really know the answer to that, but you could imagine that that would be true, that certain germline disorders would render you more sensitive to certain exposures. One example that I think in my mind, there's a big question is for the PARP inhibitors. So right now, the PARP inhibitors have a black box warning for development of heme malignancies. And the idea of that black box warning is that the PARP inhibitor drug itself is causing the heme malignancies. And I think this may be a little unfair to the PARP inhibitor drug, because who's getting the PARP inhibitor? People with germline BRCA1 and 2 mutations. But I just told you they already, by the germline mutation, have a predisposition to the heme malignancy. So is the PARP inhibitor causing the heme malignancy, or is the underlying germline mutation or some combination causing the heme malignancy? So I think just that black box warning gives you the idea that it is the drug itself that's causing the problem. And I'm not so sure about that. So we just need a lot more studies to tease that apart. It's a great question.
Any more questions, comments? Well, if there are no more comments, thank you very much again for your excellent presentation. We hope to see you maybe in a couple of years' time in Amman. Hopefully, the travel restrictions would have been lifted, and I'm sure everybody will enjoy seeing you in Amman. If you happen to drop by anytime in between, please let us know so we can.
I will do that. Thank you again for having me. Take care, everybody.
Bye-bye. تفضل. الفلور الرائع. Thank you, Dr. اسلم اسلم. يلا تفضل تفضل.
Okay. Assalamu alaikum. It gives me a great deal of pleasure to introduce our distinguishable speaker for today, Professor Ismail Al-Alami. Professor Al-Alami, he is a professor of hematology and the head of hematology department at Tenon University Hospital, Sorbonne University in Paris. His interest is in the field of thrombosis and antithrombotic agents. His research interests include improving therapeutic strategies, identifying new biomarkers, and application of novel diagnostic techniques to the clinic. He is the head, advisor, general secretary, and member of many national and international institutions working in the field of thrombosis and hemostasis. He was involved in many guidelines reductions. Professor Al-Alami has presented over 300 symposia and lectures at international congresses and has written over 200 articles and collaborated on several books on hemostasis and thrombosis. So it's my pleasure to introduce Professor Al-Alami. He will be talking today about heparin-induced thrombocytopenia. Dr. Al-Alami.
No, I think you unmute.
I think.
Unmute yourself.
Please unmute yourself.
Okay, that's fine. Okay, thank you so much. Do you hear me now?
Yes. Yes.
Okay, I thank you for this kind introduction, and I'm really honored and grateful to the organizing committee for their kind invitation, allowing me to share with you this dramatic and paradoxical complication of heparin use, which is heparin-induced thrombocytopenia. These are my disclosures as a thrombologist. So the HIT acronyms means heparin-induced trouble. Its hunting is intriguing and tricky.
The voice is not good, not clear for us.
It's not clear for you. Maybe you want me to make the microphone. Better now.
Okay.
Is it better now?
Yes. Yeah.
Okay. Sorry for that. So, as I mentioned, that again, the HIT acronym means heparin-induced trouble because its hunting is intriguing and tricky, and also it's hazy, insidious, and terrible.
what's the HIT patient profile? The HIT incidence is between 0.1% and 1% in patients receiving heparin, and sometimes, in fact, is more than 5%. You see that unfractionated heparin generates 5 to 10 folds more HIT than low molecular heparin. The smaller, the greater. In fact, the patients have often age over 50 years, and because they are related to previous heparin exposure, and mainly female gender, and sometimes obesity or overweight are linked to a more severe HIT. So we must pay attention to the context, to the comorbidities with some patient having autoimmune diseases, sepsis, or previous VTE. And HIT incidence is more frequently associated to a surgical setting than a medical setting. And the main domain is cardiac surgery, of course, but also ECMO or orthopedic surgery. But you must pay attention to the medical setting because the risk is not nil, and the risk is increased in case of previous heparin exposure. So HIT is associated with thrombosis, which is linked to a severe drop of platelet count, a high antibody levels, and a heightened, say, platelet activation, which is observed in the functional assays. In this US population-based study, you see that the HIT incidence is around 1 per 1,500. So you can imagine there are some missed cases, but thrombosis is reported in 30% of cases. You see that it's much more frequent than bleeding, and the mortality and amputations are disproportionately high in HIT patients. So there is a real need for more effective intervention in both diagnosis, prevention, and treatment approaches in HIT. So who is concerned by HIT? In this ASH recommendation, you see that they underline the intermediate risk patient, medical or obstetrical patient receiving unfractionated heparin, or surgical patient receiving low molecular heparin in case of major surgery or major trauma. The high-risk patients are in fact the same patient receiving unfractionated heparin, whatever way or post-operative, but again, if they received before unfractionated heparin, we must pay attention to the patient receiving after low molecular heparin or even from the Parinux. So again, the therapeutic context is very important. You know the Fantastic Four heroes. Now keep in mind the dramatic four HIT. 4 pivotal actors. Heparin, of course, this polysulfated and negatively charged polysaccharide, and its natural inhibitor, platelet factor 4. The IgGs, antibodies leading the immune response, and the CD32, which is a membrane receptor allowing multi-cell activation. Because heparin, with its negative charge, warps around the platelet factor 4, which is positively charged, and induce its structural modification with neoantigens exposure, promoting antibodies. So there is a real structure-activity relationship because it's requiring oligosaccharides with a long chain, sulfated groups for a negative charge, leading to platelet activation after HIT antibody occurrence. In fact, these circulating ultra-large immune complexes engage a multicellular activation. Platelets are engaged. Platelets with, of course, platelet aggregation, but also procoagulant microparticle release. The monocyte exposure of tissue factor triggers coagulation cascade and thrombin generation. The neutrophils are also involved with NETs, neutrophil extracellular traps, and the netosis supporting thrombosis growth. And the last but not the least, the endothelial activation of von Willebrand factor release is promoting a more adhesive vascular wall like a fly paper. So HIT means heparin-induced thrombosis with this multifocal thrombin generation, the vascular compartment. So you can imagine that HIT is a heparin-induced tsunami with a paradoxical prothrombotic storm in that vascular compartment. So keep in mind this picture, understand that incredible issue, heparin, anticoagulant treatment, inducing like napalm, an incendiary life-threatening complication. In fact, HIT, it's a contextualized, let's say, have a contextualized incidence because patients receiving heparin develop antibodies, but a smaller proportion of these antibodies are able to activate platelets. And again, a small proportion of them will develop thrombocytopenia, half of them will develop thrombosis. So considering cardiac surgery with unfractionated heparin, you see that seroconversion is quite important, 50% of the patient, but only 2% will develop thrombocytopenia and half of them will have thrombosis. In orthopedic surgery with unfractionated heparin, the features are quite high also. It's much more frequent than low-molecular heparin, found less. And in medicine, so whatever unfractionated heparin or low-molecular heparin, pay attention that the risk is not nil and may be increased due to the previous heparin exposure. Mass index strongly impacts incidence of HIT, and you see that the greater is the BMI, the higher is the HIT risk, and the higher is the thrombotic risk with such heparin-induced thrombocytopenia. And that is due to the adipocytokines, which are leading to a pro-inflammatory profile and the immune modulating processes in these, let's say, patients. It's about the, for example, the HIT prevalence in essential thrombocytopenia in patient carrying the JAK2 mutation. You see that in this patient receiving mainly low-molecular heparin, that the incidence of thrombosis is much higher in patient having JAK2 mutation compared to control with no JAK2 mutation. In fact, we know that the risk of thrombosis is higher in JAK2 mutation patients because they have already a hypercoagulable profile with an increase of platelet reactivity, von Willebrand factor release, and also thrombomodulin exposure. And tissue factor, of course, exposure on the vascular cells. And if you are at high risk for VTE, if you are immobilized with an inflammatory profile and developing HIT, the risk of thrombosis is much higher and the HIT will be more aggressive. See that there is a link between the HIT and the autoimmune disease, because in this patient with such autoimmune profile, the incidence is significantly increased compared to control group. Again, in case of sepsis, the risk also increased because sepsis makes patients more susceptible to HIT occurrence due to this inflammatory predisposition. Based on the clinical, let's say, approach of HIT, you may have skin reactions with heparin injections, and you have, for example, here, maculopapular erythema with pruritic rash observed mainly in women with an increased BMI. This is a late step for hypersensitivity. In fact, if you have more inflammatory, let's say, injection sites with indurated erythema, with a diffuse exanthema with purpuric, extensive, painful reaction, leading to such necrotic reaction that is due to many microthrombosis in the dermal vessels. Because in fact, heparin-induced thrombosis is the reality. The prevalence of thrombosis at the time of diagnosis is very high. You see here in this table. But we observe more venous than arterial event in that clinical setting. However, these thrombotic episodes are associated with a worse prognosis, whether functional with amputation or fatal with death. Arterial thrombosis is related to white thrombus syndrome, which is famous, but we know that these clots are made of fibrin and platelets, and they are, let's say, in healthy arteries. But the thrombosis are at multiple sites. You see here in the celiac artery or in the renal artery with here a renal infarct. We have more often venous complications with here a thrombotic extension with a real clinical resistance despite heparin treatment. But pay attention that we have in more than 50% of cases asymptomatic new venous thrombosis, whatever in the legs or in the chest with extensive and proximal VTE, PE. You may observe also rivedo reticularis, and you have to evaluate that because in case of late diagnosis, you got necrosis requiring distal amputation. The last but not the least, there is a very major complication, which is a bilateral adrenal hemorrhagic infarction, which is similar to the one observed in another human disease, which is the catastrophic antiphospholipid syndrome, the CAPS. How to diagnose HITs? In fact, you must first of all confirm the real relative thrombocytopenia, which is often moderate at the beginning. But there is no gold standard criteria, and you must build the diagnosis of HIT based on a retrospective analysis based on both clinical and biological grounds to build that HIT likelihood, because there is no certainty. You have to get probability low, high of such, let's say, diagnosis. So that's why in the recommendation, the platelet monitoring is a key for HIT suspicion. And of course, it's not proposed to monitor platelet count in patients having a low risk of HIT. But in patients with intermediate or high risk of HIT, it's mandatory to monitor platelets count 2 or 3 times a week during at least 1 month if heparin treatment is, of course, on board. In case of suspicion, it's again proposed to define the clinical probability by scoring and to check for the antibodies by testing. The analysis of the platelet curve and the platelet count evolution is fundamental. You see here in a blue curve, after orthopedic surgery, for example, a hip surgery, you see that compared to the classical evolution in the bar curve here, the patients had a decrease of platelet count after surgery, and that is due to bleeding, hemodulution, or consumption of the platelets. But thereafter, the platelet count raises, reaching at day 5 the level he got before surgery. After that, after day 5, you observe that there is a sudden increase, rapid, with a broken curve here of the platelet count. So the broken curve, the rapid platelet fall, is not classical and unexpected, so hit must be suspected. In the cardiopulmonary bypass surgery, you see that the platelet kinetic got also this biphasic profile with initial, let's say, fall after the procedure, an increase due to the inflammatory syndrome, and a second here, broken curve and the fall of platelet count. And here you have 80% of the hit patient. But you have also another monophasic profile with a persistence or aggravation of the platelet fall with no platelet recovery. And here you have the 20% of hit cases. So, concerning platelet count monitoring for hit diagnosis, I propose to give 5 because you have to check the platelets before day 5, at day 5, and after day 5 in case of heparin treatment to assess the risk of such broken curve and, of course, platelet count decrease and hit suspicion. And there is another, let's say, advantage for monitoring platelet count based on the curve. It's the platelet count recovery and increase after the heparin substitution, reinforcing the hit diagnosis. This remontada is a very, very good signal reinforcing the hit diagnosis in your patient. But anyway, at that time, we know that there are some computerized scoring systems based only on the thrombocytopenia and that timing to increase the accuracy to identify hit suspected patients. The scoring is based on the 40 score, which is well known and famous since at least 20 years, and it's based on the importance of the thrombocytopenia, the timing of platelet count fall, and the existence of thrombosis or any skin necrosis, and of course the absence or presence of other causes of thrombocytopenia. So the higher is the score and the greater is the hit probability. But the inter-observer reliability is quite bad depending on the physician experience. So there are many discrepancies regarding the timing of thrombocytopenia, regarding the evaluation of the other causes of thrombocytopenia. So you must be trained and be aware, and the 40 score is not easy to perform. Other tools are proposed, other scores are proposed, like the HEP score, for example, and they are also computerized risk scoring to try to guide the physicians. But we need education to increase the rate of appropriateness of that testing and scoring. You see, for ICU patients, that the 40 scores has been modified with more detailed items concerning the degree of thrombocytopenia here and the timeline of platelet count decrease. And this team has, let's say, encouraged the colleagues to do that in ICU setting because we think often about it without, let's say, establishing hit diagnosis. So it's important again to evaluate in an accurate way in clinical practice hits in such ICU setting. In the cardiac pulmonary bypass, you see that the French team has proposed, again, a score dedicated to that clinical, let's say, context based on the scoring with the biphasic pattern of the platelet curve or a monophasic pattern of the platelet curve based on the time from CBC to the platelet drop and the, let's say, procedure duration. So keep in mind again that the p-value for hit diagnosis is for profile, the clinical context, P for physical examination, skin, pain, inflammation, for platelets, the kinetics and platelet curve is important to observe, and P for probability, the 40 score, adapted ICU, CBP setting. So, hit diagnosis is be based on a combined triad with a clinical audit associated to both functional and immunological assays. So you must hit the hit in 3 dimensions: clinical, functional, immunological. Hit diagnosis strategy is based on 2 types of assays: the immunoassays, and we know that they got a high sensitivity and a poor specificity with a high false positive, let's say, results, and the functional assays, which are quite difficult and technically, let's say, associated to reference labs with expert, let's say, technicians, and they are not standardized. So immunological assays are many tests with different thresholds. However, they are able to detect antibodies against beta factor 4 modified heparin. They got a very good negative predictive value to rule out hit in case of low probability and negative assay. And some rapid tests are proposed, such as the lateral flow immunoassay, but you see that sometimes their interpretation can be equivocal with a weak positive, let's say, results, and it's not easy to conclude. But the ELISA threshold is informative, and you see that this optical density, if it's increased over 1, probability of hit is greater, and the risk of thrombosis is higher with more aggressive, more active antibodies. Functional assays are also quite different, again, linked to expert labs. However, they're able to identify antibodies promoting platelet activation in presence of heparin. Their predictive positive value is good. But in fact, again, they are not standardized. You have to choose your best partner. So in our group, we built an algorithm for hit diagnosis based on the clinical suspicion of hit, the scoring, the antibody detection with the optical density value over 1, less than 1, and of course the functional test, positive or negative, supporting hit diagnosis or not. Other groups are also proposing other tests such as HIPAA tests and other ELISA to propose different cutoffs. And you see that some cutoffs are associated with a very good predictive positive value, very good negative predictive value. But anyway, you must combine that to be able to define hit diagnosis and to, let's say, increase such probability. And recently, a machine learning model has been proposed with 6 predictor variables: immunoassay result, the platelet nadir, the unfractionated heparin use, inflammation, profile, timing of thrombocytopenia, and the other causes of thrombocytopenia. And you see that here you have the address to get this user-friendly machine learning algorithm for HIT diagnosis. And this team has observed with such a Toradi HIT algorithm, there are much less false negative and false positive results compared to the current classical algorithm. So optimize their strategy. Anyway, thinking HIT is acting FLIT, and you must apply the 4T's 4S rules: suspicion, suspension, substitution, and survey. If you suspect HIT, you must stop heparin and substitute heparin by a non-heparin drug, and to survey the platelet recovery and the patient evolution. That the recommendations are to inhibit as quickly as possible the thrombin generation storm using a therapeutic intensity dosing and never a prophylactic intensity dosing in such suspected HIT patient, whatever, symptomatic or not. So, after the dramatic 4, it's the fifth element to control that, the non-heparin substitution. For that, the recommendations are also multiple. They suggest argatroban, danaparoid, fondaparinux, or DOACs. In fact, you see that the use of that drugs, danaparoid is a low molecular weight heparinoid. The argatroban is a L-arginine derivative antithrombin, and the fondaparinux is an indirect anti-10A drug, which is synthetic pentasaccharide. And danaparoid is an indirect anti-10A and anti-2A drug. And you see that we got abacus for the danaparoid, but there is no abacus for argatroban and no abacus for fondaparinux. The most, let's say, greater experience is with the danaparoid, and in France we are using mainly danaparoid. And the story is less established with argatroban, and of course, fondaparinux is off-label. But anyway, pregnancy, pediatrics, intensive care units, they got experience with such drugs, but of course, argatroban is contraindicated in pregnancy, such as fondaparinux. And the renal organ is a key because in case of renal impairment, you must adjust treatment. Danaparoid, for example, use bolus followed by an IV infusion to get an anti-10A activity between 0.5 to 0.8 unit per ml. That's the rule. But sometimes, rarely, but sometimes we got cross-reactivity, and that it's suspected in case of non-platelet recovery after 2 or 3 days. And you must suspect such occurrence in case of clinical resistance. Regarding argatroban, you see that we use very low dose in patients depending on different comorbidities, but in fact, we start in France with 0.5 and not with 2 microgram per kilo per minute as required in SMPC of the drug. And the monitoring is not based on APTT as required in SMPC because it's not reliable. In fact, you see, in that case, this woman, 60 years old, with a real hit, dramatic hit, osteopenia and severe thrombosis, despite this substitution, after 10 days, we observe a gangrene of the 2 upper arms, leading to amputation, despite an APTT between 2 and 3 as required, because, in fact, APTT, the PT, because APTT prolongation is not related to argatroban activity, but more to the comorbidities and to the plasma modification of this patient. So if you want to use Agatroban, you must again follow rules, starting with low dose and targeting an activity anti-2A between 0.5 to 1.5 microgram per ml. And again, in case of renal impairment, reduce the dose of Agatroban, because in fact, in that case, the liver is also suffering. What about Fondaparinux? You see that Fondaparinux is used off-label in many countries, but in fact, the experience with that here in Canada was not so good regarding the clinical benefit, with an increase of thrombosis and also an increase of major bleeding, 20% in such patients suspected of HIT. And it's related to the renal function, which is impaired in such patients, and there is no again, abacus to adapt the anti-TNA interpretation in clinical practice. About DOACs. DOACs means doubtful oral anticoagulation because the quality of evidence remains weak, only based on the retrospective cohort studies with very small numbers. And again, the available studies do not support the use of DOACs regarding the acute situation of such frail patients in the majority of cases. However, after the acute phase you see here, after the recovery of the platelet count using the non-heparin control strategy, we can relay the drug by here apixaban, for example, or rivaroxaban, for example, to maintain the antithrombotic shield logically and practically in this patient, but after the acute phase. So you see that the recommendations were, in case of moderate or severe hepatic dysfunction, avoid Agatroban. Fondaparinux and DOACs must be used in clinically stable patients and not patients at high risk of bleeding or unstable patients. So the choice of the non-heparin treatment must be related to the drug availability, to the patient's profile and comorbidities, and the experience of the clinician. So HIT means hematologist intensivist team. We must build a multidisciplinary task force, must inform all the, let's say, people around patients, hematologists as heparin monitoring, practitioners as heparin prescriptors, nurses as heparin injectors, and pharmacists as heparin providers, because we must be, let's say, aware and reactive in case of any, let's say, side effect regarding heparin use. To conclude, HIT means heparin-induced thrombocytopenia, but the risk is heparin-initiated thrombosis. We must, again, develop such hunting, formative testing. Of course, it means hypercoagulant immediate treatment. Thank you for your attention. The right drug, the right patient at the right moment.
I think we have time for one or two questions or any comment from anyone of Dr. Abdullah.
Thank you, Professor Alami, for this excellent presentation. There are a few issues which are not clear in a developing country such as Jordan. First of all, the testing for HIT is not that simple, since the non-sensitivity of platelet factor 4 testing we do not have serotonin release assays because they use, as you are aware, radiation, radioactive material, which we don't have enough protection for it. And thirdly, regarding the treatment, fondaparinux in this region is quite popular as off-label treatment when we suspect strongly HIT. I just want your comments on these issues, please.
I agree that in case of if you have nothing, let's say optimal, you must use what you have and to be logical. I agree that the use of fondaparinux is simple and again is very attractive because it's synthetic and it's an antithrombotic drug. However, of course, there is a price to pay regarding the safety with such drug. But if you haven't any other option, you must use it. I was contacted by an Algerian colleague with a pregnant woman receiving heparin and developing a HIT. And of course, we used fondaparinux in such women, despite the contraindication of fondaparinux in pregnancy and no clear data regarding the optimization. But it was the sole antithrombotic, non-harming, non-heparinic, and able to, let's say, control the thrombin generation in such women. So we use it. So again, I agree with you. We are doctors and we must use the tools we have. And practically using fondaparinux, if you have no other option, I agree with you, is the best option for doing nothing. Okay, it's the best option, of course. The DOACs also, but again, in such situation with very frail patients, the price to pay is regarding safety. But anyway, we are facing a major enemy, which is thrombosis, and we have no other option regarding the availability of the drugs we have. Now, regarding the diagnosis, if it's not possible to have the serotonin release assay, as you mentioned, radioactive approach, we developed the HEMEA test, which is a whole blood aggregometric approach with which is really easy and based on an impedance metric, and it's standardized. And with the ISTH, 2 years ago, we validate that, and I recommend you to use it because I'm sure because it's a semi-automatic. It's very, let's say, easier to use it as a platelet reactivity test. And we do it here in Paris, in my group, with an answer in less than 1 hour, with a very, very good positive predictive value. And again, if you are following the procedure, a very, very appropriate response regarding HIT diagnosis. So we can help you to improve your availability, establish HIT diagnosis, and to try to accompany you to optimize the HIT management of your patients, even despite not having all the drugs optimal possible.
I think we have another question from Dr. Najat.
Thank you, Dr. Ismail, for your informative lecture. Do you recommend to avoid using enoxaparin in a patient who is suspected to have IgG4 disease or IgG secretory myeloma?
No, not at all. But in fact, I engage you to monitor platelets, of course, in these patients in a regular way, mainly at the beginning, because in fact, as you see, the risk is in the first month. The majority of the HIT issues occurs in the first month. So pay attention in such sensitive patients in the first month of the enoxaparin use, for sure. But after that, keep it under enoxaparin and be less anxious after 1 month.
The problem actually with this particular patient, within 48 hours, he developed thromboembolic, which was severe.
Okay.
And,
but in fact, if he develops thrombosis, in fact, it's not always related to HIT, because thrombosis in such patients, it's the risk is increased related to myeloma and to the resistance to chemo, etc., and to the other antitumoral drugs. But in fact, if you observe a thrombocytopenia associated to thrombosis, the first diagnosis is HIT, and in that situation, you use fondaparinux, as I heard from the previous expert. Now, regarding the thrombotic occurrence in myeloma patients, in the first days of enoxaparin, without such broken curve, such decrease of platelets count, you can maintain enoxaparin at therapeutic level, but control that platelets are still in the regular level.
Okay, thank you. But that patient, really, the platelets start to drop.
Drop what level? Because when you have thrombosis, you consume platelets, and you have a decrease of, let's say, 20%. 20%, it's not 50. So keep in mind that the level, because you got thrombosis. If you got thrombosis, you consume platelets, but you consume platelets at a certain level. So it's generally less than 20%. If you are above 20%, yes, you have to be anxious regarding HIT occurrence.
Thank you, I appreciate it.
Thank you again, Dr. Al-Alami, and I think this is the last lecture today. Dr. Abdullah.
Shukran.
وآخر دعوانا أن الحمد لله رب العالمين. Thank you, my friends, colleagues, for attending and following on this extensive conference, which has been going for the last 3 days. And I see that large number of you are still following our excellent speakers. We did our best to select a spectrum of topics and superb speakers internationally and regionally, covering all aspects of hematological malignancies, benign hematological disorders, immune check inhibitors, certain solid tumors, specifically lung cancer, breast cancer, and obviously some of the major hematological malignancies, including non-Hodgkin lymphomas, acute myeloid leukemias, chronic myeloid leukemias, as well as the benign hematology disorders, which we did not forget, namely sickle cell and sickle cell anemia, the thrombosis, the bleeding disorders. This has been an entertaining and really quite up-to-date review of all these topics. As you know, the society has yearly conferences, and we alternate. 1 year we make it dominantly solid tumors, and the other year we make it dominantly hematological disorders. So next year it will be mostly solid tumors. And as you can see, this year we chose to have an online virtual conference because we do have lots of travel restrictions, and many airports are being closed or shut down because of workers' protestation and because of the issues in the wars and so forth. The earthquake even made things worse. So I'm glad we chose to have it as an online conference. I know many of you would love to meet, to see each other, chat with each other. However, all our moderators came to this room and we met every single one of them, and they met each other, and this is really good. But we would love to meet you all, those who did not attend the moderator panel. Friends, this is the Society of Hematology is to bring up to date the information for our doctors, because eventually it's going to reflect to the good well-being of our patients, reflects to a better care, to improve our patients, improve the whole philosophy of treatment and diagnosis. I thank you all, and I wish you a very happy weekend, and goodbye. Thank you.
هذا كله مع السلامة. يا سيدي الله يعطيك العافية. والله